case to demonstrate the anatomy, and I will also explain to you the patterns of spread and some salient imaging findings. Okay, so how do we understand anatomy of peritoneal cavity in a very simplified manner? So we can imagine the peritoneal cavity to be a balloon, and imagine a fist is indenting the balloon, and the balloon is the peritoneal cavity, and the part that is being indented by the different organs from different sides forms the visceral peritoneum. And the parietal peritoneum is the outer part which is against the abdominal wall. So we have different organs kind of indenting the peritoneal cavity from different sides, and so the peritoneum just indents like that, and whatever covers the organ is the visceral peritoneum, that's the visceral peritoneum, and whatever is on the outer aspect is the peritoneal, is the parietal peritoneum, which is against the abdominal wall. So these organs that are indenting the peritoneal cavity are going to get fully enveloped by visceral peritoneum, and these organs are interconnected by two layers of visceral peritoneum, which is nothing but the different ligaments. So to put it shortly, in the embryo, what happens is that's the coelomic cavity, and that's the gastric bubble, and the spinal notochord is posterior, and that's the ventral mesogastrium and the dorsal mesogastrium, and the dorsal mesogastrium and the ventral mesogastrium are connected like that, and it envelopes the gastric bubble on either sides. And the solid organs that form within the ventral mesogastrium form the liver, and it moves to the right side, and liver is in the right side enveloped by visceral peritoneum. And from the dorsal mesogastrium forms the spleen and the pancreas, and that moves to the left, and it's enveloped by the visceral peritoneum. And these organs are interconnected, as you can see on either side. That becomes the lesser omentum, the ventral mesogastrium, and the dorsal mesogastrium becomes the greater omentum and the other ligaments. Not only that, the aorta is going to be here, right? So when the vessels have to supply the organs, they have to go through the dorsal mesogastrium in that fashion. So the vessels have to go through the dorsal mesogastrium and supply the different organs. So what are we talking about? The organs are all enveloped by visceral peritoneum, and the dorsal mesogastrium is going to carry the blood supply, the nerve supply, and the lymphatics to the organs. And these vascular and neural supply are going to be sitting between the organ and the visceral peritoneum. So that space which contains the neurovascular bundle and the lymphatics is nothing but the subperitoneal space. And the cavity that is formed between the visceral and the parietal peritoneum is the peritoneal cavity. And the ligaments that connect the different organs that are suspended in the peritoneal cavity is the different named ligaments. And the greater and the lesser omentum are the largest of all these ligaments. And peritoneal cavity normally has no fluid, nothing in it, and so we normally don't see it on imaging. But when we begin to see peritoneum, it is always abnormal. And peritoneum is only perceived when the peritoneal cavity has either fluid, blood, or lymphatic contents within the peritoneal cavity. Otherwise, normally we don't see the cavity, and the peritoneal cavity indents itself into in between various organs, and that is what gives you the named recesses that we read in our textbooks. And the ligaments are nothing but these folded 2 layers of visceral peritoneum, and those again have different names. So that is in short about the basis of the anatomy. To put it shortly, there are 2 parallel systems that we are seeing in the peritoneal cavity. One is the peritoneal cavity itself, which is not seen normally unless it is distended by fluid or lymph or blood, and the subperitoneal space, which carries the lymphovascular and the neural supply the different organs. So the disease, as you can see, can spread either through the subperitoneal space, which carries all these vessels. It means the disease that starts in a particular organ can spread to multiple organs within the abdominal cavity through the subperitoneal space, which is via either the neurovascular bundle or through the ligaments that connect all the organs together. So that is one pathway of disease spread. And the second pathway of disease spread is when the visceral peritoneum is broken, for example, in trauma or inflammatory or neoplastic pathology. When the visceral peritoneum is breached, then what happens is the disease spreads from the organ into the peritoneal cavity, into the parietal peritoneum. So that is the 2 types of spread. One is a subperitoneal spread, which is going along the neurovascular bundle and the lymphatics. And the second type of spread of disease is transperitoneal spread, where the disease infiltrates the visceral peritoneum, then enters the cavity, and then spreads into the entire peritoneal cavity. So that's the 2 pathways of disease spread. So using this particular example of an ovarian cancer in this female patient, I'm going to take you through the anatomy of the peritoneal cavity as it's relevant for a radiologist. So the anatomy of peritoneal cavity is roughly divided into 2 major compartments, that is divided by the transverse colon. And the part of the peritoneal cavity that is superior to the transverse colon is a supramesocolic compartment, and the part of the peritoneal cavity that is below the transverse colon is the inframesocolic compartment. And the supramesocolic compartment is again divided into right and the left, and the part that divides it is the falciform ligament that connects the liver to the anterior diaphragm, anterior portion of the diaphragm. And this kind of limits the spread of fluid from the right and the left. But if there is massive ascites, it can go below the falciform ligament and then enter the opposite compartment. And as you can see in this image, the fluid comes till the right lateral portion. This triangular portion is the triangular ligament or the coronary ligament, and it stops here, and the fluid does not seep all along the segment 7 of the liver. And this part of the liver, which is in direct contact with the diaphragm, is the bare area of the liver, which actually is contiguous with the retroperitoneum. So only when there is a retroperitoneal pathology, you will have something that is separating the diaphragm and the liver. And alternatively, if you have a patient with trauma and there is a laceration to segment 7, which is abutting the bare area of the, which is abutting the diaphragm and is in the bare area of the liver, you can have retroperitoneal hematoma, which is going into the perinephric space. Okay? And in this example, you can see this nodular soft tissue in the right coronary ligament, and that is a nodular deposit in the right subphrenic space. So the right subphrenic space is limited medially by the falciform ligament, posteriorly and laterally by the right coronary ligament, and inferiorly it is continuous. You can track this fluid into the hepatorenal rhesus, that is the Morrison's pouch. When I trace this fluid medially, where I see it leading is into the right subhepatic space. I track this fluid more medially. There is the space between the portal vein and the IVC that is the foramen of Winslow, and through the foramen of Winslow, superiorly it connects into the lesser omentum and the lesser sac. The superiormost extent of the lesser sac is around the caudate lobe, and that is the superior recess of the lesser sac, and medially it is limited by the left gastric vessels, and the inferior recess of the lesser sac is between the stomach and the pancreas, and that is the fluid in the inferior recess of the lesser sac. And if you look at this image, you can see this fat that is connecting fat with some nodules along the greater curvature of the stomach, and that's the greater omentum, and these nodules are located in the greater omentum. And there is another fat containing structure that is going to the splenic hilum, and that is the gastrosplenic ligament. And the left subphrenic space is limited inferiorly by that ligament, and superiorly it surrounds the spleen. And again, in the medial aspect of the spleen, there is no fluid, and that is the bare area of the spleen. And similarly, that is the bare area of the stomach, which has fat, and the fluid does not go there. So the bare area of the stomach and the spleen can also be other alternative pathways for retroperitoneal pathology. And as we come down, we can, below the level of the transverse colon is the inframesocolic compartment, which is the right paracolic gutter and the left paracolic gutter, and the fluid goes all the way to the pelvis, which is limited inferiorly by the bladder. So that's the bladder, which is subtly more hypodense than the fluid in this patient, which is exudative ascites in this patient because of the malignant ascites. And you can see that the limit of the peritoneal cavity is along the sides of the bladder, and then it dips down into the pouch of Douglas in this female patient, which is nothing but the recto-uterine pouch and the utero-vesical pouch of Douglas. So that's the vesico-uterine pouch of POD on both sides, and that's the recto-uterine pouch of POD in this female patient. In a female patient, because the fimbria of the fallopian tube are on either sides of the broad ligament, through the fimbria, the female genital tract is connected to the peritoneal cavity. Okay? And so in a female patient, through the fimbria and the uterine cavity and the vagina, there is extraperitoneal connection in a female patient. But in a male patient, the peritoneal cavity is a closed space. Okay? So that is why in a patient with ovarian cancer, you get such rapid peritoneal carcinomatosis. Okay. So in this patient, we can see nodules in the pouch of Douglas, and we are also seeing disease on either sides of the pelvis, either sides of the uterus filling the pelvis. And there is nodular thickening of the left paracolic gutter, the peritoneal lining along the left paracolic gutter. And as we go to the right side, there's another nodule in the right paracolic gutter. And I already showed you the omental caking, and that is also greater omentum, which is anterior. So where is the extent of greater omentum? Greater omentum extends from the greater curvature of the stomach. It drapes the entire small bowel loops. It goes all the way down, and it folds itself and comes back and inserts itself onto the anterior superior aspect of the transverse colon. So it is like a curtain that drapes from the lateral aspect of the greater curvature of the stomach, comes down, folds itself, and inserts back into the transverse colon. So now what is left is the mesentery. So what is a mesentery? I'll show you that on the sagittal image. On the sagittal image, as I told you, the blood supply to the intra-abdominal organs is going to be from the aorta. And along with this blood supply is a sheet of fat, which carries the lymphatics and the veins. And this is all covered by the visceral peritoneum. And so there are 3 points at which the blood vessels enter the gut, for the hindgut, foregut, and the midgut. It is through transverse mesocolon, that is, which carries the middle colic vessels, and then the superior mesenteric vessels, that is the root of the mesentery. As you can see, this fat-containing structure contiguous with the small bowel. And the third thing is this fat-containing structure, which is the sigmoid mesocolon, which has the inferior mesenteric vessels. So that's the three mesentery: the sigmoid mesocolon, the root of mesentery, and the transverse mesocolon. How does that look on the axial sections? On the axial sections, when we look at it, the transverse colon is going to be right anterior to the pancreas and these vessels, the middle vessels. The constant vessel of the transverse mesocolon is this vein, that is the gastrocolic trunk. Okay? And then when we come down, we will see that that's the root of mesentery, the superior mesenteric artery origin, and that's the root of mesentery, which is close to the DJ flexure. That's the third part of duodenum, and that's the DJ flexure in this patient. So that's the origin of the root of mesentery. As we trace this mesentery in this patient with a lot of fluid, you will be able to see the entire anatomy of the mesentery going all the way to the ileocecal junction. So that's the extent of the root of mesentery. And thirdly, the sigmoid mesentery, which is an inverted triangular shaped structure, and that's the sigmoid mesentery carrying its vessels, and that's the sigmoid colon, and it is usually at the level of the common iliac vessel bifurcation. So that's the sigmoid mesentery, and which is a common site for nodular disease in a CA ovary patient, and you can see this nodule in the sigmoid mesocolon. Okay, so that's the sigmoid mesocolon. So I want to demonstrate to you another case to show you very vividly the difference between the visceral and the parietal peritoneum in this example with in this patient with tuberculous peritonitis or the wet peritonitis. So what you're seeing, what you saw in the previous patient is nodular disease in the peritoneal cavity, and what you're seeing here is diffuse, smooth, enhancing thickening of the peritoneum, both the parietal and the visceral peritoneum. And this is a classic example of inflammatory peritonitis. It can be tuberculous, it can be any other infective inflammatory peritonitis. So this is an example of tuberculosis, and here you can see how the parietal peritoneum and the visceral peritoneum is thickened, and the visceral peritoneum envelops the small bowel serosa. So that's an example of visceral peritoneal thickening, which is very obvious in this example. I want to leave last with this third case, which is that of a patient with necrotizing pancreatitis. And pancreatitis is a disease that is inflammatory, right? So it does not respect boundaries, and so it transgresses into the intraperitoneal and the intraperitoneal compartment. And what you're seeing here is a necrotic collection, which is a replacement of the body of pancreas in this patient, and there is a very large walled-off necrosis containing air pockets, which is an infected walled-off necrosis in this patient. Where is it located? Any postgraduates want to say? What is the compartment where this collection is located? It is between the stomach and the pancreas, so it is located in the lesser sac. It is located in the inferior recess of the lesser sac. So I'm going to track this superiorly, and you will see that's the left gastric vessel. And then there is this collection which is compressing and indenting the caudate lobe. That is the component in the superior recess of the lesser sac, and it goes anteriorly into the lesser omentum. Okay? And also that is the extent of the walled-off necrosis in this patient. But this patient also has generalized ascites, where you can see this fluid in the right subphrenic space limited by the falciform ligament. There is also left subphrenic space fluid, and as we go down, there is a lot of ascites, which is filling the peritoneal cavity. And as we come down, all this fat belongs to the root of mesentery. It belongs to the mesentery. And you can see how this fluid is freely floating. This small bowel loops are freely floating in the peritoneal cavity in this ascites, which is more transudative in a setting of acute pancreatitis, whereas I go back to the first case where you have a patient with exudative ascites and the bowel loops are all little tethered and they're more pulled more towards itself. And this kind of exudative ascites is even more obvious in this case with tuberculosis, where all the small bowel loops are pulled and clumped together in the center and the bowel loops are not floating freely. And that is a typical example of a exudative ascites. So I just want to leave these thoughts with you that the subperitoneal space is nothing but the space that contains the lymphovascular and the neural structures that supply the different organs. And all the organs in the abdominal cavity are suspended by the visceral peritoneum, and the visceral peritoneum makes up the ligaments and the omentum, and the parietal peritoneum is along the abdominal cavity, and the peritoneal cavity is between the visceral and the parietal peritoneum, and it's only seen when it's distended by fluid or blood or lymphatic collection. And thank you very much. Yeah.
Thank you so much, Madam, for that very well-structured presentation. I now call upon Dr. S.S.G. Mohapatra to please come and felicitate Madam on stage. We now have the Secretary of ICRI, Dr. Natasha Gupta ma'am. She is currently working as a consultant radiologist at CNBC Pediatric Hospital and UCMS and GTB Hospital, Delhi. Dr. Gupta has received several state and national level IRIA awards. Her strong commitment to resident education and radiological excellence is reflected in her publications spanning book chapters and several indexed articles. I request ma'am to join us on stage and begin her session on imaging of congenital gastrointestinal anomalies.
Thank you so much for the kind introduction. And I would begin by congratulating the team of the Odisha chapter under the great leadership of Dr. M.V.K. Rao sir, Dr. Prafulla Dash sir, and Mohapatra sir, the entire team of Odisha. My congratulations for organizing such a wonderful IREP, for ensuring such great attendance from residents. So we express our thanks and gratitude from the IRIA and the ICRI to you for such wonderful organization. And thank you so much to the organizers for giving me this wonderful platform here. So I will be speaking on imaging of congenital GI anomalies, and I have modified this into a case-based review since it's a vast topic. And I will be showing you some images and cases that we frequently encounter in practice and which are also important for the residents' exam point of view. Okay, so I really expect this to be an interactive kind of session rather than a one-way lecture. Okay? Okay from the residents? So I would just expect some diagnosis from you. They are all simple cases which we see in everyday practice. Okay, so just give me your diagnosis and your findings and I think we can make it very interesting. Okay, so this is the first case. This is a neonate and this is a chest X-ray. So what do you see on this? Apart from the overt finding of the dextrocardia with the heart located in the right chest and the apex pointing to the right, the additional finding here which is important and which I want to show you is this gas-filled distended pouch in the upper dorsal region. So what will you think of if this is a neonate? Sorry, a little louder. We may all be wrong, it doesn't matter. I just want to see what you're thinking, your thought process. This comes to you as a spotter. Okay. So now let's have the next image. Does this add anything? Does it make it easier? So when we see this kind of an appearance in the neonate, I did not give you the history on purpose. So you must think of esophageal atresia, okay? You must think of that possibility. And this further confirms the diagnosis. You can see the coiled NG tube or the OG tube which is there in the cervical region only and not passing beyond. So the next thing that you have to note is the presence or absence of air in the distal GIT, okay? So this will tell you whether there is a fistula, a tracheoesophageal fistula and the location of the fistula. So when there is presence of, that means that we are dealing with the likely the most common type C in which the proximal segment is blind and the distal segment is communicating with the fistula, right? Another similar case, the same findings of a gas collection in the upper dorsal region and presence of gas in the distal GIT, but the additional finding of consolidation collapse in the right upper lobe. So remember that such features of pneumonitis and collapse and consolidation are very frequent in up to 50% cases when you have an esophageal atresia or a tracheoesophageal fistula because of aspiration, right? Now this is a less common variety in which there is an esophageal atresia, but you can see there is total absence of gas in the distal GIT. So now this is one of the rarer variants in which either there is a pure esophageal atresia with no fistula, or if there is a fistula at all, then it would be a fistula with the proximal segment. Okay, so these are the various you might encounter esophageal. And you have to remember that along with the chest X-ray, you must include the abdomen to look for presence of gas in the GIT. That is very, very important. And the remaining findings we case. Now another very typical exam spotter. So any volunteer to tell me what is the diagnosis? This is the finding which lies here in the cervical esophagus. Come on, just one word. Just tell me. Any volunteers? No, third year PGs. What are you going to write in your exam and what are you going to tell the examiners if you just don't speak out? Okay, third year PGs, raise hands. Show me how many are exam going PGs. No exam going PGs. I don't believe that. So your organizers just told me we have 136 registrations. So all the third year PGs are sitting at home studying, tell me. No third year PGs, so they are not even ready to admit that they are exam going PGs. Come on, we don't have to be so scared, it doesn't matter. We are all here to learn. I am learning from you, you are learning some things from me. At least tell me who are the exam going PGs. Not even one. Okay, never mind. So then I'll just show you the cases and you keep them in your mind. Okay, so this is a very typical exam spotter. This is nothing but an esophageal web. So what you see here is a radiolucent band-like or shelf-like filling defect. These are actually thickened mucosal folds and they may occur in any part of the GIT, not just the esophagus. So it is seen as a band-like radiolucent filling defect which stretches across the lumen of the hollow viscus, the esophagus in this case. And the esophageal webs are most frequently seen in the cervical esophagus close to the level of the cricopharyngeus, around the C6 level. And they may be transverse or oblique in orientation, and they typically in the esophagus they arise from the anterior wall of the esophagus, but at times they may be circumferential as well. Now this was a very, very interesting case. Let me show you. So this was a 1-month-old baby who came to us with intermittent wheezing. So we suspected that although we were able to see a large mass, so this is probably compressing the airway and that's responsible for the symptoms of the patient. So coming to the description, if you see this kind of an X-ray, such kind of a case you get in the exam. So how will you describe? So you will say that there is a well-defined homogeneous soft tissue density rounded lesion that has a large area of contact with the mediastinum and a broad base towards the mediastinum, well-defined, sharply defined margins, and we are not able to see the right margin of the heart. So which this is probably silhouetted. Okay, so always remember that what you describe is what is most important for the examiner, because without your saying even any differential, your description tells the examiner about your thought process, what you are thinking, and he or she can ascertain from the description itself that what direction you are going in. Okay, so my description says that I am thinking about a mediastinal mass in this case. Okay. The next set of images, this was an ultrasound from the right posterior paravertebral window, and this shows us that we are dealing with a cystic mass, not a solid mass. You can see it is an anechoic cystic lesion with lot of posterior acoustic enhancement, and there was a very important finding on ultrasound. The wall shows a layered structure of the wall. There is outer and inner hyperechoic layers and a middle hypoechoic layer. So this is described as the gut signature on ultrasound, and this is very, very diagnostic for a duplication. Okay. So a CECT scan was further advised, which further shows you the extent and characterization of the lesion. So we can see that there is a well-defined homogeneous fluid density lesion predominantly involving the middle mediastinum extending into the posterior mediastinum, and there is no soft tissue, there is no fat. So again we think of a duplication cyst only, and in this scenario, we would think of a foregut duplication cyst in the mediastinum. So commonly these can be of two types. It may be esophageal duplication or bronchogenic cyst. Imaging may not be able to differentiate between the two, but then sometimes there are few features that might help you. If the shape of the lesion is elongated or tubular, that goes more in favor of an esophageal duplication. And if it is rounded in shape, it can be either. Esophageal duplication is more commonly a homogeneous fluid density, but if the lesion appears heterogeneous or if it appears to be of soft tissue density or hyperdense, or sometimes even an apparent solid appearance. So that is because of due to presence of proteinaceous or hemorrhagic contents, and it goes more in favor of a bronchogenic cyst. And even the presence of calcium in the lumen or in the wall also goes more in favor of a bronchogenic cyst. Less commonly, there might be a neuroenteric cyst which is closely related to the spine. There may be intraspinal extension. It may be associated with vertebral anomalies. Now this is another very common spotter. I will not ask you, but I know many of you know it. I would say it's a first year spotter. So this was a 1-month-old baby with an ultrasound of the upper abdomen, and this child was presenting with recurrent vomiting after feeds. Okay, so a very typical appearance as soon as you keep the probe in the upper abdomen and you find this. So the diagnosis can be nothing but hypertrophic pyloric stenosis, right? So you can see there's an elongated pyloric canal, by definition more than 12 mm or 15 mm in length in some texts. There is thickened pyloric musculature, again by definition more than 3 mm in thickness. These are diagnostic pointers, and you see this target or donut appearance on cross section. This is what is known as the antral nipple sign. The mouse is not projecting, nobody told me. The pointer is not projecting. Otherwise you can give me the laser pointer. See, you people should have told me, you just don't speak at all. There are so many things that you won't understand if there is no pointer. So this little echogenic nipple kind of thing that is projecting in the gastric antrum, this is known as the antral nipple, and it is because of the thickened redundant antral mucosa. And then the thickened cervical musculature produces an indentation on the fluid-filled gastric antrum. Right, so this is the antral nipple, and this is the indentation on the gastric antrum that is known as the cervix sign. So ultrasound is the most important modality for the diagnosis of hypertrophic pyloric stenosis, and these upper GI barium studies, they are of historical interest only. They used to be done in the earlier times, but we don't do them for this diagnosis anymore. So just some senior examiners might show you these spotters from their museum collection. So that's why I'm showing this. This is known as the string sign. So there's an elongated, narrowed pyloric canal directed superiorly, and this is the indentation of the thickened cervical musculature on the gastric antrum. So this is hypertrophic pyloric stenosis, and remember that this is the most important and the most frequent cause of gastric obstruction in the infant. And I have shown you all the important signs on the case. Now this is another very important spotter, something that you must, the moment you see the X-ray blindly, you have to tell the finding. This is nothing but the double bubble sign, okay, which indicates a complete duodenal obstruction. So as you can see, there are two gas-filled bubbles in the distribution of the stomach and the duodenum, and there is no gas in the distal GIT. So the presence or absence of gas in the distal GIT tells you whether we are dealing with a complete or a partial obstruction. And if gas is totally absent distally, then it is a complete duodenal obstruction. So with a complete high bowel obstruction, further radiological investigation is not indicated, and the pediatric surgeons would shift the child directly for surgery. For a complete duodenal obstruction, there are three important DDs: a duodenal atresia, midgut volvulus, and annular pancreas. Always remember this. So this is just the ultrasound counterpart that shows you the fluid-filled bubbles. Now, midgut volvulus and annular pancreas may also lead to partial duodenal obstruction, and there are other causes as well, including duodenal web, stenosis, LADS. Let's see some cases. This was a very interesting case. The patient presented with recurrent episodes of vomiting. So what we see here is that there is some mild obstruction, mild narrowing in the region of the second part of duodenum. But as we can see, the mucosal folds are maintained. So what this means is that we are dealing with an extramucosal pathology, which is causing duodenal narrowing and some proximal dilatation. So MR was done for further evaluation. In incomplete obstructions, we always need to go in for further imaging to ascertain the cause of pathology. So what we saw on MR was, again, this is a very typical finding. You see an abnormal pancreatic tissue which is arising from the pancreatic head and completely encircling the second part of duodenum with the proximal dilatation. So what is the diagnosis? Yes, very good. So it's a complete annular pancreas which is causing a partial duodenal obstruction. Okay. Annular pancreas may be complete or incomplete. So incomplete would be when it is not extending on the lateral aspect of the duodenum, but just extending anteriorly, posteriorly, superiorly, inferiorly, and it is known as the crocodile jaw appearance of the annular pancreas. And the patient may be symptomatic or asymptomatic depending upon the degree of the narrowing of the duodenum, and pancreatitis, duodenal and biliary obstructions are commonly associated. This is another very typical spotter. This is, what is this? These are duodenal webs, okay, similar to what we saw in the esophagus. So as I told you, they can happen in any part of the GIT. So again, you can see horizontal or obliquely oriented mucosal thickenings which are extending across the lumen of the bowel, causing obstruction. Again, the degree of obstruction may vary, and in the duodenum, these are most frequent in the second part of duodenum, and at times the web may project caudally into duodenal lumen, producing what is known as the windsock or the halo sign appearance. Now this is another very, very typical appearance that none of you should miss, and it is very characteristic. If you see this kind of appearance, the diagnosis is only one. Okay, this can come to you as a short case or as a spotter, and all of you who deal with pediatric patients or even even in older children, I would say teenagers, you can get this appearance at times. Okay, so the upper GI series shows you a very typical appearance of the twisting or what is known as the corkscrew appearance of the upper small bowel, which is involving the duodenum and the upper jejunum in this case. And on ultrasound, we see an inverted relationship of the SMA-SMV. So normally the SMV is present to the right and anterior of SMA, but in this case you can see it is present on the left side, and you might even see it crossing posterior to the SMA. So, and when you, this is the inverted relationship, and this is what is described as the whirlpool sign. That is, you see the bowel, the mesentery and the SMV volving or going around the axis of the SMA. So all this constellation of findings is suggestive of a midgut volvulus with malrotation. And the real-time ultrasound will be really beneficial if you are able to demonstrate. It will clinch the diagnosis. So, okay, let's see this one. If you can see, there is a complete twisting or volving of the bowel and the SMV and the mesentery around the central axis, and this can be beautifully demonstrated on the real-time ultrasound. And believe me, if I show this to the surgeon, if just on the basis of this I give the diagnosis, they take the children directly for surgery. Okay, they will not advise further CT or MR to confirm the diagnosis. This is so characteristic. So some of these pathologies, the hypertrophic gastric stenosis and the gut signature, this whirlpool sign which is demonstrated on the ultrasound. So all these entities, ultrasound plays a very specific role for the definitive diagnosis. Okay. This was another very interesting case. This was a woman who presented with recurrent episodes of abdominal pain and vomiting. A CECT was done and we saw such grossly dilated duodenum, something like we had never seen before. And apart from that, there was an abrupt transition. This is such a grossly dilated duodenum and then suddenly it is normal. And there was also some mild dilatation of the ileum, again with an abrupt transition. Now this patient also had some past history of surgery for internal hernias, and the surgeons were very sure that we were dealing with post-op adhesions. They were contributing adhesions as the cause of this. But then we also noted that the DJ flexure was lying in the right abdomen and the jejunal loops were also there in the right abdomen. So we also kept the possibility of malrotation with Ladd's bands, and we told them the possibility that is also one possibility, Ladd's bands which are compressing the duodenum as well as the ileum. The Ladd's bands are, as you must be aware, they are abnormal peritoneal fixation bands that develop in malrotation and they extend from the ligament of Treats to the right iliac fossa. And indeed this patient was operated upon and it turned out to be a case of malrotation that was undiagnosed earlier, and there were Ladd's bands that were resected. And the previous internal hernia was actually a consequence also of the undiagnosed malrotation in this case. Now, these are some very interesting x-rays. This was a neonate who presented with lot of bilious vomiting since birth. And what you see on the x-ray is that there are few dilated small bowel loops in the course in the abdomen. And again, there are few 5 to 6 air fluid levels in the distribution of the small bowel with these valvulae conniventis. So this would be described on X-ray as a high bowel obstruction, which is typically defined as being proximal to the level of the mid-ileum. And this would be a complete high bowel obstruction because again there is no gas in the distal GIT above the distal to the level of the obstruction. Okay. So by seeing few or many small bowel loops and air fluid levels, you would be able to assign it as a high or a low bowel obstruction on the basis of the X-ray. And when it is a complete high bowel obstruction, just like a complete duodenal obstruction, the surgeons take the patient up for surgery. This was operated upon and this turned out to be a jejunal atresia. In comparison, in this case, you can see the patient had similar presentation, but what you can see is that there are many or multiple dilated bowel loops in the distribution of the small bowel and multiple air fluid levels in the same distribution. So, and a total absence of gas in the distal GIT. So, this is a complete low bowel obstruction, and this was a case of ileal atresia, and a closed DD would be the meconium ileus. So, meconium ileus is actually a misnomer. It is not an ileus at all. What happens is that there are thick antenaceous meconium which gets clumped up in the distal ileum or the distal small bowel, and that results in a small bowel obstruction, and similar picture of a low small bowel obstruction. When there is a complete low small bowel obstruction, we need to do a barium enema to look for presence of microcolon. That would be commonly associated because the normal distal small bowel secretions, what are known as the succus entericus, they do not pass into the colon, and so the colon, due to disuse, does not develop fully and the diameter of the colon remains narrow. So by definition this is less than 1 centimeter and that is defined as a microcolon. So on the barium enema picture, this is what you would find, a narrow large bowel or a narrow colon. Now to differentiate from a meconium ileus, which I told you would also lead to a low bowel obstruction, with meconium ileus, you would often get a frothy or a soap bubble kind of appearance in the right iliac fossa, and this is because of admixture of meconium with air. Also because of the thick tenacious meconium paste that is filling the bowel, the air fluid levels are scant or few or even absent. In spite of the fact that there are so many dilated small bowel loops and there is such a high grade obstruction, still you would not find too many air fluid levels with meconium ileus. And when you do a barium enema, apart from the finding of microcolon, you would also find inspissated pellets or clumps of the meconium which are seen as filling defects. If a bowel perforation occurs as a consequence to meconium ileus, then the meconium contents, they spill into the peritoneal cavity, and subsequently abdominal calcifications develop in the peritoneal cavity on the serosal surface of the bowel and the surface of the visceral organs, and the abdominal calcifications are a hallmark for meconium peritonitis. And finally, coming to the large bowel, this was a case of a child with abdominal distension and chronic constipation. What you can see is that there are multiple gas distended bowel loops filling the abdomen, and the barium enema picture is very, very characteristic. So what is the diagnosis? Two-word diagnosis? Yes, very good. So it is a classic and very easy spotter. This is Hirschsprung's disease, okay? And the typical picture is that you find that the distal bowel, that is the rectum in this case, this is collapsed, and there is significant dilatation of the proximal large bowel, the sigmoid and more proximally. There is an abrupt transition which is often a funnel shaped transition. At times you might even find an irregularity in the abnormal segment, and this is actually a functional obstruction which occurs due to absence of the ganglion cells. And typically on the delayed 24 hours image, you would find a lot of contrast retention in the bowel. Okay. So normally you can find on the delayed image some contrast retention in the rectum or the distal sigmoid when we are dealing with the typical short segment Hirschsprung disease. But more than that is abnormal. So there are various types of Hirschsprungs. Most common is the short segment disease, in which the rectum and or the distal up to the distal sigmoid may be involved. And then we also have the long segment type, in which the affected segment might extend right up to the splenic flexure or the descending colon. And there may be the rare entity of the total colonic aganglionosis, in which the entire large bowel may be affected. So this is a complete barium enema set of study from another patient. You can see again gas distended large bowel loops and fecal matter in the abdomen, and all these images you can see that they show a persistent underdistension of the rectum. The rectum has never distended, and there is an abrupt transition with a significantly dilated sigmoid and the descending colon, and in fact the entire proximal colon. And on the delayed 24 hours image, you find a significant contrast retention. Okay. So the diagnosis is very, very typical. This is a spotter. This is another case of a Hirschsprung's disease. So just to conclude, imaging has a very important role to play in the diagnosis of GI anomalies. Abdominal X-ray is the first tool that we must evaluate as the first screening modality, and it gives us important insights into high versus low obstruction, complete or incomplete obstruction, and also suggests what further imaging we must resort to. Ultrasound is important, and as I said, in some entities it will give you a specific diagnosis, and even further imaging may not be required. But in many of the conditions you would need cross-sectional imaging for a further characterization, for the complete extent of pathology, and to give you a precise preoperative anatomical planning. Thank you so much for your patient hearing.
Thank you, Doctor, for that very involving session with all the surgical tidbits. I request Vice President IRIA, Dr. MVK Rao, sir, to please felicitate Madam. Moving forward, we welcome back Dr. Anuradha for her talk on GI tract dilatations. Ma'am will take us through why and how they happen, and also provide us with a simplified imaging classification.
Very good morning again. So in this presentation, I'm just going to give you this overview of a very simplified imaging classification of how to approach dilated bowel. And Dr. Natasha's presentation has made my work really simple because one of the classification that I wanted you to approach with is to keep the age and the symptoms and the location in mind when you approach dilated bowel. So with that background, let's just go and see how to approach the bowel dilatation. We'll look at it from the anatomy. Bowel is basically made of folds of mucosa, which is surrounded by the submucosa, which is a loose collagen tissue, which has submucosal plexus, that is one of the part of the enteric neural system. And then we have two muscle layers. One is the circular muscle that is inside, and then the longitudinal muscle outside. And between the circular and the longitudinal muscle, there is the Auerbach or the myenteric plexus. So the gut neural network is considered the second brain. The bowel contractions happen in such a coordinated manner that it is able to propel the food in a very coordinated manner where the circular muscles relax and the longitudinal muscle contract. So when the longitudinal muscle contract, what happens is the length of the bowel will come down. And when the circular muscle relaxes, the lumen will get dilated. And the opposite happens in a segment that is just distal to the segment containing the bowel, containing the food bolus. So what happens is when the longitudinal muscles relax and the circular muscle contract, the lumen will come down in size and the food bolus is able to propel in the forward direction. And this happens in such a coordinated manner in the GI tract that the food is able to go down in only one direction and propel in only one direction. When we understand this physiology and keep this in mind, then we will be able to understand the proposed classification that I'm putting in front of you. So what is a dilated bowel? Dilated bowel is when the diameter of the bowel is more than normal. So what do we mean by that? We'll remember that as the 3-6-9 rule. When the esophagus or the small bowel is more dilated than 3 centimeters, or the large bowel is dilated more than 6 centimeters, except the cecum is dilated more than 9 centimeters, then that is the definition of a dilated bowel. So both the physical and the physiological disturbances to the stereotypical contraction of the bowel is what is the pathophysiology that we have to remember as a cause of bowel dilatation. So we will look at it in that fashion. We will look at it as a failure of peristalsis or the blockage in the plumbing system. So the plumbing system can get blocked or clogged by either causes that are within the lumen or in the wall, or that is something that is outside the wall. So we'll think of the causes in this fashion, where the failure of peristalsis is problems with the second brain that I was talking to you about. It can happen because of problems in the nervous supply. It can either be aganglionosis or hypoganglionosis, which can be congenital or acquired. Congenital causes are those that Dr. Natasha very beautifully illustrated. For example, Hirschsprung's disease and eclasia cardia. These are problems which are congenital, and the acquired causes would be Chagas disease and certain other viral and parasitic infections that cause ganglionic dysfunction or hypofunction. We also have to remember in our practice the temporary paralysis which can happen because of medications, like for example anesthetic drugs and the opioids that are given for pain management can also cause temporary dysfunction of the ganglion cells, and so there can be bowel dilatation. And there can also be autonomous dysfunction, for example, in patients with IBS. Typically, they can have dysfunction of the second brain, and so there can be problems with peristalsis. And the blocked plumbing system, I already told you that we need to think of causes within the lumen, in the wall, and extrinsic. So with that in mind, when we see an image of a patient with a dilated bowel, I would like to approach it in this fashion. You look at the symptomatology of the patient to localize the bowel dilatation to a particular part of the GI tract, foregut, midgut, or hindgut, and understand and then locate the bowel dilatation. How do we locate the bowel dilatation? Look at where the bowel dilatation stops, and as a first thing, when we look at a picture or an image with bowel dilatation, try to think in the contrary and try to see where is the normal bowel and where is the normal bowel stop. So that helps you in finding out the transition zone, which Dr. Natasha was saying. What is a transition zone? The point at which the dilated bowel becomes normal or collapsed. So that is the transition zone. So that is the location. And the etiologies will differ based on whether it is a pediatric patient, a young person, or an older individual. And finally, we will have to put it all together and provide an etiological diagnosis for the bowel dilatation. So with that in mind, symptoms can, I would also like you to think of symptoms as acute, subacute, or chronic. So that gives perspective to the dilated bowel, and the imaging modality which you will choose in evaluating the dilated bowel will depend on the symptomatology, and I'll come to that shortly. In an acute setting and you see a dilated bowel, you don't want to do an enterography. You don't want to give oral contrast. You have to go ahead with a cross-sectional study without oral contrast and just give IV contrast and do the CT. But if it is a subacute or a chronic bowel dilatation, enterography would be the best imaging modality of choice. And so that is another thing to keep in mind. And this is the symptomatology that I was trying to emphasize. If it is an esophageal origin, patient can present with dysphagia, reflux-related symptoms. They can complain of halitosis. If it is a stomach or duodenal etiology, patient will say that they have vomiting, and it could be bilious. And they could complain of early satiety, anorexia, or a delayed gastric emptying. It means stomach is feeling very full and for a very long time after they ingested food. And if it is a small and large bowel dilatation, they can complain of abdominal distension, cramping, bloating sensation, altered bowel habits, constipation, obstipation. And having this framework of symptomatology in the back of a radiologist's mind is very important in choosing the right imaging modality that is available to us. So we all start off with an X-ray, but X-ray nowadays increasingly we know is not contributory, because patient's symptom will tell the surgeon or the physician who is dealing with the patient that there is going to be a bowel pathology, and we as radiologists will be asked to choose the imaging modality that is appropriate for the patient, and that will depend on whether it is acute or chronic and whether the symptomatology fits in with a foregut, hindgut, or a midgut. So other useful information that we have to keep in mind, as I already mentioned very briefly, is the comorbidities. For example, a diabetic patient can come with gastroparesis. A patient with psychiatric illness and the psychiatric drugs can itself cause bowel dilatation. Scleroderma, SLE, Parkinson's, and Alzheimer's are other disease entities that can also affect the bowel ganglion cells, and these can also present with dilated bowel. And medications, I already touched upon opioids, but there are also other medications that are very widely used in our population, like antidepressants, antipsychotics, laxative abuse, and anticholinergics, which can also present with bowel dilatation. And other factors radiologists must keep in mind is the recent history of surgery, electrolyte imbalance, and inflammation and inflammatory pathologies that patient might already have. So all these findings will also have a bearing on what we say on imaging about the dilated bowel. So let's go, with that in mind, let's go to some examples. This is the first example. I would like any postgraduates to take it. Anybody with the diagnosis? Achalasia cardia, yes, absolutely. So it is a problem with physiology where there is problems with the ganglion cells at the gastroesophageal junction, which does not relax at the right time when the food bolus hits it, and so it stays contracted. And when the food bolus collects quite a lot in the proximal esophagus, then it bursts of opening of the distal esophageal junction happens, and that bursts of opening is the Hurst phenomena that we see in fluoroscopy. So when the patient is usually, the study happens in erect position, and when the imaging happens and you look at the GE junction in erect position, you will see these, the gastroesophageal junction opening intermittently, and that is called Hurst phenomena. And there is this bird beak sign, which is a narrowed appearance, smooth, tapered, narrowed appearance of the G junction. And the esophagus can be as dilated as this, and that's called a sigmoid esophagus. And that's a sigmoid esophagus on a CT scan. So when you see such dilated bowel, you think of achalasia cardia. On the other hand, let's look at this example. Can anybody say, is it achalasia or a pseudoachalasia? Obviously, I've shown you a case of achalasia. This is going to be a pseudoachalasia. So, but what is a pseudoachalasia? The esophagus is not so dilated. And when you look at the, this X-ray, you can see that the gastroesophageal junction region has got additional soft tissue. This much amount of thickness between the diaphragm and the gastric air bubble is not normal. Okay? And then when you do a barium study, you see this bird beak appearance. And if this is a patient 60-year-old, you really worry about this finding, and you definitely have to do endoscopy, and you have to do a CT scan, and this turns out to be a positive Kirkland sign, which is nothing but this increased thickness or the deformed fundic air bubble on a chest X-ray. That is what is called Kirkland sign. And this is seen in achalasia, which is, sorry, I'm not able to pointer. Sir, mouse not working, sorry about that. That's, so that's pseudoachalasia, and the pseudoachalasia seen as this bird beak sign, not much dilatation, and you see the soft tissue thickening at the G junction, which is from a G junction malignancy. So the Kirkland sign is a deformity of the gastric air bubble, and this is another example demonstrating the same, where you can see this deformity of the gastric bubble, and there is increased thickness at the G junction, and that's another example of pseudoachalasia. And this patient, you can see a very obvious large mass in the barium studies, and we don't do barium studies anymore to evaluate this, but if the patient lands up with the ENT surgeon or with non-specific symptoms and dysphagia is not a prominent symptom, then we might end up seeing these barium studies, and we must be able to recognize that there's going to be a mass lesion by looking at the X-ray itself. Now let's look at this example of a 62-year-old patient with dyspeptic symptoms, mild dysphagia for solids, and there was 2 episodes of mass protruding out while cleaning the tongue. Okay? And it resolved spontaneously with swallowing. So what do you make out of this history? So when you look at this barium study, this is what you're seeing. There is a problem with the plumbing system. There's intraluminal cause. What is that? Anybody with the diagnosis? You're seeing a smooth filling defect filling the entire lumen of the esophagus all the way from the proximal to the distal aspect. The G junction is normal. And what is that? Okay, that's how the CT looks. There is a soft tissue density mass, a polypoidal growth within the esophageal lumen, and that's the axial images, and the coronal images look like that, and the diagnosis is a giant esophageal polyp. And this is an entity with that particular typical clinical presentation where it's a very important diagnosis to make, though this entity is extraordinarily rare because they can asphyxiate and definitely needs a surgical management. Okay? That's giant fibrovascular polyp of the esophagus. Okay, that's an erect study, okay, and that's the supine barium study that I've projected here. So what is the diagnosis in this patient who complains of feeling very full after food? And this is a very thin, tall lady. Okay, so what is the diagnosis? This is a condition called gastroptosis. Okay, gastroptosis is a condition where in this typical type of body habitus, in a very tall, thin person, they feel that the stomach is very full just after eating, and when they are erect and walking about, they just don't feel all right. But they lie down for a few minutes, the entire stomach empties out, and then they feel all right. So they have to lie down after eating to empty their stomach. So that is called gastroptosis. Okay, so that's a typical example of gastroptosis. An elongated, dilated stomach. And so that brings us to the question of what is a dilated stomach? A stomach, when it is longer than 30 centimeters or wider than 15 centimeters, is a dilated stomach. And that's when we make that's when we call it a dilated stomach. And the causes of dilated stomach is most common cause of dilated stomach is gastroparesis in a diabetic patient. And also elderly patients due to gastric atrophy can have a grossly dilated stomach. Okay. What is this entity? Dr. Natasha already showed us this example. This is an example of volvulus, a duodenal cause, and I'll go back on that very subtly seen corkscrew sign on this upper GI series, but we have a dilated stomach and a duodenum, a typical whirlpool sign on ultrasound. And what I also want you to notice is the reversal of superior mesenteric vein and superior mesenteric artery relationship in this patient. We look at that image. The vein is supposed to be in front of the vein and artery is supposed to be in front of the artery, but in this patient it's reversed. And you see this in 65% of patients with malrotation, not 100%, but when you see this reversal of SMA-SMV relationship, you should think of malrotation, and this is an example of volvulus. Okay. In this 32-year-old male patient with abdominal pain, vomiting after food, very, very thin, emaciated patient with this history, and you see a grossly dilated duodenum all the way to the second, third part junction. So what is the diagnosis? SMA syndrome, absolutely. So this is an example of SMA syndrome. But I want to tell the radiology community that SMA syndrome is a clinical diagnosis, and radiologists should not be making this diagnosis without the clinician prompting you to make one, though these measurements are said in our textbooks. When the angle of takeoff of the superior mesenteric vessel from the aorta is less than 15 degrees, and the distance between the aorta and the superior mesenteric artery is less than 8 millimeters, you can think of this diagnosis of SMA syndrome. But in clinical practice, this must be a diagnosis that must be prompted by the clinician, where they have to tell us when the patient is in the lateral decubitus position, the patient feels better. So only when they give you that forthcoming history, the diagnosis is going to be right when we make this SMA syndrome. Okay. In this 70-year-old male patient who presented with melena, and he also has a history of gastrojejunostomy, and this is an example of an afferent loop syndrome, where you can see this gastrojejunostomy and the jejunal loop is dilated, and that's the afferent loop that's dilated. So what is the mechanism of afferent loop syndrome? Afferent loop is the blind ending loop of the jejunum, which has food which will become stagnant, and hence slowly this part of the bowel gets dilated because of bacterial overgrowth and the food residue getting collected in the afferent loop. And it does not empty itself, and so bacteria keeps growing, and they can present with malrotation, halitosis, and early satiety. And so these kind of patients, when you see a dilated bowel, you can then make a diagnosis of an afferent loop syndrome. What is the diagnosis in this patient? What is that sign which is demonstrated? Any PG? String of pearls sign, yes. What does it indicate? Okay, is it seen in supine or erect radiograph? Erect, very good. It's seen in an erect abdominal radiograph, and what does it indicate? Okay, diagnosis? Okay, high grade or low grade? High grade, yes. So that's the complete answer. So when you see the string of pearls sign in an erect abdominal radiograph, it is not a sensitive sign. It means you will see this only in 10 to 13% of patients with bowel obstruction. But when you see this sign, it is highly specific for a high-grade obstruction, and the surgeon definitely has to prepare himself to take this patient up for surgery. So that is what it means. Okay, so that's the string of pearls sign, highly specific for small bowel obstruction. And in this case, obviously, the importance of cross-section is as demonstrated in this example, where the etiology for this dilated bowel or the string of pearls sign is this cancer that is sitting in the ascending colon, and there are multiple liver metastases. So the importance of inserting a CT scan in a patient with a string of pearls sign is demonstrated in this example. So even if the surgeon wants to rush the patient to theater, you stop them and say, see, let me do a CT scan for you and tell you the etiology, and then you plan your surgery, and it'll always be worth it. Okay, so in this example of string of pearls sign again, so what is the etiology? The etiology was a gallstone ileus, which is a triad of aerobelia. You can see air in the gallbladder, air in the gallbladder lumen, dilated bowel loops, and a large gallstone obstructing the lumen of the small bowel. So this is an example of gallstone ileus. So CT will always help you in finding out the etiology of the dilatation. So gallstone ileus is another example. The Wriggler's triad, what is it? Wriggler's triad is a triad of aerobelia, dilated small bowel from small bowel obstruction, and demonstration of the gallstone in the lumen. So that's the Wriggler's triad. Okay, let's look at this example, an acute abdomen in a 42-year-old female patient, completely gasless abdomen. In an acute setting, if the abdominal X-ray looks like this, where abdomen is completely gasless, you have to tell your surgeon, you please worry about it. There's going to be a very sinister pathology in this patient. You have to do a CT scan. And this patient, if it is an obstruction, it's going to be a high-grade obstruction. So this is how the entire bowel is dilated. And in these kind of patients, you don't give oral contrast. You just do a CT scan with IV contrast. And there is no oral contrast, and we demonstrate a high-grade intestinal obstruction with grossly dilated small bowel loops, and this patient was a benign stricture, okay, but at a high-grade obstruction. Okay, this example of a 66-year-old male patient was septic in the ICU, and this is a serial X-ray, 3 different X-rays, and what do you see? Initially, there was massively dilated bowel, and progressively the abdomen becomes gasless. And as I told you, gasless abdomen, worry about it. And in this patient, what is the diagnosis we will consider? This is a Clostridium difficile infection, pseudomembranous colitis, which is evolving in this patient in the ICU. Initially presented with paralytic ileus, and then entire bowel is filled with fluid, and entire large bowel is now abnormal. So that's pseudomembranous colitis. Gangrene can be a cause of small bowel dilatation. Don't forget ischemic etiology. And then if you have a typical clinical presentation like this, you have to 32 with the perioral pigmentation, acute abdomen, be prepared to see an intussusception, and that is what this patient had. Small bowel intussusception for multiple polyps in the bowel, and that's a Peutz-Jeghers syndrome with multiple small bowel polyps. In a very elderly patient, when you see this kind of a loop, which is like a coffee bean, we will think of a sigmoid volvulus. I want you to focus on that loop there, and you follow the arrow, and you'll see the twist of two segments of large bowel, sigmoid colon, and that's a sigmoid volvulus. And remember the age, 94-year-old male patient, acute abdomen. So elderly patients or patients with psychiatric illness, when you see a coffee bean sign, think of a sigmoid volvulus. Sigmoid volvulus is treated with this flatus tube, and it is mostly a conservative management. When this fails, then the patient is taken up for surgery. And we already saw beautiful examples of Hirschsprung's disease, so I'm going to skip that. But what we see in Hirschsprung's disease is a transition zone and reversal of rectosigmoid ratio. And it can be acquired Hirschsprung's, like in Chagas disease in this adult young patient who has a recent history of travel to Kashmir and presented with severe abdominal distension and constipation, and that's a Chagas disease because of dysfunction of the autonomous nervous system. Don't forget toxic megacolon, and in the X-ray you will see this thumb printing, and the bowel can be dilated more than 6 centimeter, and there will be a forthcoming history of ulcerative colitis. But toxic megacolon is not limited to only ulcerative colitis. There are other causes, and that's the thumb printing. And approach the megacolon as whether it is acute, chronic, or toxic. If it is acute, think of pseudo-obstruction, which is where you treat the underlying condition with just conservatively with the rectal tube. If it is a chronic megacolon Hirschsprung's, it's a congenital cause, needs surgical management. If it is a toxic megacolon, the underlying etiology for the toxic megacolon needs to be addressed. So the simple classification of bowel dilatation is failure of peristalsis and blockage of the plumbing system, which can either be intraluminal, in the wall, or outside. And thank you very much.
Thank you, ma'am, for that wonderful presentation. We shall definitely integrate the finer points into our daily reporting to take them to the next level. We now call upon stage Dr. Golwin. Dr. Golwin currently holds the post of Assistant Professor at the Abdominal Radiology Unit at CMC Vellore. We are delighted to have him deliver a talk on cystic lesions of the pancreas.
This is fine. Hi, good. This is a great opportunity to be presenting here before the superstars of radiology. I'd like to thank my teacher, Anuradha ma'am, and also the organizing committee for the opportunity. So we will be discussing about the cystic lesions of pancreas. So any abnormal fluid-filled structure with a lining epithelium is a cyst. So how common is this cyst in the pancreas? It's relatively less common. Less than 10% of So among these 10% of the population, percent of the people will have a cystic neoplasm, which is a very less percentage. So why are we taking so much efforts to radiological findings and give a proper differential? So the aim is to help in the risk stratification. So these pancreatic cystic lesions, which can look similar, are all going to be range from benign to pre-malignant to a frank malignant lesion. So the common imaging modalities we are using will be ultrasound, CT, and MR with endoscopic ultrasound for problem solving. So in CT, we'll be able to identify the lesion, look for calcifications, nodes, infiltration, and metastasis. In MR, it will be useful in further characterization of the cyst and to identify the relationship with the pancreatic duct. So we'll briefly go through the protocol. We don't prefer to use oral contrast, but we start with an unenhanced CT to look for calcifications. And contrast is with cholangio and portovenous phase. MRCP will be T2HR with diffusion restriction sequences and MRCP, and T1 fat suppressed sequences if required. So endoscopic ultrasound, as we discussed, is going to be a problem-solving tool only in indeterminate cases or to look for the internal morphology, to sample fluid or get a biopsy, we'll be using endoscopic ultrasound. So we'll classify these cystic lesions. It's like non-neoplastic and neoplastic. Non-neoplastic is going to be majorly pancreatitis-related sequelae, which is pseudocyst or a walled-off necrosis. In neoplastic lesions, we will either characterize this to be communicating with the main pancreatic duct or non-communicating lesions. So the non-communicating lesions is going to be mucinous, mucinous cystic neoplasm. Non-mucinous is cystic, serous cystic neoplasms, SPEN, cystic pancreatic neuroendocrine tumors, acina cystic neoplasm, and ductal adenocarcinoma with cystic degeneration. So those that communicating with the main pancreatic duct will be IPMNs. So we'll go through the cases. So this is a 37-year-old male with severe abdomen pain. Axial CT, we see a lot of inflammatory stranding and fat necrosis around the peripancreatic region. We see a large cystic lesion, which is hypodense with a thick wall, and septations within, which is replacing the neck, replacing the pancreatic parenchyma, involving the neck, partly the body, and extending to the tail. There is inflammation with thickening of the peritoneum, anterior pararenal fascia. The MR of this patient shows debris, and this patient had history of recent pancreatitis, and inflammation also suggests recent pancreatitis, and this is going to be a pancreatic walled-off necrosis. So in pancreatic lesions, there will be no calcifications. There can be debris. In pseudocyst, there need not be debris. And whenever the lesion is within the pancreatic parenchyma, it is a sequelae of an acute necrotizing pancreatitis and a walled-off necrosis. So if at all confirmation is required, we can do a aspiration in which the amylase values will be more than 250 units. And this usually regresses with time. So if the lesion is not regressing with 6 weeks, we might resort to draining it via endoscopy or radiology or surgically. So next is a 62-year-old female with abdomen pain for 2 months. We have a lobulated lesion which appears to have multiple clustered cysts, thin septations which are enhancing, may look solid and hyper-enhancing in CT. We have a lot of central calcification, and it is seen involving the neck and the body of the pancreas. In the MR, it is T2 hyperintense with a central scar. This is a classical description of a serous cystic neoplasm. So remember, this lobulated appearance would be useful for differentiating with other conditions. So as we said, we have multiple microcysts with a less than 2 centimeter and more than 6 in number. The septations can enhance and hence can have a hypervascular appearance. So there should be definitely no communication with the main pancreatic duct, and location is in the head and the body. So this we commonly call it as a grandmother lesion because it's common in seen in elderly women. and association with von Hippel-Lindau syndrome. This is a patient with VHL. We have multiple serous cystic neoplasm replacing the pancreatic parenchyma. So once we are sure that this is a serous cystic neoplasm, we can comfortably follow this patient up for every 2 years. And if at all the patient's cyst causes symptoms, he can be surgically removed, and their recurrence possibility is very less. So these are some of the variants which are described, and the most common will be the polycystic variant, where we have 70% of the serous cyst adenomas. So classically described as cysts of multiple sizes, and there can be a central scar and calcification. The septae may be enhancing. The next less common variants will be honeycomb and oligocystic, which is 20 and 10%. The patient we saw in the first will be the honeycombs, where we have a lobulated appearance, multiple smaller microcysts, less than 2 centimeters, and can appear solid and hyper-enhancing. The oligocystic variant is less than 10%, and they have a larger size cyst, and can be sometimes confused with the mucinous neoplasm. So we have a 35-year-old female with abdominal distension and pain. So we have a large cystic lesion. Note that this has a smooth capsule, and the cyst has multiple enhancing thick septations. And the smooth capsule is very important, and they are macrocystic, that is more than 2 centimeters in size. So sometimes these can have peripheral calcification, and the calcification can be also seen in the septae. So most common location is tail and body. It is seen in 95% of the patients. So this is called as a mother's lesion because the common age group is 40 to 50 years, and there is ovarian stomata. So this is another patient showing a calcification in the peripheral wall, which is classical for a mucinous cystic neoplasm. As described earlier, so this mucinous neoplasms can be appearing benign to malignant, and the malignancy potential will be around 17%. There is no definite imaging feature which will point definitely that this is going to be a malignant lesion, and hence the management will be mostly surgery. If at all, the confirmation is going to be endoscopic ultrasound and aspiration, which has high CEA values and mucin. Some imaging pointers which can point towards a malignancy are the dense calcifications, mural nodules, the infiltration of the capsule to the surroundings, lymphadenopathy, elevated CA19 values, and a size of more than 4 centimeters. As said, most of these cases go in for surgery because there is no definite image predictor to say whether it is malignant or not. So few points to differentiate a serous cystic neoplasm for a mucinous will be, first, the age of the patient, grandmother lesion and mother lesion can be in the head, body, tail. And the major thing to remember is the microcystic appearance in serous cystic neoplasm, which is less than 2 centimeter cyst, macrocystic appearance in the mucinous cystic neoplasm, which is more than 2 centimeter, lobulated appearance in serous cyst adenoma. There is central calcification, honeycomb appearance, but mucinous is going to be a smooth wall with cyst within the cyst appearance, and calcification, if at all, will be peripheral and the septal. The more confusing variant will be the oligocystic serous cyst adenoma, which is less than 10% of serous cyst adenomas. However, the lobulated appearance and multiple clustered cysts can give a clue of serous cyst adenoma, but in doubtful cases, can be confirmed with an endoscopic ultrasound guided aspiration. This is a 22-year-old female with abdomen pain and vomiting. We see a solid appearing heterogeneously enhancing lesion involving the head and the neck of the pancreas, which has a capsule. So these lesions can have hemorrhage, which is T1 hyperintense. Calcification can be punctate and peripheral. Some of these lesions can show enhancement like a nodular enhancement like a hemangioma. It's more commonly seen in body and tail, and this is called as a daughter lesion because it is seen in 2nd and 4th decade. This patient had a solid appearing lesion which is heterogeneous in T2 with T1 hyperintense signal suggestive of blood products, which is classically seen in SPEN. The SPEN is a solid lesion which is very heterogeneous. So malignancy possibility of, it is a low grade, slowly growing tumor it is more malignant potential increases when the size is more than 5, location in tail, if we see the capsule to be discontinuous or with metastasis. Most of the spin are surgically resected. And the follow-up can be widely spaced because it's a very slow-growing tumor. Next, we are seeing a 62-year-old male with vague abdominal pain. We see a cystic lesion with small septations and lobulated appearance communicating with the main pancreatic duct, which is not dilated. The MRCP images also show the cystic appearance of the lesion with communication with the main pancreatic duct. We also have another side branch dilatation. So this is a classical imaging of a side branch IPMN. So this has a cluster or bunch of grape appearance with MPD communication. So this can more look like a serous cystic neoplasm. The differentiating will be the communication with the MPD. So calcification and scars can or cannot be, may not be present. In ultrasound or CT imaging, we might see mural enhancing nodules, and more commonly seen in the uncinate process. So this is a patient showing a branch duct IPMN. We see a great cluster of a bunch of grape appearance with communication with the main pancreatic duct in the uncinate process. So in up to 40% of the cases, when we find a IPMN, side branch IPMN, we should search for other IPMNs, because in 40% of cases, there is multiple IPMNs. And this is most common among the IPMNs. Up to 60% of the IPMNs are side branch IPMNs. They have low malignant potential, but up to 13% risk of malignancy. So next we go to 65-year-old male patient with abdomen pain since 1 month with recent worsening of diabetes. So we see a lobulated cystic lesion with some dilated branch ducts and some mural thickening and communication with the MPD. The MPD is dilated. The pancreas is diffusely atrophic. So this is a feature of a mixed IPMN where we have side branch and the main IPMN. So the communication with the main pancreatic duct, dilated MPD are all necessary for the diagnosis. The main lesion may or may not be seen in a main duct IPMN. So enhancing mural nodules and papillary projections are sometimes seen. The pancreas is atrophic as said, and most commonly seen in the head region. So the age is 60 to 70 years, and male and female it is common. It is equally predominant. These neoplasms secrete a lot of mucin, which cause the dilatation of the pancreatic duct. And that is the cause for the pushing of the papilla, which projects into the duodenum, which can be seen in some CTs or EUS study. These are high risk of malignancy, with 40% risk of malignancy and 40% risk of recurrence. This is a patient who had a mixed IPMN who was lost to follow-up, who came back with an aggressive infiltrative malignancy. We can see the infiltration to the stomach in this patient. So IPMN is considered a background parenchymal abnormality. Like cirrhosis to the liver is IPMN to the pancreas. We have a concept called the field defect, where the malignancy is located at a different location from the main IPMN. Therefore, always the patient, even after the resection of such IPMN, requires a long-term follow-up. So initially, we were following up IPMNs with Fukuoka guidelines of 2017, now replaced by the Kyoto guidelines, where this is in 2024, Kyoto guidelines. There is high-risk stigmata and worrisome features. The high-risk stigmata will be obstructive jaundice, enhancing nodule more than 5 mm, main pancreatic duct more than 10 mm, and any guided cytology positive for IPMN. Worrisome features will be mural nodule of less than 5 mm, MPD dilatation of 5 to 10 mm, acute pancreatitis, cyst more than 3 mm size, thickened enhancing cysts, and abrupt change in the pancreatic duct. So the cyst growth of more than 5 mm was considered in Fukuoka guidelines. Now it is more than 2.5 mm per year. So the management will be, in a patient with suspected IPMN, we will be looking for high-risk stigmata features. If we find them, the patient will be taken for surgery. If there is no high-risk stigmata features, we will be looking for worrisome features. If at least 2 or 3 worrisome features are seen, or the patient has acute pancreatitis, and young and fit for surgery, most consider for a surgery. Or if both are absent, that is high-risk stigmata and worrisome features are absent, the patient cyst is less than 3 centimeter in size, the patient can be followed up. And in follow-up, if the lesion is increasing in size, again, we will have to reassess the patient for high-risk stigmata, worrisome features, and consider surgery. So eventually, most of the main duct and mixed duct IPMNs will be taken for surgery, and very few, only side branch IPMN will be followed up. So we have finished major chunk of the cystic lesions. We will go to the less common variants. So this is a 57-year-old male with abdomen pain and vomiting. We see a macrocystic lesion which is heterogeneous with peripheral rim of arterial phase hyperenhancement. It has smooth margins. So this lesion had an uptake in DOTA PET, and calcification can be seen, and most commonly seen in body and tail. This is cystic pancreatic neuroendocrine tumor, which is less common. So this is another patient with similar features who presented with us liver metastasis. So pancreatic neuroendocrine tumors can be sporadic or associated with syndromes. And the cystic variants are less aggressive compared to the solid counterparts. Most of the time, they are taken for surgery or chemotherapy based on the staging. Next is the acinar cell cystadenocarcinomas. This is a 57-year-old male who had a non-contrast CT. We had diffuse cystic lesions in the pancreas, clustered cysts. And in the MRCP, we did not find any communication with the MPD. But based on the symptoms and CA19-9 values, this patient underwent an EUS, and most of these acinar cell cystadenomas usually present with a mural nodule. And enhancement can be minimal, and the treatment will be based on the staging, either surgery or systemic therapy. So this is a 67-year-old lady with pancreatic mass. So in the CT, we saw a hypoenhancing mass with a thick wall enhancing septum, which has some aggressive features and had a cutoff of the MPD. There was also a peripherally enhancing lesion in the liver. So this is like a cystic degeneration of a pancreatic adenocarcinoma. It can infiltrate to the surroundings. There can be distortion of architecture, metastasis, and more common in the body. So it is treated by surgery or systemic therapy. So this is a patient with a large lung mass in the left lower lobe who presented with multiple hypodense lesion, peripherally enhancing lesion in the bilateral liver lobes, and also a large hypodense lesion in the tail of the pancreas. So since the patient was already a metastatic disease, this patient underwent a PET, which had a PET uptake. So the cystic metastasis to the pancreas is less common, but can be seen from lungs, breast, RCC, and ovaries. It's secondary to a necrotic degeneration. And confirmation can be with EUS-guided aspiration or biopsy. And if it is a metastatic disease, it has to be a metastatic disease and hence treated with systemic therapy. So summarizing, whenever we encounter a cystic lesion in the pancreas, we will be asking for a history of pancreatitis or looking for imaging features of pancreatitis. So if the patient has imaging features of pancreatitis, we'll consider it as a sequelae of pancreatitis, either a necrotizing pancreatitis or edematous pancreatitis, and name it as pseudocyst or a walled-off necrosis subsequently. If the history of pancreatitis is absent or any features of pancreatitis is not seen, we consider it as a cystic neoplasm. So in cystic neoplasm, we can try to characterize the cyst further, look for microcystic appearance, that is cyst less than 2 centimeters. If the cysts are less than 2 centimeters and there is no communication with the MPD, there is a cluster of cysts which has a lobulated appearance, enhancing septae, central scar, central calcification, with age group of grandmother. We will be calling it a serous cystic neoplasm. A microcyst with connection to the pancreatic duct will be a side branch IPMN. A cystic neoplasm which has macrocyst more than 2 centimeters, a smooth capsule, age of mother lesion, in a female will be a mucinous cystic neoplasm. A patient with segmental or focal dilated pancreatic duct will be considered a mixed or a main branch IPMN. All these lesions are up to contribute up to the 90% of the primary cystic neoplasms. And the remaining conditions, which are less commonly described, can be suspected in cases where there are clinical suspicion of malignancy, or the presentation can be atypical with lymph nodes or metastasis. And in those patients, we can have an EUS arrow biopsy. So these are my references. I'd like to thank you.
Thank you, Dr. Goldwyn, for that very detailed and insightful presentation. I call upon Dr. Prafulla Kumar Dash, President, ORIA, to kindly felicitate Sir on stage. So as tea is already being served in your places, I'd just like to say, anybody wanting a second helping, we have the tea stall just outside near the registration counter. We will move on to our next speaker, and I would like to call upon Dr. Swati Das, Assistant Professor, Kalinga Institute of Medical Sciences here in Bhubaneswar. Madam is a seasoned academician alongside her interest and expertise in both diagnostic and interventional radiology with an array of publications. We invite her to the podium for her lecture on CT findings of acute small bowel entities.
For your kind introduction. Good afternoon, esteemed guest speakers, organizing team, senior faculties, and my dear residents. So, I'll be presenting on the topic, role of CT in acute small bowel entities. So I'll cover these topics: acute GI bleed, small bowel obstruction, trauma to bowel and mesentery, acute mesenteric ischemia. So, dear residents, do you feel small bowel evaluation is challenging? So, I feel it's little challenging because I know when I scroll up on then with the clinicians want the diagnosis. The patient will be presenting with pain abdomen and they will be eagerly waiting for our diagnosis, and we still can't reach the diagnosis, and I ask my residents scroll and see where is the finding. So we usually means the findings will be subtle as compared to the symptoms. So in many cases, like enteritis cases, we don't get the very subtle finding will be there. Apart from that, because in emergency setting we can't distend the bowel, so it will not be possible to differentiate between true thickening and pseudo thickening because the bowel will be collapsed. So that is another challenge, and many cases differentiating paralytic ileus from mechanical obstruction, it also becomes difficult because we have to go on scrolling and we don't get the site of obstruction. So in that case, whether it is mechanical obstruction or paralytic ileus, so that one again remains a challenge. Out these things. So first is acute GI bleed. We all know these terminologies. The obscure variety, that means there will be recurrent and persistent bleeding. That and in colonoscopy and endoscopy both will be negative, and that fits to the small bowel pathology, in which from the endoscopy route or colonoscopy route site of bleeding. So in that case, feeds to the bleed. So what are the different causes of small bowel bleed? We all know the vascular lesions and tumors. These are the common causes of bleeding. Other less common are trauma, Meckel's diverticulum, vasculitis. Some cases of patients on anticoagulation, they also bleed. And very less commonly, we see autoenteric fistula. So any patient will be coming with GI bleed. If it is hematemesis or melena, first they will undergo endoscopy. Or if hematochezia, they will undergo colonoscopy. So in that, if they gets the bleeder and it is minimal, can be managed with endoscopy, colonoscopy route, there is no necessity of CT angio. But if it is massive and or the bleeder site is not known, then CT angiography has to be done. And after CT angiography, if it is negative, some prefer to go for capsule endoscopy. So sometimes we, in the literature, we read about radionuclide imaging. So what is its role? The advantage is that it can detect up to very less amount of bleed, up to 0.04 ml per minute. This rate of bleed it can detect. But the problem is that it can detect the exact site where it is bleeding, and it's not available everywhere, and it takes a lot of time for imaging. So this is the site of radionuclide uptake, and it is not very clearly seen, but see in the CT, because of high contrast and spatial resolution, the site of bleeding is very clearly seen. So what is the use of CT angiography? So CT angiography localizes the exact site of bleeding. In addition to that, it is a friend of the interventional radiology because it gives the vascular map on the basis of which we can detect, which can plan through which vessel we go and where to target. So it decreases the time as well as the contrast load and the labor for the radiologist. So CT angiography remains the investigation of choice in case of acute GI bleed. Sometimes clinicians call you directly go for catheter angiography without going for CT angiography. So should we do so what is the problem with direct conventional angiography? Because it is one thing, it is invasive. Next is without seeing the vascular map directly, if we go for angiography, there is many chance that we may not hit the target vessel, we may not get the bleeder, and also because it will take longer time to get the bleeder, the contrast load will be much, the radiation dose will be much, and the time will be more consumed. So it's better to go for CT angiography first, then conventional angiography. So what is the protocol? First, non-contrast scan has to be taken, and after that, with pressure injector at a rate of 4 to 6 ml per second, IV contrast is given, and 3 phases has to be taken. Arterial phase, venous and delayed phase, and in most of the institutions they are following the automated bolus tracking method, in which automatically according to the setup, the arterial, venous and delayed phases will be taken. So how the extravasation will be seen? This is very important for the residents because they help us at the night time when a patient comes with bleeder and we get calls where the bleeding site CT angio has been done. If the resident misses the bleeding site, because we always may not be available, so they should know how the bleeding looks. So the bleeding looks like this. This is the arterial phase and this is a late arterial phase. Here in the arterial phase we are not getting anything, and in the late arterial phase here is the contrast pool which is matching the adjacent blood pool. So that means we have to first see the non-contrast phase. If it is not seen in the non-contrast phase, seen in the arterial or late arterial phase, and that is also gradually increasing in the subsequent phases, portal venous and delayed phases, that means that is the bleeding site. So we should not miss the site of bleeding, otherwise the patient, we are not going to help the patient. So pitfalls when we are not going to see the non-contrast, means non-contrast CT scan, if we are missing, these pitfalls may come. Like if there are some high density material like pills, previous CT scan oral contrast is there, or there is high density food, sometimes suture material of previous surgery. If we are not seeing the non-contrast scan, directly we are seeing the contrast scans, and they may be misinterpreted as the site of bleeding. And sometimes even the mucosal enhancement of the collapsed loop, they may be misinterpreted as bleeding. So that means we have to look into all the three phases. Like this is the non-contrast scan. Here in the jejunal loop, we are seeing small hyperdense areas this is in the hepatic flexure, there are small hyperdense areas, and in the arterial phase, it's a little increase in attenuation, and subsequently in the portal venous phase, it is more increased attenuation. So if we are not seeing all the three phases, this subtle bleeding we may miss. So the patient, this is a diagnosis for obscure bleeding. So we have to reach at the diagnosis, then we can manage the patient. So this is a case. Here we can see in the MIP image, there are few serpiginous triangular vessels, and in the contrast, like catheter angiography, we are seeing extravasation. So it's acute ileal bleed, likely due to some vascular lesion. Similarly, this is another case in which jejunum we are seeing a mass lesion, and there is surrounding contrast extravasation. So this is a tumoral bleed. This is another case of RCC. Here there is a tumor, and in this jejunal loop there is tumor within and associated contrast blood extravasation. So this is again site of bleeding. So there are also many bleeds which we cannot detect the cause. So from the history we can find out the cause. Like this is a case of SLE. The patient had SLE, and now we are seeing ileal bleed. So we can't say that it is due to SLE, it's due to vasculitis without taking the history. So history sometimes important to establish the cause. So this is vasculitis associated bleed. This is non-enhancing bowel. And there is associated intraluminal bleed. So this is ischemia associated bleed. And here another bleed in which the patient is under anticoagulation. The patient under dual antiplatelet, and there is bleed. So this is anticoagulation induced bleed. So I had already told this is a rare case, and this case I have taken not from our department, this is from the internet. So here we are seeing there is communication between aorta and adjacent third part of duodenum. So that is aortoenteric fistula, and this is a very emergency condition. It has to be managed. If at the first sitting we are managing endovascularly, but the definite management is by open repair, because more often it will get infected. So the management is open repair for aortoenteric fistula. The patients with bleeding diathesis like hemophilia and other VW disease, etc., they also may have GI bleeds. Like here, the jejunal loops appears to be edematous, and here is a small blus in the mesentery. So this is a patient with bleeding diathesis having bleed. So there are many causes of bleed which we can know from the history, but the important thing is that we should diagnose that there is bleed, because it has to be managed immediately. Next entity, small bowel obstruction. So our ma'am, Natasha ma'am and Anuradha ma'am had already covered many cases of bowel dilatation obstruction, but again I will be going to repeat some cases so that it will be, you will not miss it during your reporting. So for bowel obstruction, abdomen X-ray has only sensitivity of 50%. It will not detect all the cases of bowel obstruction, while compared to that, CT has a sensitivity of 95%. So what are the causes? As we all know, the main causes are hernias, adhesions and tumors. They are main causes of obstruction. Even inflammatory diseases, we see some cases, and apart from that, intussusception, gallstone ileus, these are also cases which we see. Other cases are not very common. So coming to classification, it can be simple obstruction or closed loop obstruction. So simple obstruction again can be partial or complete. The complete obstruction is called high obstruction. So this is a picture in which there is complete obstruction, and this is simple type because we are seeing a single transit at a single bowel loop. And here there is partial because we are seeing some opening in the bowel. So this is partial obstruction, and this is closed loop obstruction. So closed loop obstruction means in a single bowel loop there will be more than one transit point, and when associated with ischemia it is called strangulated obstruction. So what is the utility of CT? First, it will confirm the diagnosis. Apart from that, it will detect the site and cause and the degree of obstruction, and then it will also detect the presence of ischemia. So these are the utility of CT. So the protocol, unlike your CT angio, in CT, like for obstruction, we need not to take the 3 phases, only non-contrast and direct IV contrast with a little lesser rate like 3 to 4 ml per second, and only venous phase will be enough. If dual energy or multispectral energy CT is available, then without non-contrast directly venous phase also we can take, and from that we can reconstruct virtual non-contrast also can be taken. But here we don't have. So why we should not give oral contrast? Because see, without oral contrast we can appreciate the mucosal enhancement, and with oral contrast we are not able to appreciate. And here we can see there is non-enhancement of the bowel wall, and here that non-enhancement is obscured with positive oral contrast. So most of cases of bowel imaging, we should not give positive oral contrast. Only when we are suspecting any perforation or fistulous communication, then only we can give positive oral contrast. So what are the signs of bowel obstruction? Transition point is the most sensitive and specific sign of bowel obstruction. Another is small bowel feces sign, and this collar of pearls or the necklace of pearl sign. This one already we had seen in the previous speaker. So this is your transition point. Here we can see this is the collapsed loop and this is dilated loop. So when we are getting this, that means there is mechanical obstruction. So here this is small bowel feces sign. Like in the ileal loop, we are seeing fecal matter because we always see fecal matter in the colonic loops. Why we are seeing fecal matter in the ileal loops? Because due to prolonged transit, the water gets absorbed. So the content becomes like fecal matter. So this is also another sign of obstruction. So this is a case of simple obstruction by gallstone. This is gallstone ileus. Ma'am has already discussed regular triad. Hope you remember. And this is intussusception. Here we are seeing bowel within bowel appearance or pseudo-kidney appearance. So this is again a case of simple obstruction due to intussusception. What is closed loop obstruction? I already discussed, and it is very like poor prognosis because closed loop obstruction is prone for ischemia. So we should diagnose the cases of closed loop obstruction and inform the surgeon so that they will immediately operate the patient. So how the closed loop obstruction will be seen? So here this is the example of closed loop. This is simple obstruction and closed loop obstruction. Here we can see single transit point, and here multiple transit points in the same bowel loop, giving rise to a U-shaped or C-shaped configuration for the bowel, and they are more prone for ischemia. So this is the C-shaped configuration, and here we are seeing U-shaped configuration of bowel, and this big sign, it's most commonly associated with volvulus. And what is that? This is the gradual tapering of the bowel at the transit point, where at the transition between the collapsed and dilated loop, there will be gradual transition. That is the big sign. And here Weill's sign, which ma'am already discussed, that is because of volvulus. Because of twisting of mesentery, this wild sign comes, and it is usually seen in case of volvulus or closed loop obstruction. So few cases of hernia, like this is ventral hernia. Here we are seeing in the inguinal canal there is a bowel loop. This is inguinal hernia. And here in the obturator fossa we are seeing a bowel loop. This is the obturator fossa. Here we are seeing bowel loop. So this is obturator hernia. So these are the external hernias that will give rise to closed loop obstruction. There are also some cases of internal hernias which is difficult to diagnose and also not common. They are rare. So if comes, how you will diagnose? The most common is left paraduodenal hernia. You have to look whether this is the normal position of the bowel. If a clump of bowel is seen in an abnormal area and there is displacement of the superior mesenteric vessels, then we can diagnose a case of internal hernia. Like this is a case post gastric bypass surgery. Here we are seeing bowel loop just posterior inferior to pancreas, which is not common, and this SMV is displaced towards right. So this is diagnosed as a transmesenteric hernia. This is a paraduodenal hernia. Here in the gastrohepatic region we are seeing jejunal loops, and which is not common. So this is paraduodenal hernia because it's lateral to the duodenum. This is closed loop obstruction from adhesions. Adhesions more often can give, and this is very common, and this can give rise to closed loop obstruction. When we are getting transit point but not getting any cause and has history of previous surgery, then we stamp it as maybe due to adhesion. So we can tell the surgeon it may be due to adhesion. So the patient needs surgery. This is like the big sign due to volvulus. So this is all about obstruction. So when should we worry? If we see a closed loop obstruction associated with volvulus and associated with ischemia. So we have to look for signs of ischemia. If it is there, immediately the patient has to be explored. Like if there is a dilated bowel loop associated with mucosal hyperenhancement. Here we are seeing because of mucosal hyperenhancement there is more pronounced gut signatura, that is mucosa, submucosa and serosa are well delineated. So if this appearance, it is impending infarction. And this is target appearance. It is again because of ischemia, impending ischemia. So there is edematous bowel wall giving rise to thickening and a target appearance. This is also a poor sign that refers to ischemia. And here hypoenhancement of the bowel wall means there is overt infarction and there is possibility of gangrene. And here mesenteric fluid, mesenteric edema, they also come in the setting. Like here we are seeing mesenteric edema, so they also come when there is impending ischemia. And this is like pneumatosis intestinalis, which is seen in case of mucosal necrosis. When there will be necrosis of the mucosa, then air can be seen trapped between the valvuli conniventis, which gives to the pearl necklace sign. So this is the pneumatosis that also shows your infarction. So when we are seeing infarction, we have to immediately inform the surgeon. Next, bowel and mesenteric injury, they are usually accompanied by solid organ injury. So how we can diagnose? If there is discontinuity in the bowel wall or extravasation of intestinal content or oral contrast extravasation or your pneumoperitoneum. So we all know these things, but we need to appreciate them while reporting. So this is a case. Here we can see there is pancreatic injury and associated there is here the ileal wall, there is a breach and there is extravasation of fluid. So and there is also a pneumoperitoneum. So this is a case of bowel injury. Sometimes we only see edematous bowel with fluid, so they are indirect signs of bowel injury. That patient has to be followed up with CT scan or ultrasound to see the size of fluid, amount of fluid, and also clinically. So mesenteric injury, how it will appear? It may appear as a contrast extravasation from the mesenteric vessels, or it can also be seen as mesenteric hematoma with blus. So this can be, this is diagnosed as a case of mesenteric hematoma, and it has to be treated by embolization. So the last topic is acute mesenteric ischemia. As we already discussed, small bowel obstruction can give rise to infarct. Similarly, directly SMA thrombosis also or SMA stenosis can also give rise to bowel infarct. So we have to differentiate between these two entities when we are seeing infarction, whether it is due to obstruction, or so we have to look for the vessels also. So in this case, this is the 3D reformatted image in which there is discontinuation of SMA, means there is SMA thrombosis. So here there is filling defect within the SMA as we see, and the bowel is all the SMA supply, the entire bowel territory is gone, and there is no wall enhancement, there is overt infarction. So the patient has to be immediately undergo surgery. Few rare causes which we have seen, it's a this is a 17-year male. The patient had recurrent persistent bleeding. So the pediatrician became very like, where is the lesion? So they did CT scan, and scrolling all through between these tangled the bowel loops, we get a blind ending structure, and here the wall is enhancing, and there is also some enhancing content within. So we diagnosed likely a case of Meckel's diverticulum, and it was operated, and it was Meckel's diverticulum with ectopic gastric mucosa, and after that the patient became all right. And this is a case in which the patient had severe pain abdomen, and the CT scan just show this much, only dilatation of the jejunal loops, and no wall thickening, no other like site of transition, nothing was there. So just jejunal dilatation. The patient underwent endoscopy biopsy from the duodenum, and it came out to be strongyloid enteritis. So enteritis cases are difficult to diagnose. They are mostly diagnosed clinically in CT scan. The finding may be very subtle, like just dilatation, mild mucosa, like closed spacing of the valvuli conniventis. So these subtle diagnosis may be seen in case of enteritis. So we have two publications. One is this one on the small and large bowel lesions, which we found CT scan is highly sensitive and specific in many small and large bowel lesions, and less sensitive for inflammatory lesions. And in detecting the presence of obstruction, CT is very high sensitive, and only to detect the cause, it is highly sensitive for many causes except for adhesion and stricture, because it will not definitely see the cause in case of adhesion or stricture. That will be exclusion. If no pathology is seen, then we will think that it can be due to adhesion or benign stricture. So finally, while reporting CT of small bowel, we have to report on these headings whether the abnormality is focal, segmental, or diffuse, whether there is wall thickening or thinning, if it is, how much and what is the length. We have to look for the enhancement pattern, and whether it is mechanical obstruction or ileus, how to differentiate. If we are seeing rectal gas, then we can think that it is ileus. If we are not detecting rectal gas, it means without trying much, if we see rectal gas, then it is ileus. And pneumatosis, we have to look for pneumatosis, and adjacent areas, if any extraluminal gas, fluid, or lymphadenopathy stranding. On these headings, we should report CT of small bowel. Thank you.
Thank you, Dr. Swati, for the wonderful talk. I now request Dr. Natasha Gupta to kindly felicitate Madam. Dr. Goldwyn will now be back on stage for his session on the current role of imaging in diagnosis and detection of complications of inflammatory bowel diseases.
We'll discuss about inflammatory bowel diseases. So, this is a chronic relapsing inflammatory disorder of gastrointestinal tract. There is usually bimodal distribution, 20 to 40 years and after 60 years. The etiology is usually multifactorial. Pathophysiologically, we can differentiate it into Crohn's disease and ulcerative colitis. So Crohn's disease can involve the entire gastrointestinal tract from mouth to the anal canal. There is a skip segment involvement, transmural involvement. In active disease, there is inflammation of bowel with So fibrostenotic disease, there is fibrosis of the bowel wall with complications like stricture and fistula. So as against this ulcerative colitis, it is more of a mucosal lineal ulcers with contiguous involvement, commonly involving colon and the terminal ileum. It's more prone for malignancies. So what is the role of imaging in IBD? So we will be assessing the bowel inflammation activity, whether the disease is active or inactive, and the extent of bowel involvement. We will detect complications, follow-up and treatment response, and help in differentiating in some cases where Crohn's disease and ulcerative colitis is a confusion. So we resort to multimodality imaging approach, and we take in the recommendations from European and American societies. So in cases with low index of suspicion, the first will be a colonoscopy or an intestinal ultrasound. If there is some abnormality detected in colonoscopy or an intestinal ultrasound, we will be resorting to MRI enterography, MR enterography. In perianal diseases, MR pelvis is the best modality. We will do a fistula protocol. In treatment follow-up and post-operative cases, MR enterography is considered best. So while discussing the modalities, fluoroscopy can help in dynamic evaluation, but the wall evaluation is difficult with fluoroscopy, and there is a risk of ionizing radiations. Ultrasound is by far has lot of potential capabilities in IBD. We are able to see the lot of abnormalities, including the bowel wall thickening, complication, fistula, and collections. But it is, has a learning curve, operator dependent, and difficult in obese patients. Enterography is useful in emergency setting like perforation. As the previous speakers mentioned, in bowel obstruction, CT enterography is contraindicated unless there is a subacute or a chronic obstruction. CT is better for extra-intestinal complication visualization. The limitation here is ionizing radiation. Most of these patients who are diagnosed are going to be young patients who will require lifelong follow-up. So repeated CT exposure can add up the radiation and increases the risk of radiation-induced risks. So the protocol we follow is with PEGLEC. We give itopride in 2 liters of water with PEGLEC. We give 1 liter over 30 minutes, then injection buscopan, 500 ml over the next 15 minutes, and we do arterial and venous phase. So MR enterography, it's superior soft tissue resolution, and the one more added advantage is we will be able to differentiate whether the disease is active or inactive. We'll be able to differentiate whether the thickening is because of edema, fibrosis, or fat. So the protocol in MR is almost similar to CT. Only difference we follow is the buscopan injection is given just before the contrast injection. The sequences acquired are T2 axial and T2 fat suppress images, which can help us identify the wall thickening and also decide on whether the lesion is, whether the thickening is active or inactive. DWI sequences, which can be useful to identify the bowel which is abnormal. Cine sequences are very useful in differentiating peristalsis from a stricture. Post-contrast imaging also is useful for the extent of the disease and also to identify the activity. So I like to describe the imaging features with the following headings. This will be useful in remembering the titles. So inflamed mesentery, bowel wall changes, and disease complications. So under inflamed mesentery, we will be dealing with fat changes, engorged vessels, and lymphadenopathy. In bowel wall changes will be thickening, stratification, and permanent structural changes. Disease complication can be intraluminal and extraluminal. So intraluminal will be strictures, dilatation, and neoplasm. Extraluminal is going to be fistula, abscesses, and perforation. So imaging features. So we have a patient with ultrasound showing bowel wall thickening and hyperechoic fat in the adjoining areas. This is mesenteric fat stranding. So this is an active inflammation marker. We have a patient CT where there is bowel wall thickening. We are able to see the mucosal enhancement, submucosal hypodensity. In the CTs, any hypodense thickening of the submucosa can be because of edema, fibrosis, or fat, which cannot be differentiated. So in this patient, we see the fat adjoining this bowel loop to have increased attenuation compared to the subcutaneous fat, which is a sign of mesenteric stranding, which is a feature for active inflammation. In MRI, it can range from a mild increase in attenuation to a altered signal. So next will be fat proliferation. So we have a patient with asymmetric proliferation of fat along the bowel wall with increased spacing of the bowel loops. So this is called the creeping fat sign or a fat dropping sign. So we can call this to be positive when there is stranding involving more than 180 degree in axial views. In MR, this fat can have a low signal intensity compared to the rest of the normal fat. So fibrofat proliferation is a chronic and inactive inflammation marker. Next is engorged vessel. This is a patient CT which shows a bowel wall thickening and enhancement. We see increased prominence of the mesenteric vessels suggestive of hyperemia, which is called the Combs sign. In this patient, another patient, we have the trophy sequences showing the Combs sign better. So Combs sign is a sign for bowel hyperemia and definitely an active inflammation marker. So we have a patient where there is a asymmetrical bowel wall thickening involving the mesenteric side of the bowel loop with Combs sign and few homogeneously enhancing small lymph nodes, which are up to 3 to 8 millimeter in size. So this is a mesenteric lymphadenopathy. It is always remember that these lymph nodes are small, less than 10 mm, and they are homogeneously enhancing. If there is size more than 10 mm or appearing heterogeneous, definitely alternate diagnosis needs to be considered. So lymphadenopathy is a feature of active inflammation. So we'll move to the bowel wall changes. First, we will ascertain whether the bowel wall is thickened. All my previous speakers have dealt with this extensively. So the bowel wall thickening is like more than 3 mm. In MR, we will choose a T1 post-contrast or a T2 non-fat suppressed sequence for assessing the bowel wall thickening. After confirming bowel wall thickening, we will attempt to graduate the thickening. 3 to 5 is mild, 5 to 7 mm is moderate, more than 7 is severe thickening. After graduating the thickening, we will try to assess what is the cause for the thickening. So whether it is because of edema or fibrosis or fat. Then we will go about how the thickening appears, whether it is homogeneous or bilaminar or trilaminar or it has fat. So while assessing the bowel wall composition, it can be, as we earlier discussed, it can be because of edema, fibrosis, or fat. We will be interested in T2 and T2 fat suppressed sequences. So if it is, whatever is bright in T2 will be fluid and fat. So if it is bright in T2 and bright in fat suppressed as well, it is going to be edema. It is bright in T2, suppressed in fat suppressed sequences, then it is going to be fat. It is hypo in both, it is going to be fibrosis. So we'll go about trying to decode this in the subsequent images. So edema is going to be active inflammation, fibrosis and fat is chronic inflammation. This is a patient showing bowel wall thickening. This is the submucosal thickening, which has T2 hyperintense signal. The spare images also shows a hyperintense signal with fluid in the perienteric region. suggestive of edema. This is an active inflammation. We have another patient with bowel wall thickening showing T2 hypointense thickening, which is not bright in spare as well, which is fibrosis. This is a fibrotic stricture, which is chronic inflammation. We have a bowel wall thickening with T2 hyperintense signal, and corresponding area looks hypointense in fat suppressed sequences, which means this is fat infiltration, and again a chronic marker. So next we will talk about the layering. So we are worried whether the bowel stratification is maintained or it appears homogeneously thickened. So if the bowel is homogeneous with contrast enhancement, it is active disease. If it is homogeneous without a contrast enhancement, it can be either active or inactive. So we have a patient whose CT shows bowel wall thickening, straightening of the mesenteric border, pseudocirculations in the anti-mesenteric border with a homogeneous enhancement, suggestive of active Crohn's disease. So next will be a bilaminar stratification. Here we have a patient who has asymmetrical bowel wall thickening with luminal narrowing and a mucosal hyperenhancement. And the submucosa is thickened with hypodense signal, giving a bilaminar appearance. So this sign is non-specific. However, mucosal hyperenhancement in IBD diseases are considered as active diseases, and an MRI can help us better identify whether the submucosal thickening is related to edema or fat. It is an active inflammatory marker, as we said. So next we will go to the trilaminar appearance. This is a patient CT showing a enhancing mucosa, submucosa which appears hypodense with enhancing serosa. Again, in the MRI, similar appearance. We are again stuck with the same thing. Mucosa is enhancing, submucosa hypodense with enhancing serosa. So most commonly, this is considered as active disease because of mucosal enhancement, but MRI can definitely help us better whether this is acute on chronic or just acute disease. So the next fat halo sign is this. This is same as earlier. There is fat in the submucosa. It is a chronic inflammation. So there can be permanent bowel wall changes like decrease in the folds in the ileum and a lead pipe-like appearance in ulcerative colitis. We have a long segment of bowel wall thickening with ahostal appearance in the patient with mild increase in vascularity. So this is a Crohn's disease with lead pipe colon. We are moving into the disease complications. First, we will be dealing with the strictures. Stricture is a bowel wall thickening causing luminal narrowing. 25% of chronic disease, Crohn's disease patients have strictures. So always when we are suspicious of a stricture, definitely go through the rest of the sequences so that this bowel segment has to be collapsed in all the sequences. And Cine MRI sequence is very useful to confirm a stricture. So we have a patient who has presented with a bowel obstruction. We have a segment which has luminal narrowing, enhancement of the mucosa with thickening of the bowel wall. So considering the bilaminar enhancement, this is considered as an active Crohn's disease, and this patient might benefit from anti-inflammatory therapy. The other patient with thickening of bowel with the proximal dilatation, however, the signal is T2 hypo, suggestive of fibrosis. This patient might not benefit much from an inflammatory therapy and might require a dilatation or a resection. Next are fistulas. Fistulas are permanent abnormal passages between two organs. So in this patient, we have a stellate-shaped enhancing fistulous communication between the large bowel loop and small bowel loop, suggestive of a Crohn's fistula. Fistulas are considered active disease and seen in up to 20 to 40% of the Crohn's disease patients. Another patient with an enhancing fistula communicating from large bowel to the small bowel loops. So any patient with active fistula, fistulizing Crohn's, has an increased risk of developing an abscess. This is a patient with asymmetrical thickening, bowel wall enhancement, and enhancing fistula between the descending colon and ileal loops with a hypodense collection which is peripherally enhancing, extending up to the left psoas muscle. This was an abscess secondary to the fistulizing Crohn's disease. So as other abscesses, they have a central diffusion restriction. In these patients, the radiologist might be of help in percutaneous drainage for these patients. Next is malignancy. All ulcerative colitis patients have 8-fold increase in malignancy risk, and Crohn's disease 4.5-fold increase in malignancy risk. We have a patient with long segment bowel wall thickening and asymmetrical thickening involving the colon, and the biopsy showed adenocarcinoma. So apart from adenocarcinoma, Crohn's disease patients, patients with IBD are in risk of lymphoma, melanoma. Next complication is toxic megacolon. As ma'am discussed earlier, patients with ulcerative colitis can present with a non-obstructive colonic dilatation. They are usually associated with systemic toxicity like fever. We have a patient with ahostel appearance of colon and dilated bowel loop who had systemic features and was diagnosed as toxic megacolon. Remember, this is non-obstructive. We'll go into the extraintestinal manifestations. Primary sclerosing cholangitis has a strong association with ulcerative colitis. So up to 75% of patients with primary sclerosing cholangitis have coexisting ulcerative colitis. The reverse is not true. So we have a patient with multiple strictures and dilated intrahepatic biliary ducts and a cutoff at the right hepatic duct. This patient had a cholangiocarcinoma with a primary sclerosing cholangitis. So next is autoimmune pancreatitis. We have a sausage-like appearing bulky pancreas, lost lobulation with hyperdense thickening, suggestive of an autoimmune pancreatitis. There is also association with seronegative spondyloarthropathies, stir images showing subchondral edema on the right side and fat replacement in the left side, suggestive of acute and chronic spondyloarthritis. This patient also had IBD. So moving on to the differentials, the most common differential in India will be tuberculosis, and definitely we are expected to know the differences. So involvement will be Crohn's, any bowel from mouth to the anal canal. Here it is mostly cecum, terminal ileum, and the IC valve. IC valve is damaged. IC valve can be patulous, involved in tuberculosis. Strictures are focal segmental strictures. In Crohn's, it is a segmental stricture, which is a long segment. Skip lesions are common in Crohn's, uncommon in TB. Mural enhancement and stratification more common in Crohn's. Enteroenteric fistula more common in Crohn's. So ascites, peritoneal thickening, and mesenteric nodes, which are larger and necrotic, will be a very helpful point to differentiate TB from Crohn's in some cases. So the diagnosis is based on multiple parameters: biochemical, clinical, endoscopic findings, and radiology. Colonoscopy and biopsy will be the gold standard finally. So the treatment is going to be, we are going to segregate the disease into active and fibrostenotic. Active disease patients will benefit from anti-inflammatory drugs, steroids, immunomodulators, and biological therapy. Chronic patients are going to go in for a surgery or a lifestyle modification. A few words on post-treatment assessment. So while follow-up imaging, we see a normalization of the imaging findings. We'll call it as a transmural remission. So there is a clear decrease in the disease. It's called response. There is no appreciable change. It is stable disease. If there is deterioration, it is called a progression. So we will quickly go through the take-home points. So how to differentiate Crohn's disease from ulcerative colitis? So dilatation of vasa recta, Crohn's sign can be seen in both, but fibrofatty proliferation is more common in Crohn's disease. Mural thickening, stratification can be seen in both, but mucosal thickening is going to be significant, more than 11 to 13 mm in Crohn's disease. It is going to be eccentric. It is discontinuous with skip segments in Crohn's disease, whereas symmetrical and continuous in ulcerative colitis. So ulcerative colitis is going to involve only colon and terminal ileum, whereas Crohn's can involve the entire bowel intestine. So disease complication, fistulas and abscesses are more common in Crohn's. Ulcerative colitis present with toxic megacolon. So few points how to differentiate an active and inactive disease. Engorged vessels, COMSIGN, homogeneously enhancing small nodes, lymphadenopathy. Fat standing is going to be a sign of active disease. Fibrofatty proliferation, which is creeping fat, is going to be inactive disease. Mural thickening and stratification, mucosal enhancement, submucosal edema are going to be active disease. In inactive, homogeneous wall thickening without an enhancement, loss of hostrations, submucosal fat and fibrosis are inactive disease. So in complications, abscesses, fistulas, and toxic megacolon are signs of active disease. Stricture is more commonly associated with inactive disease. So always remember to start with these points, and these are my references. Thank you for the opportunity.
Thank you, sir, for expanding our knowledge on IBD. Up next, we have Dr. Sanket Dash, who will talk about the imaging of non-compressive myelopathy. Dr. Sanket has trained at VMMC Safdarjung Hospital, New Delhi, with further specialization in neuroradiology from PGI Chandigarh. He is an assistant professor and is the in charge of neuroradiology and neurointerventions at NIMS Medical College, Jaipur. I request sir to please take the dais.
Very good morning, everyone. Thank you, organizers, for giving me this opportunity. So I will be deviating from the topic of the session. It was mainly for the gastropathologists and the GI radiology. But in my session, in 2 of the sessions, we will be discussing something different about neuroimaging. So the first talk is about imaging in non-compressive myelopathy. So in the next 20 minutes or so, we will be discussing about non-compressive myelopathy and how to differentiate it from the compressive causes. We will also try to outline an MRI-based diagnostic approach, basically for the residents. Then we will review major etiologies and their characteristic imaging findings. And finally, we will also highlight the key pitfalls and pearls for the daily practice, so basically for the residents. So what is non-compressive myelopathy? So non-compressive myelopathy is, excuse me, sorry for the interruption. Can you please see? So sorry for the interruption. So non-compressive myelopathy is basically spinal cord dysfunction, which is caused by either intrinsic or extrinsic process without any mechanical compression. So it can be because of, I think the screen is going off repeatedly. Okay. It can be because of several causes, including inflammatory, vascular, metabolic, toxic, infective, or neoplastic etiologies. So clinically, the patients usually present with either motor or sensory impairment and often associated with bowel and bladder symptoms. So before jumping into looking at the images of any patient having a myelopathy symptoms, we must look at the clinical symptoms and basically the time course or time duration of the symptoms, whether it is hyperacute or chronic. This is very, very important for further characterization and subdivision of the further differential diagnosis. So the causes of non-compressive myelopathy, as I have already discussed, can be vascular, inflammatory, infectious, metabolic, neoplastic, or radiation-induced, or several miscellaneous causes like SLE and sarcoidosis. Now, let us, before going further into details, let's discuss this simple patterned approach. So this is basically taken from an article of Radiographics. So this is an approach to T2 hyperintensity of spinal cord. So whenever you are looking at T2 hyperintense lesion in the spinal cord, so first thing to do is to exclude an artifact, because often several artifacts can give rise to an T2 hyperintense appearance. So you should not misinterpret them as lesions. They are, so we will also see what these artifacts are. So after you have excluded an artifact and you have confirmed that it is a true lesion, not a false lesion, so then you have to try to differentiate it as compressive or non-compressive. And in the non-compressive group, clinical evaluation is very important. You should look at the duration of the symptoms, whether it is an acute or a non-acute cause. And the acute onset of symptoms, you should look at the lesion pattern, whether there is an expansion of the cord or it is a non-expansile lesion. And then the acute causes can be demyelinating, infarct, or infection. And in all the three cases, you can get some degree of expansion, or it may not be having any expansion. In the non-acute group, again, expansile lesions are mostly neoplasms, whereas the non-expansile can be metabolic, neurodegenerative, inflammatory, HIV-induced causes, and other causes. So this is a very simple patterned approach for T2 hyperintensity of spinal cord. Especially helpful for the residents. So before going into the detail, what is the basic protocol that we follow for the MRI evaluation of a non-compressive myelopathy? So apart from the routine sequences like the SAG, T1, T2, STAR, and the axial sequences, sometimes contrast is especially useful, particularly dealing with either compressive or non-compressive myelopathy. Contrast enhancement can give further clues, so contrast is our friend here. So you have to use contrast enhancement. Also, diffusion and gradient sequences can be added upon, particularly if specific pathologies are suspected, like if you are suspecting an infarct. Diffusion weighted imaging is very, very useful, and also gradient echo sequences when you are suspecting hemorrhagic causes of the spinal cord. Angiography can be added upon if you are suspecting a vascular cause. So in the angiography, by angiography, I mean a time-resolved MR angiography, which is basically known as either a TRIX or a twist sequence. So a time-resolved MR angiogram is helpful when you are suspecting vascular causes of non-compressive myelopathy. So the technical tips here are, you have to take up thin slices, always conus, you should look at the conus, and motion artifacts. Very, very important to reduce the motion artifacts. So the first point, as I've already told, is to exclude the artifacts. So the artifacts in spine imaging can be, most importantly, is the Gibbs truncation artifact, or it can be several motion artifacts due to the respiratory or the vascular pulsations. It can be due to CSF pulsation artifacts or susceptibility artifact due to metallic implants. So like this, so what is a Gibbs truncation artifact? Basically, it is an artifact that occurs whenever there is a interface between two highly differentiating signal intensity substances, like at the interface of your gray matter and the CSF, because of the inverse Fourier transformation in the K space. These kind of artifacts usually occur. So you can see this kind of linear T2 hyperintensity, which is basically paralleling your interface of the gray-white CSF and the gray matter. So this is not a true lesion, but this is artifact. This is Gibbs truncation artifact, and you should not misinterpret it as a hyperintense lesion of the spinal cord. Then what are these? These kind of T2 hypointensities in the posterior CSF space. These are nothing but your CSF pulsation artifacts. So you should not misinterpret them as something flow voids or abnormal lesion in the spinal cord. This is often misinterpreted by our residents. So you should know that this is CSF pulsation artifact. Okay. So motion artifacts, so proper saturation band is necessary to reduce the motion artifacts due to the vascular pulsation from the aorta. Then metallic susceptibility or magnetic susceptibility artifacts, as we all know, there are several other different softwares for that, and also spin echo sequence is definitely better whenever there is implant in the vertebral bodies. So the first thing to decide is the time course of the disease, whether it is acute, subacute, or chronic. Then there are several things that you should look at the imaging. So before jumping into the imaging, you should look at the clinical feature, acute, subacute, or chronic. Then in the imaging, you should look at the lesion length, whether it is a short segment lesion or a long segment lesion. In the myelopathy, long segment lesion means more than or equal to 3 vertebral level involvement, what we classically describe as a longitudinally extensive transverse myelitis. Then comes the cross-sectional pattern, whether it is central, dorsal, or peripheral. Then comes the enhancement pattern. What is the pattern of enhancement, whether it is enhancing or non-enhancing, and then associated features like flow void or cord expansion. So based on these things, we will try to differentiate we will try to devise the differential diagnosis for these kind of lesions. So just looking at the patterned approach for the cross-sectional appearances. So if there is central cord is predominantly involved, it can be inflammatory causes like NMO or ADEM. It can be systemic inflammatory diseases like SLE, Sjogren's. It can be idiopathic transverse myelitis, various infections, or even radiation-induced myelitis. Then peripheral wedge-shaped lesions. The most important diagnosis is multiple sclerosis. Central gray matter involvement is infarct, dural AVA for AVM, or compressive myelopathy. Dorsal column involvement, vitamin B12 deficiency, most common cause, but other causes can also give this kind of appearance, like your zinc or nitrous oxide toxicity, copper deficiency, even autoimmune causes. And another important cause is HIV vacuolating myelopathy. So this gives similar appearance to your vitamin B12 deficiency with dorsal column involvement. Then anterior horn cell involvement, classically infarct, infarcts, basically the watershed pattern of infarct, infections like polio or enterovirus involvement, and post-vaccination myelopathies. So diagnostic algorithm for these kind of non-compressive myelopathy, as I have already told, first determine the onset of the disease, then you see the MR pattern analysis, and finally you can go for correlation with the other tests like your serum analysis and all. So let's discuss some common pathologies. So first important cause is vascular causes, that is spinal cord infarct. So the classic presentation in these kind of cases will be hyperacute onset and often associated with a severe back pain. So these patients will have severe back pain followed by flaccid paralysis and a very hyperacute onset. On imaging, you can get the central or anterior two-third T2 hyperintensity and diffusion restriction. So if you are suspecting a vascular cause, if this kind of history is there, you should always add diffusion weighted imaging to your routine sequences to exclude the cause of spinal cord infarction. And owl's eye appearance or the anterior horn cell involvement basically because of the watershed pattern of infarct. So as we know, there are two important territories of the spinal cord, the anterior spinal artery territory and the posterior spinal artery territory. So anterior spinal artery affects the anterior horn and the surrounding white matter. So owl's eye sign will be there when there is ASA infarct. Whereas posterior spinal artery infarct is very, very rare, but if it occurs, then dorsal column and posterior horn involvement can also be there. Okay. So what are the common etiology of spinal cord infarct? In what setting you will suspect a spinal cord infarction? Basically after aortic surgery, hypotension, embolic etiologies or even dissection. So vertebral artery dissection is one common cause where you can have this involvement of ASA and get spinal cord infarcts. Another important thing that we very often see as a clinical or interventional radiologist is post-bronchial artery embolization because of the involvement of artery of Adamski's. So you can get complication as spinal infarction. So let's see one case. So you can see subtle expansion here in the cord and some subtle hyperintensity on the T2 weighted sequence, but it is not very evident. But this patient developed complete paraplegia after bronchial artery embolization. Now let's see the diffusion. So we added the diffusion. So in diffusion there is subtle, I know it's very difficult to interpret spinal diffusion images, but you should always look at the ADC maps. So in ADC you can see that there is, this area is more darker compared to the other areas of the spinal cord, right? So there is diffusion restriction here. So there is a subtle abnormality on T2, but diffusion restriction on DWI. So this was a case of acute spinal infarction. This was following bronchial artery embolization, basically because of involvement of artery of Adamski's. Now, second important cause is your inflammatory demyelinating myelopathies. So among the inflammatory demyelinating lesions, the three important pathologies are multiple sclerosis, NMO spectrum disorder, and the Mogard spectrum. So you have to know the pattern of involvement of spinal cord in all the three and try to differentiate them. So basically MS is short segment lesion, less than 3 segment, and usually peripheral or posterolateral, as we have already seen in the cross-sectional pattern. Then NMO usually is a longitudinally extensive, more than or equal to 3 vertebral levels, and commonly involves your central gray matter, whereas Mogard usually can be either long segment or short segment, but conus medullaris is often involved in Mogard cases. And it can be either central, dorsal, or even symmetric. Then enhancement, MS can have enhancement, particularly in the acute phase of demyelination. NMO usually shows enhancement, can have homogeneous enhancement or patchy enhancement both. Then important is to look at the brain and the optic nerves. So brain lesions in MS usually are mostly, you know, all of you know, that is periventricular, typical Dawson fingers. NMO, you will have this area postrema involvement, hypothalamus involvement, and aquaporin 4-channel distribution, so mostly periventricular lesions. And Mogard can have involving your deep gray matter as well as the posterior fossa. Most importantly is, do not forget, is the middle cerebellar peduncle. So if you have lesions in the MCP and these kind of spinal cord lesions, you should suspect Mogard. So let's see some cases. So this was a 40-year-old female who presented with left upper limb monoparesis. So on spinal MR, you can see this short segment lesion in the cervical cord. And on axial section, you can see this wedge-shaped peripheral region here. And it also shows some degree of diffusion restriction. When we did the brain imaging, you will see these kind of lesions in the periventricular region with involvement of your callosocceptal interface as well. So classic Dawson finger appearance. So this is a classical case of multiple sclerosis. Next, another case, this is basically a 8-year-old male who presented with acute to subacute onset of paraplegia. Patient was completely paraplegic when presented. So this is the spinal cord MRI. You see this long segment T2 hyperintensity. Some degree of expansion is also present. The hyperintensity is extending almost up to the level of the conus. So conus is also involved. And on axial, you can see that there is involvement of this gray matter. So it looks like your letter H, right? So this is H sign due to the involvement of the gray matter. So this is a classic case of MOG associated demyelination. So this is a case of MOGAD. I have not shown the contrast here. So on contrast, MOGAD can show enhancement, but enhancement is variable. It can be patchy, it can be complete enhancement, and there can be also some degree of leptomeningeal enhancement in MOGAD. Now another case, you can see that there is again longitudinally extensive transverse myelitis, more than 3 segment involvement. Contrast, you can see some patchy enhancement here. Okay, some degree of expansion is also present in the cervical cord, but at the same time you see the optic nerves, we see bilateral optic neuritis. So this is a case of NMOSD. Another case, again a young child presented with, this is 7 days post a fever, patient presented with paraplegia and altered mental sensorium. So spinal cord shows this longitudinally extensive transverse myelitis pattern. At the same time, brain shows multiple large T2 hyperintense lesions, including involvement of the posterior fossa. So this is ADEM, and definitely it can be MOGAD also. If testing is done, half of these patients turn out to be MOG positive. So this is very, very important differentiating table or picture. So spinal cord involvement in NMO can be is longitudinally extensive with central cord involvement. MOGAD, usually conus involvement, similar pattern of axial section. MS, multiple short segment and patchy peripheral involvement. At the same time, you should not forget the brain and the optic nerve findings to help differentiating these kind of pathologies. Another case, so sometimes longitudinally extensive transverse myelitis need not be differentiated into these 3 pathologies only. Sometimes we do not get any etiologies also, and we label them as idiopathic transverse myelitis. So this is another case of transverse myelitis, involvement of the central cord, but NMO was negative, MOG was negative, so this is idiopathic transverse myelitis. So this already I have told, LETM with more than 3 vertebra involvement, central lesion, expansile lesion is NMOSD. One sign has been described. This is not very useful clinically, but again, academically it is important. So on axial sections, you can get bright spotty lesions. I don't find this very useful for routine practice, but again, academically, this has been described. MOG, often conus involvement, marked swelling and enhancement. So these 2 entities you should try to differentiate on imaging. Next comes the infectious myelitis. So infections can be TB, viral, all, even fungal and bacterial can involve the spinal cord, except in TB, we all know that is spondylodiscitis. So most common spinal pathology in TB is a compressive myelopathy because of the spondylodiscitis. But sometimes non-compressive myelitis can also occur without visible spondylodiscitis in TB. So this is one case of a child. You can see that there is some long segment hyperintensity with these abnormalities. At the same time, we give contrast and we see this abscesses within the intradural sac, which is also showing diffusion restriction. So basically this is a pyogenic involvement with intradural abscesses. So this was secondary to an infected dorsal dermal sinus. Viral myelitis can be long segment or short segment. So this is a case of varicella myelitis. You can see this central involvement of the cord with a longitudinally extensive pattern. Another case, this is a case of classical case. This is a spotter. So this patient had a dog bite. So post dog bite, patient having flaccid paralysis, altered sensorium. So what you see, longitudinally extensive pattern of spinal cord involvement. At the same time, look at the brachial plexus. It is enhancing and thickening. And look at the brain. You are seeing bilaterally symmetrical involvement of the basal ganglia and thalamus. So this is a classic. Any diagnosis? So this is rabies. This is rabies. This is paralytic pattern of rabies. So this is another case. See again, I will not tell the history, you have to tell the diagnosis from the imaging. So this is long segment hyperintensity patchy involvement. On axial, you see posterior column involvement. So what is the diagnosis? So subacute combined cord degeneration. But I will tell you this patient was HIV positive with a low CD4 count. So what is the diagnosis now? So it is HIV vacuolating myelopathy. So it is a differential for vitamin B12 deficiency. So pattern of involvement is similar, but history is important. So the nutritional metabolic causes, vitamin B12 deficiency, copper deficiency, nitrous oxide toxicity, they all present with posterior column involvement like this, posterior column involvement. This is case of subacute combined cord degeneration. Important to recognize them because it is completely reversible. So after vitamin B12 therapy, even the hyperintensity goes away. So last but important topic not to miss is spinal vascular malformations. So the classic history will be a middle-aged patient and a patient presenting with progressive myelopathy. Often they have a waxing waning course. That means there will be some time improvement, then again worsening, and they will be having often sphincter issues, bowel bladder involvement. So MR, what you will get is a long segment hyperintensity with some degree of cord swelling and serpiginous flow voids on the dorsal or the ventral surface of the spinal cord with patchy enhancement. So then you have to suspect spinal vascular malformations. So spinal vascular malformation on MRI, there is you should always add few sequences, that is a time-resolved MR angiogram, that is tricks or twist, and then followed by catheter angiography, which is the gold standard. Often MR may miss these kind of lesions, so whenever you are thinking in a middle-aged patient, there is some unexplained kind of myelopathy, these patients, you should think that underlying vascular malformation may be present, and they should undergo a spinal angiogram, catheter angiogram, which is the gold standard for the diagnosis. Because this is treated by if treated by endovascularly or surgically, they can be also cured. So spinal vascular malformation, I know it is a very difficult topic for the residents, but I will try to simplify the spinal vascular malformation for you. So basically there are 4 important types. So 4 types, it is either arteriovenous fistula or arteriovenous malformation. Now remember, type 1 and type 4 are fistula. Type 1 is dural fistula, whereas type 4 is perimedullary fistula. So type 1, where the fistula will be, the fistula site is at the level of nerve root sleeve. So basically it is dural fistula between the radiculomeningeal artery. Remember, it is the meningeal artery and fistula's communication with the perimedullary vein. So the location will be along the nerve root sleeve, which is just behind your pedicle. Type 4 is perimedullary arteriovenous fistula, which is the communication between the spinal artery, that is ASA or PSA, with the perimedullary vein. So here the fistula will be either on the anterior or on the posterior surface of the spinal cord. Then type 2 is basically an arteriovenous malformation of the spinal cord. So you will get a nidus within the substance of the spinal cord. And type 3 is the juvenile type, where you will get this intramedullary AVM with extension into the adjacent epidural and extradural compartment. So this is spinal metameric lesions. So it is common in the children and associated with various kind of syndromic causes. So what we see commonly clinically on imaging is 1, 2 and these 3 types. So basically either fistula or a glomus avium. So let's see some cases. So this is another case, again middle-aged patient having a hyperintensity in the spinal cord. But what you see here, some T2 hypointense serpiginous flow voids on the posterior surface of the spinal cord. Again, even in the conus, and you can see that on the axial section as well. So we performed DSA. Now what we find here, this is DE11 intercostal artery run, and you see that these are the meningeal, radiculomeningeal branches, and there is a fistulous communication here. So this is at the level of nerve root sleeve, and this dilated structure is the vein. This is the perimedullary vein. So there is a fistula between the radiculomeningeal artery and the perimedullary vein. So this is spinal dural arteriovenous fistula. So now these patients, the hyperintensity in spinal cord is because of 2 causes. One is the congestive cause because of the engorged veins, and secondary can be compressive because of the very much dilated veins. So both compressive and non-compressive causes are responsible for the T2 hyperintensity. Another case, you can see this long segment hyperintensity in cord, and at the center you see some T2 hypointense lesion here. So this is basically a glomus avium. So this is the DSC. You can see there is a nidus here. So there is a nidus within the spinal cord. This is the anterior spinal artery that is supplying the nidus. And this is the dilated perimedullary vein which is draining from the nidus. So this is basically a spinal cord glomus avium. Then another case, long segment T2 hyperintensity of the spinal cord. And you can see some enhancing flow voids, but not on the posterior surface, but more on the anterior surface. So on DSA, what you see, this is the anterior spinal artery, and this is your vein. So there is a fistula. So can you identify the fistula? So the fistula is here. Basically, there is a change in the caliber between the 2 vessels. So this is artery, this is vein, and this is the fistula. So this is spinal perimedullary AVF, and this has been treated with glue embolization, and this is the post-embolization picture. So these patients greatly improve after the embolization. So other causes can be like radiation, paraneoplastic, and the tumors. So tumors, as we all know, it can be intramedullary, it can be intradural, extramedullary, or extradural in nature. So you should remember that there is expansion of the cord in the intramedullary pathology, whereas there is compression of the cord in the extramedullary pathologies. So the important points here is the cord expansion, enhancement, and associated cysts. That is the three important hallmarks of a intramedullary tumors. So some cases here, again, central lesion with long segment hyperintensity, very much enhancing. On axial, it is central in nature. So what is the diagnosis? This is an intramedullary tumor, which is ependymoma. Another case, again, long segment hyperintensity, some degree of enhancement, but on axial it is mostly paracentral. It is not central, it is paracentral. So what is the diagnosis? Astrocytoma. So another case, long segment hyperintensity of cord, but on axial you can see multiple enhancing nodules and some increased flow voids also. And on cerebellum also you are seeing this enhancing nodular lesion. So what is the diagnosis? Spinal hemangioblastoma. So can you name the syndrome which is associated with this? It is a case of von Hippel-Lindau syndrome. So this is a very, very useful approach to the non-compressive myelopathies. Most of it I have already covered. So basically, first you, after excluding artifacts, you should rule out the compressive causes, and once you have confirmed the non-compressive, you should look at the course, whether it is acute or subacute. In acute, again, short segment or long segment, and then try to devise the differential diagnosis. Similarly, in subacute, again, expansile or non-expansile. Expansile is usually neoplasm. Non-expansile is usually all the other causes. Then again, you should look at the length of involvement and try to devise a differential diagnosis. So this is the same thing. So take-home messages is that MR pattern recognition with the time course of disease gives you the diagnostic power, and always rule out the compression and vascular causes first. LETM requires comprehensive serologic and CSF evaluation. So it is not always NMO or MOGAD on a single MRI. It is always the serological and CSF evaluation. Early treatment can prevent the irreversible cord damage. So we should try to help the clinicians by giving an important differential diagnosis so that they can target the therapy treatment approach according to the differentials. So thank you very much. For any further queries, you can always contact me. Thank you.
Thank you, Doctor, for an excellent presentation. I call upon stage one of our veteran professors, Dr. B.B. Dash, to kindly felicitate Dr. Sanket. For our next topic, I'm pleased to invite on stage Dr. Tara Prasad Tripathi. He is an assistant professor and an interventional radiologist at IREP Bhubaneswar and has a postdoctorate certification from the European Board of Interventional Radiology. Sir is a passionate educator and will update us on the current imaging concepts of hepatocellular carcinoma.
At the outset, I'd like to thank the organizers for this opportunity. So in the next 20 minutes, we'll be covering certain current imaging concepts in hepatocellular carcinoma. So we will be covering the risk factors, pathophysiology, and vascular dynamics of HCC. We'll review the various imaging modalities, including the hepatobiliary contrast agents, recognize the imaging hallmarks and Lyrad's categories, learn the post-treatment imaging assessment, and certain prognostic imaging markers. So HCC is the most common primary liver malignancy. The risk factors being virus like hepatitis B, C, MASLD, and metabolic associated steatosis, alcohol and cirrhosis. The incidence varies geographically. The important thing to remember is the pathophysiology of, that is the vascular supply of liver, the dual blood supply, that is portal vein supplies 70 to 80% of the blood flow, and hepatic artery, the rest 20 to 30%. And as there is a development of HCC or the hepatocarcinogenesis, the blood supply changes from portal to predominant arterial supply. So in this case, as you see, there is a arterial enhancing lesion arterial phase hyperenhancing lesion, and as compared to the background parenchyma, it is enhancing more, and even in the delayed phase, you can see it is hypoenhancing. This is because of this variable blood supply between the background liver parenchyma and the liver lesion. The same arterial enhancement can also be used in follow-up imaging, because this patient then underwent sorafenib therapy, and the follow-ups at 6 months, you can see the arterial enhancement is lost. This vascular supply plays a big role in our imaging and determining the post-treatment outcomes or recurrence. So we'll see it with examples. So coming to the imaging modalities, what is the role of conventional ultrasound? So we have a lot of imaging parameters like abbreviated MRI, new biomarkers that are available, but the ultrasound presently, although the role is reduced, but it will still be used for surveillance. So the next imaging modality is contrast ultrasound. So the only one point you need to remember is how to differentiate is it benign from malignant if there is sustained enhancement in the portovenous phase. So the first thing that you should see in contrast enhanced ultrasound is the portovenous phase. If there is sustained enhancement, it is a benign lesion, and if there is washout, it is malignant. If the nature of the washout is weak and late, that is beyond 1 minute, and less intense washout, that is HCC. So this is a portovenous phase contrast ultrasound where you can see mild degree of washout, and this washout occurred beyond 1 minute. So this fits into HCC. So where does CUS stand in our diagnostic algorithm? So this is basically a second line test. It provides real-time vascular dynamics. So use contrast enhanced ultrasound for indeterminate lesions or patients who are contraindicated for CT and MR contrast. So coming to the workhorse of HCC diagnosis, that is multiphasic CT. So we obtain a non-contrast, we obtain a late arterial phase. So it's important to remember we are using the late arterial phase because in this phase there is maximum discrepancy in enhancement between the HCC and the background liver parenchyma. Besides this, we'll take a portovenous phase and delayed phase. So the CT hallmarks of HCC are non-rim arterial phase hyperenhancement and washout in portovenous phase with a capsule. Besides this, for initial practice for residents, you can use this quantitative method. You can draw the values of attenuation and see how in arterial phase there is hyperenhancing, and subsequently in delayed phase the same lesion will be hypoenhancing as compared to the background parenchyma. So what are the additional features that we'll be looking at? It's enhancing capsule, a mosaic attenuation. So this mosaic attenuation is an ancillary feature in LIRADS. We'll cover it under LIRADS. So this is because of hemorrhage within the lesion or the fibrous septa or the metallic deposition, creating a mosaic pattern of attenuation, which is a characteristic feature of HCC. You can have fat within the lesion, or you can have nodule within nodule appearance. All these are ancillary features in LIRADS. So this is how macrovascular portal vein invasion looks like. So you can see the enhancing thrombus within the portal vein. So coming to MRI protocol, so we obtain a T1 weighted, T2 weighted image. The in-phase, opposed phase is taken to identify fat. Diffusion weighted image is obtained and dynamic contrast image is obtained. Besides that, the area of interest presently is on the hepatobiliary phase using gadoxetic acid. Gadoxetic acid is not available in India, so we use gadobenate dimeglumine, and it's the hepatobiliary phase in gadobenate dimeglumine is around 60 minutes. So I'll come to those difference between gadobenate dimeglumine and gadoxetic acid. So as we have already discussed, the recommended timing of hepatobiliary phase in gadobenate dimeglumine is 1 to 2 hours or 60 minutes roughly, and gadoxetic acid is 20 minutes. The biliary excretion of gadobenate dimeglumine is 3 to 5%, whereas gadoxetic acid is more, that is 50%. And this is how a gadoxetic acid enhanced MRI looks. You will be taking this is the hepatobiliary phase image where you can see the hypointense lesion. So coming to LIRADS. So why LIRADS? It is to bring the hepatologist or gastroenterologist, pathologist and radiologist into single forum where they use the common terminologies. What does LIRADS give is a probability of HCC based on the CT and MR findings. So where it is applicable for cirrhotic patients, patients who are chronic hepatitis B or C with a current or prior HCC. You should not use it in less than 18 years, patients with congenital hepatic fibrosis and patients with vascular disorders like HHT or Budd-Chiari syndrome. So the major features of LIRADS we have already seen. Those are non-rim arterial phase hyperenhancement. That means the enhancement of the entire lesion as compared to the background liver parenchyma, and not this type of enhancement, that is rim enhancement. So it's a non-rim pattern of enhancement. Then coming to non-peripheral washout, that means there is in the portovenous phase or delayed phase, you will see a hypoenhancing lesion as compared to the background liver parenchyma. You have another lesion which is having lesser degree of washout as compared to the other lesion. So this is non-peripheral washout. A capsule, which is a smooth rim of enhancement that you see in portovenous phase. And the other two major features are size. So larger the size of the lesion, higher is the chance of being an HCC, and the threshold growth, which has been simplified in version 2018 of LIRADS as 50% increase at 6 months. So there are certain ancillary features. I'll just go through this and then I will show you with example how we use ancillary features, where we use ancillary features. So there are certain ancillary features which favor HCC, which are non-enhancing capsule, nodule within nodule, mosaic architecture, blood products and fat within the mass. There are certain features that favor malignancy, not HCC. These are ultrasound visibility of discrete nodules, subthreshold growth, restricted diffusion, corona enhancement, and hepatobiliary phase hypointensity. There are certain features which favor benignity, is a stable lesion at 2 years, size reduction, paralleling blood pool, and undistorted vessels, or hepatobiliary phase isointensity. So as we progress from LIRADS 1 to LIRADS 5, the probability of malignancy gradually increases. So this is the diagnostic table of LIRADS. We will discuss this table with examples. So one important point to remember is you cannot upgrade from LIRADS 4 to LIRADS 5 using ancillary features. Again, we will discuss with examples. So basically with the features favoring malignancy, you can upgrade from one stage to the other stage, and the features favoring benignity, you can downgrade from one stage to the other stage. We'll discuss this later on. So this is basically LIRADS 1, which is a simple cyst hypoattenuating without any peripheral enhancement. This is a large lesion, hypoattenuating lesion in left lobe with peripheral nodular enhancement, gradual centripetal fill in. So this is a classic giant cavernous hemangioma, again LIRADS 1. This ill-defined lesion with arterial phase hyperenhancement with enhancing thrombus within the portal vein. So this is basically LRTIV, tumor in vein. Similarly, tumor in vein can also be within the hepatic vein. You can notice the enhancing thrombus within the hepatic vein. Can have a ill-defined hypoattenuating lesion with no arterial phase hyperenhancement. Gradually, the enhancement is increasing subsequently towards the portovenous phase with adjoining biliary dilatation, probably a intrahepatic cholangiocarcinoma. This will be given LRM. And this targetoid pattern of enhancement is consistent with LRM. And this is a patient who was evaluated having chronic hepatitis B, non-cirrhotic with arterial phase hyperenhancement. So this fits into, this pattern of enhancement is non-rim arterial phase hyperenhancement. Size was 10 to 19. You don't have any additional feature like washout or capsule. We don't have a threshold growth. So none of the three other parameters are there. So this fits into a LIRADS 3 category. So whether it will be LIRADS 3 category, whether you will be upgrading or downgrading it, so you see for any benign, any ancillary feature. So we can see here the lesion parallels the blood pool. You compare it with the aorta. This is the enhancement of the lesion. Again, similar to the aortic enhancement within the aorta, the lesion is paralleling. So this paralleling the blood pool is an ancillary feature which favors benignity. So you downgrade it from LR3 to LR2. So another lesion, so you read it as 19/12/2024. This patient was underwent tests for HCC, had another observation in the follow-up MRI, arterial phase hyperenhancing lesion around 3 centimeter without any significant washout. This was the CT that was done, follow-up CT. So this again is a non-rim arterial phase enhancement pattern. and size of the lesion was more than 20 mm without any additional major features like enhancing capsule or washout. So this fits into LR4. So whether this imaging has any ancillary features, we can see there is some mosaic attenuation type pattern of enhancement. So this is ancillary feature, that is mosaic architecture. However, as we have already discussed, you cannot upgrade LR4 to LR5 on the basis of ancillary features. So this will be staying as LR4. Another case, you can see a large non-rim arterial phase hyperenhancing lesion with washout, size more than 20 mm. So this one major feature, that is non-peripheral washout. So this fits into LR5. Another lesion, you can see again non-rim arterial phase hyperenhancement with subsequent washout with a capsule. So more than 2 centimeter, 2 major features. So this fits into LR5. This had also an additional ancillary feature of mosaic attenuation. This patient who was a diabetic patient with early F4 fibrosis, having arterial phase hyperenhancing lesion with washout, however there is no capsule. So this is again non-rim arterial phase hyperenhancement, 10 to 19 lesion with non-peripheral washout. So this fits into LR5. Additionally, he had a nodule within nodule appearance. Another case we will see. So this is a sub 10 millimeter lesion, non-rim arterial phase hyperenhancement, and with no additional major features. So this fits into LR3. Another lesion in left lobe, again non-rim arterial phase hyperenhancement with washout. So this will become LR4. So this LIDARs has been also used to for treatment response. So we have non-viable, equivocal, and viable. So this is a patient who underwent TACE, then follow-up imaging at 1 month was done by CT. So ideally we do a post-TACE imaging using MRI subtraction. So here we did a CT. You can see in the non-contrast, this hyperdense deposition are lipidol deposits. So with this background of hyperdensity, it's difficult to pick up the arterial phase hyperenhancement. That's why we are doing a MRI with subtraction. So in arterial phase, you can see there is enhancement within the lesion. That means this is a viable tumor, TR viable. Thereafter, the patient underwent a second session of tests, and we followed it up with a MRI subtraction phase. You can see this subtraction MRI where you can see the aorta, that is arterial phase, and this is how a subtraction MRI looks. Basically, you are subtracting the arterial phase, late arterial phase MRI from the non-contrast T1 weighted image. This will generate this kind of image. So post second session of test, this is a non-viable, LRTR non-viable. I'll skip this. So this anyone can volunteer and tell the LIDARs category. So this is a non-rim arterial phase hyperenhancement with washout with a capsule. What will be the category? LR5. Okay, so this was a case of Budd-Chiari syndrome, patient having a segment 5 observation arterial phase hyperenhancement, and it was showing some washout. So what will be the category in this case? So you will not categorize because LIDARs is not applicable for vascular disorders like HHT and Budd-Chiari syndrome. Okay, so we'll go to the next difficulty that we face in characterizing whether it is a regenerative nodule, dysplastic nodule, or early HCC. So these are all differential mimics of HCC. So what are these regenerative nodules and dysplastic nodules? So basically, regenerative nodule are those nodules which are non-malignant that you see in your routine imaging. These are different from dysplastic nodule because dysplastic nodule will be harboring the pre-malignant lesion. So it is needed that you identify the dysplastic nodule, which will be different LIDARs category and needs early follow-up and a stricter follow-up as compared to regenerative nodule. So the difference in imaging is because of this variant supply. That means arterial supply is increasing as the hepatocarcinogenesis is progressing from a regenerative to a dysplastic nodule to a early HCC. So out of all these imaging features, just try to see this hepatobiliary phase. That means we will be using gadobenate dimiglumin. The 1 hour delayed phase, which is the hepatobiliary phase, is the most important imaging characteristic to differentiate regenerative from dysplastic nodule. So any hypointensity in the hepatobiliary phase indicates there is pre-malignant or malignant lesion. So if it is definitely hypointense, you will be taking it into early HCC category, but any hypointensity within the nodule, you give it as dysplastic nodule. So any hepatobiliary phase hypointense nodule without APHE means a dysplastic nodule. So where does it fit in the LIRADS category? A regenerative nodule will be in the LR2, that means it's a probably benign, whereas a dysplastic nodule, that means any nodule having a hypointensity in hepatobiliary phase will be fitting into LR3, that means intermediate probability. Then what is M-resist? So since in resist we are using size as the criteria, however in HCC after treatment the arterial phase hyperenhancement is reducing, which indicates the treatment response. We are using modified resist in HCC, which is basically measurement of the arterial enhancing component. So you measure only the arterial enhancing component, not the entire lesion in modified resist. So certain post-treatment imaging after I want to show you that you should be aware of, that is post-treatment imaging after ablation. Two things that you should differentiate is the post-ablation reactive hyperemia from a residual recurrent disease. So this is a segment 8 nodule which was ablated. Immediate post-ablation we do a CT to see the how well we have ablated. So this AR foci usually are generated during ablation. So this reactive enhancement, this enhancement that you are seeing is smooth rim enhancement, is the post-ablation hyperemia. The same patient at 4 months, at 4 weeks follow-up, you can see there is no hyperemia. So this hyperemia usually seen within the 4 weeks. That's why we image post-ablation post-ablation HCCs after 4 weeks. So this segment 7 lesion which was ablated, you can see immediately post-ablation there is some residual leftover in this. So residual disease or recurrent disease will be nodular, irregular, and asymmetric as compared to a post-ablation hyperemia which is smooth and uniform. Okay, so these two differences that these two differences in imaging you should understand, that is difference between recurrence residual from post-ablation hyperemia. So we have already discussed test here. So coming to vascular invasion, we have already seen macrovascular invasion easily detectable on imaging. Can we detect microvascular invasion on imaging? So there are certain imaging features which are consistent with microvascular invasion. These are arterial peritumoral enhancement, a non-smooth tumoral margin, and peritumoral hypointensity on the hepatobiliary phase. So these three imaging features, if present, increase the possibility of microvascular invasion. So what is the importance of microvascular invasion? So if this microvascular invasion is present in the HCC, that means post-resection, post-transplant or post-ablation or post-locoregional therapy, the chances of recurrence will be high. So we can prognosticate the patient that you have a high-risk tumor and you have high chances of recurrence. So as we discussed, so what are these imaging features that suggest microvascular invasion? Is this irregularity in the margin of the lesion? This is the hepatobiliary phase using gadoxetic acid. You can see this peritumoral hypointensity. So this peritumoral hypointensity, low ADC and irregular tumor margin suggest microvascular invasion. So can we prognosticate and predict the HCC? So there are a lot of molecular subclasses and genetic types of HCC present. So they have been broadly categorized into proliferative versus non-proliferative HCC. So proliferative ones which are aggressive and non-proliferative ones which are less aggressive. So there are imaging features which are consistent with proliferative HCC and imaging features which are consistent with non-proliferative HCC. So on imaging we can predict that this is a proliferative versus non-proliferative HCC. So both LIRADS, so we'll individually see these features. So for proliferative HCC, more than 5 centimeter suggest a proliferative HCC. That means larger size lesion means it's an aggressive tumor. Then you can have a non-peripheral washout, which is consistent with the proliferative HCC. Necrosis within the lesion. Okay, necrosis within the lesion suggests proliferative HCC. Okay, and this peritumoral lateral phase hyperenhancement suggestive of proliferative HCC. These are all LIRADS features that already you know. There are certain LIRADS, non-LIRADS feature also. Move on. Okay, there are certain non-LiRADS features which are consistent with proliferative HCC, like this irregular margins. A low ADC signal. This peritumoral hepatobiliary hypointensity. So this is basically hepatobiliary phase image. We can see this peritumoral hypointensity or any biliary invasion. Satellite nodules. So these are all features which are consistent with proliferative HCC. Whereas a smaller size of lesion, that is less than 5 centimeter, fat within the lesion. This is the in phase and opposed phase image where you can see the drop in signal within the lesion which suggests fat within the mass. Hepatobiliary phase iso or hyperintense lesion. T1 iso-intense lesion or a T1 hyperintense lesion, these are all consistent with non-proliferative HCC. So using these features, we can prognosticate the HCC. You should be aware of this new entity that has been described recently. So what is abbreviated MRI? So basically, MRI, the drawback of MRI is it takes a lot of time. So in abbreviated MRI, we are using few sequences which can give adequate information that a full sequence of MRI can give. So basically you are reducing the protocol to 10 to 15 minutes, and there are several protocols available which are contrast based and non-contrast based. So sensitivity for more than 2 centimeter lesions in screening is around almost equivalent to standard MRI, that is 90 to 95%. So where to use is, it will be useful for obese patient where ultrasound screening is not effective. So this was a hepatitis C patient where we are barely able to see any lesion on surveillance ultrasound. So there was we did the abbreviated MRI protocol where we saw diffusion restriction. Then we did the dynamic MRI where we can see there was arterial enhancement and washout in the delayed phase. So this will be useful for picking up lesions for surveillance. So basically the purpose of abbreviated MRI is to save time and give you more information or make your surveillance more sturdier. So we have PET CTs. CT perfusion gives quantitative functional information. However, the radiation dose is the limiting factor for CT perfusion. So radio mix is an entity. That means besides our regular measurements that we do, radio mix collects information like texture, shape, intensity, and spatial patterns, which correlate with the tumor nature or tumor biology. So concluding, HCC diagnosis relies on imaging hallmarks, that is arterial phase hyperenhancement, washout, and capsule. The purpose of LiRAD is to standardize the reporting and management recommendations. MRI with hepatobiliary phase agents increases the sensitivity for smaller lesions, and advanced imaging like radiomics is promising for prognosis and treatment planning. Thank you.
Thank you, sir. That was indeed a very comprehensive update. I would now request Dr. Anuradha Chandramohan ma'am to please come up and felicitate Dr. Tara Prasad. Dr. Sanket Dash will now deliver his next talk on epilepsy protocol.
Thank you. So let's move ahead with the next talk. So in the next 20 minutes or so, we will be discussing about the epilepsy protocol. So we will try to discuss when to image in epilepsy, how to image, and what is the so-called epilepsy protocol, some common pathologies on epilepsy MRI, and we'll try to discuss in brief about the role of advanced imaging. So we all know the difference between seizures and epilepsy. So seizure is basically excessive burst of abnormally synchronized neuronal activity, whereas 2 or more unprovoked episodes episodes of seizure within 24 hours is known as epilepsy. So we should know the difference between seizure and epilepsy. So epilepsy in general population, there is about 4% patients of the general population experience seizure, out of which 1% have epilepsy disorder. And about 0.4% have uncontrolled or drug-resistant epilepsy. And if we consider this population, about 80% will have some identifiable epileptogenic focus in a dedicated epilepsy protocol MRI. So the International League Against Epilepsy classifies seizures as either focal onset or generalized onset or a combination of both. So these kind of terms like a complex partial, simple partial, or secondarily generalized tonic-clonic seizures do not exist. So don't use them. So the role of imaging in epilepsy is to detect the epileptogenic lesion, to localize the epileptogenic lesion, and to aid a syndromic or etiologic diagnosis. So basically the International League Against Epilepsy, or ILE, has devised a formulation that every patient who has a first-time seizure of unknown cause should undergo a brain MRI. So the ACR, or American College of Radiology, appropriateness criteria devises that any patient having a new onset seizure which is not related to trauma, MRI and CT, both are equally important and appropriate investigations to be considered on the first line. On the other hand, patient having already a known seizure disorder, MRI is considered the most appropriate imaging modality. So basically the imaging in epilepsy can be broadly divided into structural and functional imaging. So structural imaging, the imaging modality of choice is MRI, CT is also helpful. The functional imaging like functional MRI, MR spectroscopy, magnetic encephalogram, and nuclear medicine modalities like SPECT and PET also aid in the diagnosis of difficult to diagnose cases of epilepsy. So remember that CT is basically the first line which is easily available. So usually CT helps in ruling out most of the acute causes or very obvious causes of seizure like tumors, extensive malformations, etc. So several studies have also shown that CT can beautifully exclude major causes of epilepsy. So as this is a very good table for the diagnostic yield of CT. So basically in acute scenario, you should go for CT first followed by MRI, whereas if it is a non-acute situation, then you can directly go for MRI and skip CT. So MRI is indicated in all patients of epilepsy. Remember that all patients of epilepsy should undergo an MRI. Basically, there are certain exceptions like juvenile myoclonic epilepsy or childhood absence seizures. These do not actually require MRI, but practically speaking, any patient having an epilepsy disorder always undergoes MRI at least for one time in their lifetime. So between 3 Tesla and 1.5 Tesla, definitely 3 Tesla fares better. That is because of improved detection of cortical malformations. So now let us discuss what is an epilepsy protocol MRI. So it is called as harness MRI. So basically harness stands for Harmonized Neuroimaging of Epilepsy Structural Sequences. It has been devised by International League Against Epilepsy, or ILE, to basically give a standardized protocol for the epilepsy imaging. So this includes 3 basic sequences, that is the 3D T1, 3D flare, and a T2 coronal oblique sequence. So remember that 3D sequences are our go-to sequences when we are evaluating for epilepsy. So by epilepsy imaging, we always think about hippocampal imaging, but it is not only hippocampus which is responsible for seizure. So you should not miss about the other lesions, and that's why your 3D sequence is the most important sequence when we are dealing with the epilepsy protocol. So in harness MRI protocol, the first important sequence is a 3D T1 based sequence. So the various brand names or vendor specific sequences like the MPRAJ on Siemens, FSPGR on GE, or turbo field echo sequence or the 3D TFE sequence on Philips, depending on whatever scanner you are using. So the 3D T1 sequence, basically a gradient based sequence, is the most important sequence because of its high gray-white matter interface differentiation and for the evaluation of the brain anatomy and morphology. Second important sequence to go for is a 3D flare sequence. Again, the vendor specific names like Cube on GE, Vista on Philips, and Space on Siemens. So 3D flare and 3D T1. Along with that, you should go for the T2 coronal oblique sequence, basically perpendicular to the plane of the hippocampus. So this is acquired something like this. It is perpendicular to the plane of the hippocampus, basically the body of hippocampus. So planning should be like this. So coronal oblique sequences, and remember that the slice thickness is not the normal 5 mm sequences. So, slice thickness. It is basically an isotropic and small voxel thickness. So the thickness should be somewhere like this, a submillimetric voxel resolution, only covering the hippocampus. So 3 important sequences, 3D T1, 3D flare, and the coronal T2 oblique sequences are go-to for epilepsy protocol evaluation. So basically, when a patient of epilepsy comes, so this is how you should go ahead. The normal MRI sequences you should definitely consider. So you can skip the axial flare and the axial T1 if you are considering the 3D sequences. So go for the axial T2, diffusion and the susceptibility, or GRE, whatever you have, and then the 3D based sequences, the 3D flare, the 3D T1, and the corneal T2 oblique sequence for the hippocampus. Once you have the 3D T1, you do not require the corneal T1 IR sequence, which often we do in the epilepsy protocol is a corneal T1 IR and a corneal T2 flare. If you have a 3D sequence, you can reformat them in the any plane that you want. So you can reformat them in the corneal oblique planes as well, so you do not need to acquire them separately. Other additional sequences may be helpful, like a double inversion recovery or even post-contrast if you are suspecting for infections or inflammatory granulomas. Otherwise, for routine evaluation of epilepsy, you do not need contrast. You remember that contrast is not necessary for epilepsy protocol. And ASL perfusion may be helpful, particularly in very difficult cases where you are not able to localize the pathology. Sometimes perfusion helps. So there are several causes of epilepsy, including your idiopathic, the mesial temporal lobe sclerosis, malformations of cortical development, the epileptogenic tumors, the vascular malformations, and several neurocutaneous syndromes. So we will try to look at some of the classic cases of epilepsy that we come across in a routine evaluation of epilepsy. So the first case, this is very common case that we commonly encountered in cases of epilepsy. So what we see, so can anyone name what is the sequence? So this is basically a double inversion recovery sequence. So in double inversion recovery, we apply 2 inversion recovery pulses for separation of both the white matter and the CSF. So it accentuates your gray-white matter interface differentiation. So this is your 3D T1 sequence which has been reformatted along the plane of the hippocampus. So this is the 3D T1 reformatted. It is not a corneal IR, right? And this is the thin sequence corneal T2 being acquired perpendicular to the plane of hippocampus. So what we see here is a volume loss involving the left hippocampus with flare hyperintensity. And associated, you can see volume loss with dilatation of the temporal horn. So classic case of mesial temporal lobe sclerosis. So on axial also, you can beautifully see this is the right side hippocampus, which is normal, and this is the left side hippocampus. You see there is greatly reduced in volume with associated flare hyperintensity. So you should know about the anatomy of hippocampus. So hippocampal anatomy, you should remember that it is the only structure in brain which is outlined by white matter and not gray matter. So the white matter outlining the hippocampus is your alveus. So this is the thin white matter outlining the hippocampus is your alveus. And you should remember that there are 2 important gray matter structures in the hippocampus, that is the cornu ammonis and your dentate gyrus. So cornu ammonis has 4 parts, CA1 to CA4. So this is CA1, CA2, CA3 and CA4, where it merges with your dentate gyrus. Now the hippocampus proper continues as subiculum, which further continues as the entorhinal cortex and the parahippocampal gyrus. And this sulcus here is the collateral sulcus. So this CSF here, this is your choroid fissure and this is your temporal horn. So hippocampal sclerosis, as we have seen in the case, there are primary signs and secondary signs. So primary signs are atrophy with hyperintensity on T2 and flare in the hippocampus and associated loss of interdigitations of the hippocampus. Secondary findings are related to volume loss in the associated Papez circuit or the limbic system. So you can get atrophy of thalamus, ipsilateral fornix, or even the mammillary bodies. So they are related to the afferent and efferent pathways of the hippocampus. So this is a very recent development in the mesial temporal lobe sclerosis. So recently, last year only, the International League Against Epilepsy has further classified the mesial temporal lobe sclerosis. So it is further classified from type 1 to type 4, basically depending on which subset of the cornu ammonis is more involved. So type 1 is basically uniform involvement of entire extent of the hippocampus. Type 2 is basically when CA1 is predominantly involved, and type 3 is when the CA4 and the dentate gyrus region is predominantly involved. Now why this classification is important? So this classification is important because they have different associations. So type 1 is most important, associated with bilateral tonic-clonic seizures, whereas type 2, you remember that they do not have memory disturbances. And type 3 is usually associated with a second pathology. So if you are getting type 3 or CA4 predominant hippocampal sclerosis, you should always search for the second pathology in the form of a focal cortical dysplasia or a epileptogenic tumor in the vicinity. So let's see another case. This is a patient having status epilepticus and presented to us in the postictal state. Now the MRI shows this cortical gyral edema with diffusion restriction, no other changes. So now what is this? What is this? This is whether it is an infarct, encephalitis, or it is just a postictal change. So basically this is a postictal change. So postictal MRI you can have this T2 flare kind of hyperintensity with gyral edema, and the classic locations are cerebral cortex and the subcortical white matter, also involving hippocampus, thalamus, particularly the pulvinar region, and your cerebellum. Now, how to differentiate it from infarct? So you can go for advanced imaging modalities like perfusion. In cases of status epilepticus or post-ictal edema, you will get hyperperfusion, whereas in cases of infarct, you will get hypoperfusion. Then this is another case of post-ictal status where you see only involvement of the subcortical white matter and no involvement of the gray matter. So only subcortical white matter hyperintensity can also be seen in a case of post-ictal state. So next important cause of epilepsy is the developmental pathologies like your malformations of cortical development. So this is a very beautiful classification. This table is from Osborne, and the classification is given by the great pediatric neuroradiologist Barkovich. So the cortical malformations of cortical development can be a malformation in the level of neuronal proliferation, neuronal migration, or post-migrational development. So let's see some common pathologies. One is your focal cortical dysplasia, which is the most important cause of focal epilepsy, particularly in children. So FCD has 3 types, 1, 2, and 3. 1, you have a dysmorphism in the layering of the cortical layers, whereas 2, along with the dysmorphism in the layering, you get abnormal neurons, that is type 2. And type 3, you have an associated pathology like a hippocampal sclerosis or some epileptogenic tumor or some vascular malformation. So this is the 3 types of focal cortical dysplasia. So the common important findings in focal cortical dysplasia is blurring of gray-white matter junction is the first sign. Second sign can be cortical thickening or gyral expansion, which is most commonly seen in type 2 FCD, and then white matter hyperintensity extending from the level of the gyral thickening till the ventricle. That is known as transmental sign, which is often present in type 2B focal cortical dysplasia. So let's see some case examples. So let's see this MRI. Can you see the abnormality here? So this was a case of focal epilepsy. Can anyone see the abnormality? So again, our friend here is the 3D T1 sequence. Do you see the abnormality now? So there is some degree of blurring, there is definite blurring of the gray-white matter junction. So 3D T1 sequence is very, very useful for these kind of subtle focal cortical dysplasias. So now remember, the diagnosis here is incomplete if you don't have the clinical information. So often we get requests, epilepsy protocol, MRI, patient having seizures. What kind of seizure it is? It is a generalized seizure, it is a focal seizure. In focal, what is the seizure semiology? Whether it is frontal, occipital, temporal, you should know this information. And always EEG should be done prior to MRI and not a vice versa. But in clinical practice, we see that patients often refer to us for MRI first and then go for EEG. But it should be EEG first followed by MRI. So in that way, you will be more wiser in looking at what region the abnormality is, and then you will carefully look at that region. Like in this case, we knew that it is a focal epilepsy of frontal region. So then if you clearly see that there is some gray-white matter blurring here, there is no associated hyperintensity, only subtle blurring. So this is FCD type 1. Type 2A. Basically next is another case. You see this is again blurring of gray-white matter junction here, and there is some degree of white matter hyperintensity also. So this is another case of focal cortical dysplasia. This is FCD type 2B. Then next another case, hippocampal sclerosis is evident, right? But there is something else. There is some degree of blurring of gray-white matter junction here. So this is FCD together with focal mesial temporal lobe sclerosis. So this is FCD type 3A. FCD along with hippocampal sclerosis. Another case, this is focal cortical dysplasia here. But at the same time, you see there is some expansion and tumor. So this is a epileptogenic tumor, that is a DNET. So this is DNET along with focal cortical dysplasia. So this is FCD type 3B. Another important developmental pathology is polymicrogyria. So polymicrogyria, you get multiple small sallow sulci, which is known as lumpy bumpy cortex. So let's see this case. So can you see the abnormality in the perisylvian region? You see that this sulcation here is not normal. You see multiple small sallow sulci. So this is in the perisylvian region. So this is perisylvian polymicrogyria, which is the most common location for polymicrogyria. You should not forget to look at the sylvian fissures and at the poles, whether it is the temporal pole or the occipital pole, because often small polymicrogyria in this region can be missed. Then another case, this is a case of congenital torch infection. So I have given you half the diagnosis. So you see some temporal cysts, some degree of this widening, some white matter hyperintensities, and abnormal polymicrogyria in this region. So polymicrogyria with temporal cysts and congenital torch infection. So what is the diagnosis? Congenital CMV. Another case, I have written the findings here. You see corpus callosum agenesis, there is polymicrogyria, there is gray matter heterotopia, there is some interhemispheric fissure cyst. So this is basically classic syndromic diagnosis of ICAD syndrome. So ICAD syndrome has these three important findings, that is corpus callosum agenesis, polymicrogyria, and heterotopia. So these, if you see these findings, you should raise a suspicion of ICAD syndrome. Then genetic testing can be done. Like, then comes schizencephaly, which is like this cleft, cortical cleft extending from the surface to the ventricle. Now the key to differentiate here is the lining. It is lined by gray matter and not the white matter. So that is why it is schizencephaly and not porencephaly. So schizencephaly can be again two types. It is like this, which is the open lip schizencephaly, or it can be like this, where it is closed lip schizencephaly. So schizencephaly can also be an important cause of seizures. Then comes megalencephaly. So look at this, I have already told you the diagnosis, but which hemisphere is abnormal here? Whether it is the right hemisphere or the left hemisphere? Which hemisphere is abnormal? So how to decide which hemisphere is abnormal? You should look at the ventricle. The side where the ventricle is dilated is abnormal. So in this case, this hemisphere is abnormal because the ventricle is dilated. So the ventricle is dilated, but this hemisphere is bigger, not smaller. So bigger hemisphere with a dilated ventricle, everything is bigger in that hemisphere, right? So this is hemimegalencephaly and not a hemiatrophy. So remember to differentiate hemimegalencephaly from hemiatrophy. So look at the ventricle, the side where the ventricle is dilated is abnormal. If ventricle dilated with smaller size of the cortex, then it is hemiatrophy. Ventricle is dilated with associated dilated hemisphere, it is hemimegalencephaly. So sometimes hemimegalencephaly can be only focal. So this is quadrant megalencephaly. It is not hemi, it is quadrant. You can see only part of the hemisphere is involved. Then comes gray matter heterotopia. So heterotopia basically is abnormal location of the normal gray matter. This is normal gray matter deposited in abnormal location. So this is basically an abnormality of cortical migration. Okay, so in this case you can see multiple small nodular lesion in the periventricular subependymal location. So this is periventricular nodular heterotopia. Now the key here is that nodular heterotopia always parallels your gray matter. It should be equal to or similar to the gray matter on all sequences. But the major differential diagnosis is the subependymal nodule of tuberous sclerosis. Now how to differentiate them is by looking at the signal intensity. Gray matter heterotopia will parallel the cortex on all sequences, whereas cortical tuber will be T1, the subependymal nodule will be T1 hyperintense. Next, same case, I have already shown this case. Then periventricular nodular heterotopia along the occipital horn. Another case of occipital horn periventricular nodular heterotopia. Next case. So what we see here is a very simplified pattern of the gyrus. You don't see the sulcal species, right? The sulcal species are almost obliterated. It is kind of a flat surface of brain. And can you see the abnormality? There is a band-shaped area of gray matter attenuation within the white matter. So it is gray matter within the white matter. So this is subcortical band heterotopia. So subcortical band heterotopia is usually associated with lissencephaly. So here there is lissencephaly, which is simplification of the gyral pattern. You see almost flat surface of the brain, right? Then cortical glial scars secondary to or any kind of perinatal insult can also act as an epileptogenic focus. Next important etiology for epilepsy is the long-term epilepsy-associated tumor, which is also known as LEATs. So long-term epilepsy-associated tumors, there are certain pointers that you should know that epilepsy-associated tumors are always cortical-based tumors. So they are cortical-based tumors, usually slow-growing, indolent, mostly benign, and because of their slow-growing nature, they often have the signs of chronicity, like bony remodeling and scalloping of the adjacent skull. So let's see some cases. So can you see the abnormality in the temporal lobe here? So this is solid cystic tumor, kind of a bubbly appearance, right? Solid cystic tumor, and it is having a flare hyperintense rim. So this is DNET, dysembryoplastic neuroepithelial tumor. Another case of cortical-based tumor, you can see this expansion and flare hyperintense rim. Another case of DNET. So the most common location of DNET is your temporal lobe, followed by frontal lobe. So this is DNET, and DNET can be associated with FCD. So this is which is FCD type 3B. We have already seen this case. Another case of cortical-based tumor, but here what you see is the cyst and mural nodule appearance. So it is a cyst and mural nodule appearance. So when cyst and mural nodule appearance comes, first thing comes to our mind is pilocytic astrocytoma, right? But this is a case where you can see that there is some degree of cortical remodeling also, and dural tail is also seen. So this is pleomorphic xanthoastrocytoma, which is another important cortical-based tumor which can act as a long-term epilepsy-associated tumor. Then calcifying tumors which are epileptogenic, you should remember 4 entities. Apart from the routine tumors like oligodendroglioma and ganglioglioma, these are 2 cortical-based tumors which show calcification. There are 2 other entities which is capnon and plenty. What is capnon? Calcifying pseudo-tumor of neuroaxis. And plenty is polymorphic low-grade neuroepithelial tumor of young. So these are some low-grade indolent calcifying tumors which can also present with long-term epilepsy. So let's see this case on CT, very, very calcified lesion in the temporal lobe. On MRI, you can see this is susceptibility changes, not very minimal enhancement. So this is kind of a cortical-based calcifying tumor. So the differentials in this case will be same, ganglioglioma, or it can even be a plenty, that is polymorphic low-grade neuroepithelial tumor of the young. But we never came to know about the diagnosis because often these patients do not undergo a surgery because that is, they can be managed with anti-epileptics, and on long term when it is refractory, they need surgery. And they are not biopsied unless they undergo a surgical resection. Another case, again cortical-based calcifying tumor, you can see here. So this is again another case, similar case. So there are several cases I am showing. Enhancement with calcification. So this is a classic case of ganglioglioma. You see enhancement, you see calcification, cortical-based tumor and associated with epilepsy. This classic history suggests ganglioglioma. Then comes MVNT, which is multinodular vacuolating neuronal tumor. This is one of the classic leave me alone lesions of the brain. So here there are multiple small T2 hyperintense cysts in the subcortical white matter. So let's see this case. So in the amygdala region, you see some abnormality, right? There are very small T2 hyperintense cysts in the subcortical region. So this is a very subtle lesion. So this is either an MBNT or it can be even a low-grade DNET. So basically, this was causing the temporal lobe epilepsy. So remember, all temporal lobe epilepsies are not mesial temporal lobe sclerosis. There are tumors, there are focal cortical dysplasias, and that should be always excluded on MRI. Then next case, I have already shown you the diagnosis, lesion in the region of hypothalamus. So this was basically adolescent patient presenting with classic seizure, that is known as gelastic seizure. The child laughs when having seizure. So gelastic seizure, adolescent with precocious puberty. This is the classic history of hypothalamic hamartoma. So you can see some lesion like this involving the hypothalamus, and it always parallels again the gray matter. So the differential here will be optic nerve glioma. Another case of hypothalamic hamartoma, but what is this T1 hyperintense structure here? So this is associated with dermoid cyst. You can see some rupture also with T1 hyperintensity along the callosal margin. So this hypothalamic hamartoma may be associated with other developmental lesions like dermoid. Then neurocutaneous syndrome, 2 important, that is the tuberous sclerosis, where you know there are 4 important brain findings, that is subependymal nodules like this, cortical tubers like this, white matter hyperintensities, which is known as radial migration lines. So these are the classic findings of tuberous sclerosis on brain MRI. And often they have low IQ, and with adenoma sebaceum, with typical seizures, these patients are diagnosed with tuberous sclerosis. Then another important case of neurocutaneous syndrome, which is associated with seizure, is Strach-Weber syndrome. You see this port wine stain here on the left side. On the same time, on brain MRI, what you are seeing here is multiple cortical-based calcifications. And at the same time, what is this? So what is the pathology behind this Strach-Weber syndrome? Is the abnormality of the venous drainage. So here what you see, this is the normal, this is SWI sequence, which is undergone a MIP reformation. So you see this is the normal deep veins, but in this case you see superficial veins are absent and deep veins are more prominent. So this is the classic pathology. You see absent superficial veins with prominent deep veins or medullary veins along with cortical gyral calcification. So this is leptomeningeal angiomatosis or Strach-Weber syndrome. Another important vascular cause of seizure is this. So what is this? Is a spotter. What is this? Patient with temporal lobe epilepsy, this classic lesion, what is this? So this is a cavernoma or cavernous malformation. You see central reticulated core with surrounding T2 hypointense rim. So this is a spotter, this is cavernoma. You can have multiple cavernomas on GRE or SWI. So SWI is your friend where you see these multiple small cavernomas which can be missed on other sequences. Even at the same time, you can have cavernomas in the spinal cord also. So don't forget. Then neurofibromatosis and other neurocutaneous syndromes may also be associated with seizures. Always look at the cutaneous stigmata and the clinical history. Arteriovenous malformations like this, large nidus, some calcifications, this is the cause of seizure in this patient. So often unruptured arteriovenous malformation of brain presents with seizures. Another case, some gliosis, but you can see some T2 hypointense flow voids. So when MR angio was done, you see this abnormal nidus here. So this is arteriovenous malformation again causing seizures. Other causes, most important cause in our setup is a inflammatory granuloma, neurocysticercosis or tuberculoma. You should know about them, and I am not going into details of that. There are several signs. So briefly, in 2 minutes, I will just tell what are the advanced MRI sequences that you should do in cases of epilepsy. So these are basically for research and for difficult to do cases where routine imaging fails to demonstrate the lesion. Okay? So diffusion tensor imaging and tractography, and that is very useful for preoperative planning and also to detect subtle white matter hyperintensities which are missed on normal diffusion. So this is a case of glioma. You can see preoperative planning has been done with DTI. Beautifully shows the displacement of the tracts, useful for the surgeons. Then diffusion kurtosis imaging and NODD is the neurite orientation dispersion density imaging. They are advancements of the diffusion imaging basically to look for the microstructural abnormalities. Then I have already told about double inversion recovery. This is a handy tool for you. It can be applied on a routine practice. This is basically a 7 to 8 minute sequence. So adding it does not hamper much of your clinical time, only 7 to 8 minutes sequence, double inversion recovery. But see how beautifully the gray white matter differentiation comes on a DIR sequence. So it is again a 3D sequence, so you can reformat in any plane. So DIR is another important sequence that can be helpful for subtle cortical malformations. Then MP2-RAGE, I have told you about MP-RAGE, which is a 3D T1 based GRE sequence. MP2-RAGE is just a modification of that, again for look at this. This is MP-RAGE and MP2-RAGE. How beautifully the gray-white matter differentiation comes. So basically, these sequences are there for subtle cortical malformations, or what you can say is the bottom of sulcus dysplasias. Then there are other sequences that has been in research like FLOSS, which again is based on the double inversion principle, basically to accentuate the gray-white matter differentiation. Then ASL perfusion, as I was telling you, it is a non-contrast perfusion which helps in detecting the epileptogenic focus. So ictal period you have a hyperperfusion, whereas in the post-ictal period you have a hypoperfusion. Like in this case, this is the ASL perfusion. You can see this is the normal cortical perfusion, and what is here? In this area there is some subtle hypoperfusion. At the same time, on going back to the FLAIR image, you can see there is a subtle cortical malformation here, which was initially missed on the routine imaging, but ASL helped us in picking up this small lesion. Quantitative susceptibility mapping can help in detecting the abnormal mineral depositions. Then T2 relaxometry, which is basically the quantitative imaging. So you get the T2 relaxation times. T2 relaxometry per se is a very long sequence. It is not clinically useful. But nowadays, synthetic MRI has come up. So in synthetic MRI, this T2 relaxometry can be done in only 5 minutes. So T2 relaxometry is very, very useful in mesial temporal lobe sclerosis. You can further read. We have published on T2 relaxometry using this synthetic MRI in this mesial temporal lobe epilepsy. You can undergo further reading on that. Then spectroscopy can show reduced NAA, but this is non-specific. Hippocampal volumetry, very old technique, but you should know that volumetry is not replacement for your structural imaging. Visual look is the most important. Even ILE says that visual interpretation of hippocampus is more important than volumetry, because volumetry only you can detect larger changes, which often comes very late stages. So volumetry is done something like this. You outline the hippocampus and then the volume comes in the cubic centimeters. So more than 3 cc asymmetry between the hippocampus and volumetry suggests hippocampal sclerosis. Surface-based morphometry, basically it is a reformation of your cortex. So basically the entire cortex of the brain is opened up. So you can detect subtle dysplasias. So it is nothing but a post-processing software, surface-based morphometry. Then functional MRI is usually helpful for the planning preoperatively to localize your language area and the other important areas, basically for the surgical planning. Then functional imaging like SPECT and PET can be useful, and you can fuse MRI with SPECT and PET. So this is by Syscom software. So you fuse the SPECT images with your 3D T1 sequence. So structure and function, structural and functional imaging co-registered together gives better yield for localizing subtle epileptogenic focus. So finally, this is the last slide. So before reporting, you should go for an approach that is known as 3, 2, 1, go. So 3, 2, 1, go. What is 3? 3 means on 3D T1, you should first visualize all three planes, axial, sagittal, and coronal, followed by 3D flare, where you should look for two images that is in the normal windowing, and you should also look in aggressive windowing to look for the subtle abnormalities or bottom-up sulcus dysplasia. Then one, that is your GRE and SWI in axial, you can look at that for the cavernomas and calcified granulomas. So 3, 2, 1, go. Then only go for hippocampus. So in epilepsy, don't jump to hippocampus first, but go by this approach 3, 2, 1, then go to hippocampus. So you will not miss the subtle lesions, and often your MRI will not come negative but positive. So acquisition is most important, followed by your interpretation. So I would like to highlight is that clinical history is the most important point, followed by proper acquisition and 3D sequences. These are the three important aspects by which you can improve your epilepsy diagnosis by more than 90%. Thank you.
Thank you, sir, for that lucid yet eloquent session. That brings us to the end of our morning sessions. To mark the commencement of today's academic extravaganza, we are honored to invite the office bearers of ICRI, ORIA, and our senior faculty members to please come forward and light the lamp to officially inaugurate this resident education program. Ma'am, please.
Good afternoon, everybody. So, my dear colleagues, friends, those who have traversed across the country, our elected speakers. So, after this marathon sessions of this academics, and already since you've been welcomed in the morning, and it is a re-welcome, you can say. So, I thank particularly the speakers, those who have traveled from the far across the country to deliver their lectures for the betterment of the upliftment of the knowledge for these resident doctors. And this IRIA and ICRI, who are persistently and consistently trying to improve are not the upliftment of our subjects, but to see that the residents are trained properly so that they can do something in future. So for that reason, they are trying to do different programs of academics, and IREP is one of them. So IREP, you can say that in being taken care of by our seniors, and most recently by our dynamic ICRI Secretary, Dr. Natasha, and she is personally taking care of all these things to see that this becomes a success. And I welcome all the speakers like Dr. Natasha and Dr. Anuradha, who has traveled from seems well, and who has delivered a very concrete lecture on different subjects, which I hopefully think that it will be useful to residents, particularly those who are preparing for their exams. And our Goldsmith, he has also delivered some of the good topics. And our own Dr. Swati, she delivered, we are well versed so far IRIA is concerned. Dr. Swati is delivering for the last so many years in different formats. And Sanket is from our place, is doing well and settled there in NIMS Jaipur. And our own Tara Prasad, our dynamic person who is taking care of all the activities nowadays of late. And he is going to host a big annual conference this year on behalf of the IREP Bhubaneswar. And all said and done, this IREP has been taken care of by our good friend and colleague Dr. Satyasundar Mahapatra, whose continued endeavor and persistent efforts to see that everything is made ready-made and everything is made so beautifully orchestrated so that everyone will be happy and everyone will be pleased to learn and enjoy this session. So big round of applause to Dr. Satyasundar Mahapatra. He is a good leader, of course. Of late we have got as an IRIA, and probably the IRIA is developing, and we'll see much of this sort of academic activity under his leadership. And thank Dr. Satya for the pain and pleasure you are taking on behalf of everybody. And moreover, his team, Dr. Adya and his team, they are doing wonder. And nice to see our senior colleagues like Father Figure Vividas and our ex-presidents, etc., were present. And it's a learning curve. It's surprising to see at this age they are coming over here and enjoying the session. And big round of thanks to them and the encouraging figure to the youngsters, particularly when at this age they are coming to learn. And most of the students I am finding they are also coming forward. I request them to join. Thank you all.
Thank you, sir, for your kind words. Now, we request Dr. M.V.K. Rao, Vice President, IRIA, to kindly grace us with a few words.
A very good afternoon to everyone, all the residents, the teachers, and all the ORIA members. The resident education program is a flagship of IRIA and ICRI. It is purely a teaching program for the residents of all over India, and it is conducted twice every year, and particularly in a medical college. This is in addition to the teachings which the residents get in their respective colleges. The IRA has taken it as a challenge to teach all the residents of all the states of India by doing these type of programs. We are happy that Orissa Radiological and Imaging Association has got to conduct this program for the first time. And I am very much thankful to the organizers, that is our secretary, Dr. Satya, president, Dr. P.K. Das, and the organizer, Dr. Adya. And I hope this two-day program will enrich all our residents to learn more and what is going on outside our state. This is a two-day program. Today, our ICRI Secretary Natasha Madam is with us. Tomorrow, the chairman, Dr. Sikandar, is going to be with us. And we are going to have a very good teaching extravaganza. And we will request them to allot IREP in future years so that our residents will get more benefit out of it. Thank you.
Thank you, sir. Now, I call upon Dr. Natasha Gupta, Secretary of ICRI, to please address the gathering.
Thank you so much. It's truly a great pleasure for me to be here on this wonderful platform with this wonderful gathering. All the respected dignitaries, Dr. Prafulla sir, the President, Odisha chapter, Dr. Satya Sundar Mohapatra sir, the Secretary, Odisha chapter, our mentor and senior, Dr. M.V.K. Rao sir, who has been a guiding force for all of us since the last so many years, and he will also be taking over as the VP IRIA, the National IRIA in 2026. Dr. Adya, who is a very valuable state coordinator and has played a crucial role, as I understand, in conducting this IREP, all the seniors, colleagues, friends, and dear residents. It is truly a pleasure for me to stand here today before such a vibrant gathering of radiologists, educators, and learners. As we all know, we have such dedicated and esteemed faculty who have contributed in such a big way in making this IREP a success. So many thanks to all the faculty, and a big thanks to Dr. Anuradha and her team from CMC Vellore for coming all the way for the sake of the residents. I stand here on behalf of Dr. Gurdeep Singh, the President IRIA, Dr. Pankaj Sharma, Secretary IRIA, and Dr. Sikandar Sheikh, the Chairman ICRI. And with great joy from my own side, I warmly welcome you all to this special academic event of the IRIA and ICRI that is being organized in such a wonderful way by the Odisha State Chapter of IRIA today. So before starting, I would just like to take out a few brief moments and fondly remember and pay my homage to our great and visionary leader of all times, who is not with us today, none other than Dr. Hemant Patel. He was a big guide and a mentor, not just to me, but many of the great radiologists pan-India, and I'm sure to many of us here in this gathering today as well. Dr. Hemant Patel worked relentlessly and tirelessly, not just for the progress and upliftment of IRIA, but also to promote brotherhood among the radiology fraternity. Just today morning, Dr. Anuradha was also commenting that I really remember and appreciate Sir for the great international collaboration that he got for IRIA through his efforts. He put us on the platform of the International Radiology Associations of the world, which no other leader has been able to do to such a great extent before this. So we all fondly remember him today and pay our homage on this great event that we are organizing today. I congratulate the entire organizing team of the Odisha IRIA under the leadership of the President, Secretary, Dr. Rao, and the entire team for the tireless events. And you have made this event not just possible, but an exceptional event, I have to say. I am sure everybody here today will be enjoying the unmatched hospitality of Bhubaneswar, and as well as the academic sessions, and also it will be a pleasure for all of us, a great memory for us to be in this temple city of Bhubaneswar, which is a vibrant blend of ancient heritage and modern urban planning. We at IRIA are not just an association, we are a movement and a collective force who work together to elevate radiology through ethics, education, and unity. And we are committed to advancing the study and practice of radiology and imaging across India. It is with great pride that I share with all of you that the membership of IRIA is now over 27,000 members. So this tells us about the shared commitment that we all have to excellence. But just numbers do not define us, while active participation does. Through the academic wing of IRIA, the ICRI, that is the Indian College of Radiology and Imaging, of which I am also the secretary in this current tenure, we organize regular CMEs and workshops and conferences. And the aim of these is to make the radiologists stay updated and connected with all the emerging technologies. Apart from the CMEs, we conduct 2 IREPs, that is the IRIA resident education programs, as Dr. Rao also informed you all. And these happen twice a year. And this is the second IREP program that is being done by the Odisha chapter at Bhubaneswar. And the goal of these IREPs is to make a very structured academic program which is exclusively designed to enrich the radiology residents with exam-oriented knowledge as well as the cutting-edge practical skills. So in the end, I would just once again congratulate and thank the entire team of Odisha chapter, the scientific coordinators, the national coordinator for IREP, Dr. Kushaljeet Sodhi, and all of you who have made immense efforts for conducting and organizing and executing this program. Long live IRIA and ICRI. Thank you so much.
Thank you, ma'am. You have renewed our inspiration for our subject. We shall now adjourn for lunch. And since some of our speakers will also be departing today in the evening, I would request everyone to kindly make it back to the hall by 2:20 p.m. And you can find the lifts. Lunch will be served on the ground floor. And the lifts, a set of lifts are there on the right side of the stage, and the other set is near the registration counter. Please try to make it back by 2:20 p.m. Thank you.
The compartment in which they are located in the suprahyoid or the infrahyoid neck or the various other compartments and spaces of neck, or according to the etiology, the causation. The role of various imaging modalities. Now, X-ray does not have much role, but the single most important application, and that too in the emergent setting, is assessment of airway compromise. And particularly if a child comes with difficulty in breathing, a single lateral X-ray of the neck can give you a hint as to whether there is compression or compromise of the upper respiratory airway. Ultrasound is the preferred modality for the initial evaluation of the pediatric neck mass, particularly if it is superficial or palpable. So it will be able to well show you the morphology, whether it is solid or cystic, pick calcifications, assess internal vascularity, show vascular displacement, and the most important advantage of ultrasound, as we all know, in the pediatric setting is that it does not expose the child to radiation exposure. However, cross-sectional imaging will be required for a complete characterization to assess the complete extent of the tumor, particularly the lesions that are located deeply in the neck, because ultrasound is often able to evaluate just the superficial part, and for staging of the neoplastic etiologies. So CT is preferred in the emergent setting because it is fast and it also gives the best spatial resolution as well as excellent multiplanar and 3D reconstructions. However, MR is preferred over CT in the non-emergent setting, mainly because there is lack of radiation exposure to the child, and also it provides the best contrast resolution, the most detailed characterization, and it is preferred in the multiphasic repeat and follow-up imaging, and for the most accurate pre-op anatomic localization. So coming to the congenital lesions, the thyroglossal duct cyst is the most common congenital cystic neck mass that we encounter in the child, and it may occur in the neck. It is seen in the anterior triangle of the neck close to the midline and anywhere extending from the base of tongue to the thyroid. It is closely related to the hyoid bone and may be embedded in the strap muscles. A thyroglossal duct cyst that is suprahyoid in location is more commonly midline, and infrahyoid is more commonly off midline. So an uncomplicated thyroglossal cyst, as anywhere else, it would be seen as an anechoic avascular lesion, rounded in shape, well defined, with thin regular walls, posterior enhancement on ultrasound, and similarly a simple homogeneous fluid density or intensity lesion with thin, smooth, non-enhancing walls on cross-sectional imaging. However, if there are secondary complications of internal hemorrhage or infection, then these appearances would change, and the lesion may show thick and irregular walls, and it may show peripheral enhancement and internal debris or echoes. So this was a case of a 4-year-old girl who presented with an infrahigh cystic swelling in the left anterior neck since birth. And another important clinical sign of the thyroglossal duct cyst, or any thyroid lesions for that matter, as we know, is that they tend to elevate or move cranially when you swallow or protrude the tongue. So that often is helpful in differentiating from other cystic lesions located in the same location. So on ultrasound, we saw that this was a complex cystic lesion on the left side that was closely related to the thyroid gland, and it shows this internal clot-like structure and dependent debris. CT was able to well demonstrate the lesion. It was very closely associated to the isthmus and the left lobe of thyroid and appeared to be embedded in the strap muscles. Also, it was superiorly very closely related to the hyoid bone. So this was operated upon, and it was so intimately related that part of hyoid bone and thyroid lobe had to be removed to excise the cyst, and histopathology proved it to be a thyroglossal duct cyst. The branchial cleft cyst is the second most common congenital cystic neck mass in the child after the thyroglossal duct cyst, and as we know, this occurs from incomplete obliteration of the various branchial tracts. Now, of the various branchial anomalies, the second branchial cleft cyst is the most common, and this has been subdivided by Bailey into 4 types according to the location. So the type 2 subtype of the second branchial cyst is again the most common, and it has a very typical location. It is a unilateral cyst located in anterior triangle, and it often is located in submandibular region, and it is seen to be located. The typical lesion is deep to sternomastoid, lateral to carotid sheath, and this is a borrowed image which shows a homogeneous cystic density. Now, this was a young child who presented to us with a swelling in the right neck since birth, and we again see a homogeneous fluid density lesion within non-enhancing walls in the submandibular region, pushing the submandibular gland anteriorly, anteromedial to sternomastoid, anterior to the carotid sheath vessels. So this is a branchial cleft cyst. Again, knowledge about the spectrum of the dermoid, epidermoid cysts and teratoma is extremely important in the child, because this is a lesion which occurs not infrequently in the pediatric age group. The dermoid cysts, the dermoid spectrum of lesions may be located in the midline of the neck, and it may closely mimic a thyroglossal duct cyst according to location. It may also be located adjacent to the hyoid bone. The other locations being oral cavity in the floor of mouth and submandibular and submental regions. But as I told you, it would be possible to differentiate from thyroglossal duct cyst on the basis of the clinical feature of elevation on swallowing or tongue protrusion. Okay, then the dermoid cyst, it shows very typical features of the presence of fat. There may be fat fluid levels. Calcification is also a sign that goes more in feature of a dermoid other than the bony and dental elements. And a very typical feature that has been described with the dermoid cyst, this is known as the sack of marbles or the marbles in the bag appearance. So what happens is that the fat globules coalesce to form marble-like spheres that appear hyperechoic on ultrasound and show the lucent spheres with a negative HU value on CT lying within the cyst, and hyperintense on T1, T2 MR with loss of signal on the fat suppression images. As you can see, this is a dermoid cyst with the location very similar to the thyroglossal duct cyst. It is located in the anterior midline of the neck and superiorly related to hyoid bone, inferiorly to the thyroid gland. But these telltale spheres within the cyst which show the fat density, this would give you the correct diagnosis that this is not a thyroglossal duct cyst, but this is a dermoid cyst. The epidermoid cyst is a well-defined fluid density lesion which may show rim enhancement, and often it would show diffuse or organized internal echos and present as a cystic lesion. The teratomas contain germ cells, contain derivatives from all the 3 germ cell layers, and the mature teratoma is the same as dermoid cyst, while immature teratoma would show you more of soft tissue, and it may show you negligible fat or calcium components. Now this was a 7-month-old girl who presented with a large cystic mass in the left neck since birth, and we can see this soft tissue swelling in the left neck with a lot of radiolucency on the X-ray itself. On ultrasound, it appeared to be a very heterogeneous lesion with hyperechoic and hypoechoic areas and fluid components, but the CT picture was very, very diagnostic, and there was a large heterogeneous mass with lot of macroscopic fat inside with some soft tissue nodular areas as well as fluid, and it was extending from the submental region right up to the parapharyngeal region and even displacing the airway to the opposite side. So based on all these morphological characteristics, the diagnosis of a teratoma was kept, and on histopathology it was proved to be a mature teratoma. Now the infective inflammatory pathologies are also extremely common in the children and young patients, and cervical lymphadenopathy of infective inflammatory origin is actually the most common cause of a neck mass in the child. So talking about the cystic lesions, the infections such as tuberculosis and the suppurative infections, suppurative bacterial infections like staph and streptococcus, they present with necrotic nodal masses which may present as complex cystic lesions in the neck. So tuberculosis and suppurative infections, when they produce the necrotic nodal masses, what you will see on ultrasound, you find the cystic and hypoechoic necrotic areas within the enlarged nodes. The nodes appear rounded or lobulated in shape as compared to the normal ovoid structure of the nodes. There is a hypervascularity because of inflammation, and the normal fatty hilum which is seen in the normal node may be obliterated or displaced. This is the MR picture which shows you a necrotic nodal mass with central hypointensity and peripheral enhancement. Now the frank cervical abscess is also a very, very important lesion which is a cystic mass in the child, and of course the systemic features, the fever, the pain, inflammatory signs, all these would help you to suspect an abscess in the neck which is presenting as the cystic mass. So this was a 2-month-old girl who presented with fever and neck swelling and systemic symptoms and a severe respiratory distress. So it is important to identify and correctly diagnose a cervical abscess which is a cause of respiratory distress, because that may be life-threatening for the patient and that has to be drained on an emergent basis. So on ultrasound, as we all know, we will see a complex cystic lesion with lot of internal necrosis and debris and mobile echoes. There may be thick nodular irregular wall, and in this particular patient an emergency tracheostomy had to be done. There was so much of respiratory distress, and imaging revealed a large complex cystic lesion with a long air fluid level and septae in the retropharyngeal region. So this was a retropharyngeal abscess, and drainage revealed frank pus. Sialadenitis, that is inflammation of the salivary glands, it is also not uncommon in the child, and when there is suppurative infection in the salivary glands, then that may present as an abscess in the salivary gland and again as a complex cystic lesion. Now this was a very unusual case who presented to us. There was a complex cystic mass in the left submandibular gland, and rather this had a cyst within cyst appearance, the presence of daughter cyst within a larger cyst in an enlarged submandibular gland, and this was a very unusual case of a hydatid cyst within the submandibular gland. This case is also a very typical entity and this is something which will actually help you to suspect an undiagnosed case which has not been clinically diagnosed so far. The imaging findings are so typical. So this was a 4-year-old who presented with swellings in bilateral parotid glands and submandibular glands with cervical lymphadenopathy. And what do we see here? There are multiple tiny cystic or hypoechoic lesions interspersed, scattered diffusely in both the parotid glands. The parotids also show some enlarged intraparotid lymph nodes, and the submandibular glands also show the same findings of tiny cystic hypoechoic lesions. This is cervical lymphadenopathy. A CECT was also done, although the ultrasound showed the findings much more beautifully. So what you see here is diffuse enlargement of the glands, again showing the small cystic and hypodense lesions in the salivary glands, and in addition CT also showed enlargement of the adenoid glands and tonsils with the similar findings of these little lesions. So what do you suspect just on this appearance? No history? When you have this kind of picture, you must ask the clinician to get the HIV testing done for this patient. And these are nothing but HIV related lesions or the benign lymphoepithelial lesions. So this has happened in at least 2 to 3 times when we got this kind of typical findings, and it was an undiagnosed case of HIV, and subsequently we suggested to the clinician and the child came out to be HIV positive. Okay, so we all, this is seen in even in adults, not just in children, but then we all must be aware of this entity. Then some neoplastic pathologies may also present as complex cystic lesions in the neck in the child. Among the neurogenic tumors, the neuroblastoma and the neuroblastoma group of tumors, which are less common, ganglioneuroblastoma and so on. So they may also present as complex masses in the neck. The cervical neuroblastoma will usually represent a metastatic disease from the primary elsewhere in the neck. But in up to 5% children with neuroblastoma, it is in the neck that the primary cervical tumor may be found. So neuroblastoma has a property of often presenting as a heterogeneous soft tissue mass in the neck, and there is associated lymphadenopathy. It would be seen located posterior to the carotid sheath, and the vessels may be either displaced or encased. So neuroblastoma, typically it also encases the vessels, as we see elsewhere in the abdomen as well. And if you find the tumor extending into the neural foramina or in the spinal canal, then that is very, very typical for a neurogenic mass. Okay, then you have to put the neurogenic mass above any other causation. And MR, as we know, is the best for the intraforaminal and intraspinal extension. So the ultrasound CT appearances may be variable depending upon morphology, and presence of calcifications is also an important sign of neuroblastoma. So this was another very interesting case who came to us. This was a 2-month-old child, and right from birth the baby had a huge lobulated neck mass. So as you can see, such a huge mass which is seen on the X-ray also, and there was very subtle calcification that was identified with difficulty on the X-ray. Ultrasound showed a very heterogeneous mass with internal calcifications, hypervascularity, and right at the time of presentation we could see some deposits in the liver as well as the left kidney, and within 1 week of presentation the subcutaneous nodules also developed on the body, first of all on the scalp. So CT very beautifully showed this lesion. You can see this large heterogeneous mass with lot of internal calcification, and these cystic necrotic metastases in the liver and the kidney, and also the lytic lesions in the hip bone and the femur. So this was a huge primary cervical neuroblastoma that was proven on histopathology, and it was metastatic right from the time of presentation. So rather it was a congenital cervical neuroblastoma. Rhabdomyosarcoma is another very important tumor in the pediatric age group, and it is in fact the most common soft tissue sarcoma that occurs in children. It is a very aggressive malignancy, and it would be shown to be invading the adjacent structures, causing bony destruction, metastasizing, showing lymphadenopathy, but it is something which always has to be kept in the differential when you have an aggressive mass in the child. And the head and neck is a preferential area of location for the rhabdomyosarcoma, and in the neck it has a propensity for involving the cervical musculature and the parapharyngeal spaces. So this is also seen as a very heterogeneous mass, and it has a propensity to show internal cystic necrotic areas and hemorrhage. So this you can see is a necrotic tumor that is presenting as a complex cystic mass involving the parapharyngeal space, showing some peripheral irregular nodular enhancement and extending laterally to involve the carotid sheath and going posterior to the mandible. Now vascular pathologies are another subset of lesions which are extremely important in the child, and I am sure you all must have come across infantile hemangiomas, venous malformations, lymphatic malformations. We see them in little children in pediatric practice all the time. Almost every week we are doing sclerotherapy for venolymphatic malformations, and I am sure you all must be encountering similar lesions. So infantile hemangioma, we all should know what it looks like. It has a very typical course. It presents shortly after birth, and it rapidly increases in size in the first year, and then it would, the natural course is that it would involute on its own, it would regress on its own. But when you see it on imaging, ultrasound is a very good tool. It is seen as a heterogeneous mass with hypoechoic and hyperechoic areas, and it is a very hypervascular, high flow lesion with a high vessel density, and it shows both arterial and venous waveforms. So it has to be differentiated from an AV malformation, which is another high flow lesion. So how to differentiate? The AV malformation is just a tangle of vessels. Remember that infantile hemangioma would show you a lot of parenchymal tissue which will not be present in the AVM. Both would be high flow lesions, both would show you arterial and venous waveforms, but the number one, there's so much of parenchyma you would find in an infantile hemangioma, and then the typical course, that is, it rapidly enlarges in size and looks very aggressive in the first year. And then when you follow it, maybe just give some propranolol to reduce the vascularity, and then when you follow, after 1 year, it will just go on regressing and involuting and reducing in size on its own without doing anything. Okay, so these two things are very, very important to remember. The venous malformations, these are slow flow lesions, and these would show you low velocity venous waveforms. The appearance, the morphology can be variable. They may be hypoechoic, they may be complex cystic lesions, but sometimes they are so slow flow lesions that you may not find any vascularity within them on Doppler. And when phleboliths are seen, that is the hallmark imaging feature. If you see the phleboliths as the rounded nodular calcific foci, then you can be sure that there is certainly a venous component to this lesion. It may be a combined venolymphatic malformation or a venous malformation if you see the phleboliths. So this is an example. You can see this tortuous infiltrative lesion, a lobulated lesion in the left face and neck, which is appearing hyper-intense on T2 and iso to mildly hyper on T1, and it shows progressive enhancement on contrast. And these little hypo-intense foci, they are the phleboliths which are seen within the lesion on all the sequences. And the venous malformation, it may be present at birth, but it will increase proportionately in size with the age of the patient. It will not rapidly increase in size in the first year, and it will never involute. Lymphatic malformations, I am sure we all have seen the cystic hygroma, such large cystic lesions that present in the children, and the head and neck is a very important location for them. These are multi-compartmental tumors that have no respect for the tissue planes, and they encase all the normal structures, but they do not exert much mass effect. So this is a typical cystic hygroma. See, there's such a large cystic lesion in the neck, and this is a typical macrocystic variety which is seen as a multicystic, multi-septated lesion. The septae may be thick or thin, and this shows a fluid intensity and the hypointense septae on MR. So just coming to the last entity, ranula, this is also another lesion which we must know what it looks like. It is nothing but a mucocele or a mucus retention cyst that arises from occlusion of the sublingual duct, and the simple ranula by definition is confined to the floor of the mouth or the sublingual space, and it is confined by the mylohyoid sling. Whereas when it extends from the sublingual space to the submandibular space, you can see this is the sublingual component extending to the submandibular space or passing through a mylohyoid muscle defect. So then we call it a diving or a plunging ranula. But this case was not just a plunging ranula, it was a giant ranula. So giant ranula is something which is defined as the ranula which extends into the parapharyngeal space, which is even more extensive and more disseminated in location than a plunging ranula. So as you can see, after going into the submandibular space, this is going posteriorly and superiorly and going into the parapharyngeal space. So although clinically this was a clear-cut ranula, there was a lesion in the sublingual space which is bluish and transilluminant positive, but then the cross-sectional imaging only was able to reveal how much extensive this mass was and till where it was extending. So such cases actually also need to be differentiated from a cystic hygroma, which is again multi-compartmental and may be very extensive. So how to differentiate? Cystic hygroma would also always show you septae, but ranula it does not usually show you internal septae unless there is a superadded infection or a hemorrhage, and ranula would always have a component in the sublingual space, and it does not generally go into the posterior triangle. Whereas for a cystic hygroma, location in posterior triangle is much more common and the sublingual component is relatively less common. So sorry for overshooting my time by a few minutes, and thank you so much for your patient hearing.
Thank you, ma'am, for distilling our concepts. Up next, we are proud to invite on stage our alumnus, Dr. Aishwarya Manoharan. She is currently working as assistant physician at the Clinical Radiology Division at CMC Vellore. Ma'am is still fondly remembered at our department here at IMS and some hospital for her exemplary performance as a postgraduate resident, and we are eager to have her refresh our basics with a discussion on the abnormal chest radiographs.
Good afternoon. Good afternoon, everyone. Before I start the session, I would really like to thank Satya sir for giving me this opportunity to present, to deliver a talk at my own alma mater. And I would also like to thank all my teaching faculty, all the radiology faculty at IMS and SOM Hospital who shaped me to the person who am I today. Thank you so much, SOM Hospital. Thank you for making me the person I am today. So yeah, quickly going into the interpretation of abnormal chest radiographs. So the approach of abnormal chest radiographs can always be taken as a graded approach, as what we call it. So the grading can be these following mnemonics. We can either use it as like A, B, C, D, E, F, G, H. So each one abbreviating for assessment or assessment of the radiographs or assessment of the airways, progressively going on to the bones and soft tissue, cardia, the diaphragm, looking into the pleura, fissures and fields, great vessels, hyla and mediastinum. So this approach can be utilized, else we can make use of an approach which is called as inside out or the out to in approach, wherein we can progressively look into the structures from the rib cage, have a quick look at all the bones, and then we progressively move in assess the hilum, the lung fields, and then the mediastinum. Or you can either go the opposite way as well. So by having a graded approach, we make sure we are not missing out any findings. So yeah. So we are going to have a case-based approach for common pathologies, and I would really like the residents to make a quick guess. All of this are case-based approach, so please make sure you try answering something. Okay, so this is case one. This is a 45-year-old gentleman whose X-ray was taken as a part of pre-employment workup. So it was in our radiology department, we had quickly seen this radiograph, and one of our residents had written cardiomegaly, but the patient is asymptomatic, not having any comorbidities. What do you think went wrong with the radiograph? You can just prompt as a group also, either group 1, group 2. So what do you think went wrong with the radiograph? So if you look closely, this area, so what do we assess this area? Assess this area for? This is the spinous process, and these are the medial ends of the clavicle. So what do you get an idea from that? Rotation, yes, very good. So this is a rotated film. So you can see the distance between the spinous process and the right side of the clavicle is much less when compared to the other side, making the heart appear enlarged. So you have to pay attention to all these technical factors as well before we actually comment on what is going on. Yeah, so A, which stands for assessment. So this is another case. This is a 30-year-old who was under evaluation for LRTI. So again, what do we see? So definitely as a part of LRTI, there is some peribronchial prominence or peribronchial inflammatory changes. So again, an error was there. So something abnormal was reported in regards to the cardiac shadow. So what went wrong here? Very good, yeah. So we call back the patient, and this was how the radiograph was taken properly, and you can see the how well the lung fields are inflated. So it's always important to have a good inspiratory film so that we also avoid erroneous interpretations. One more finding was also spuriously mentioned here. So what happened when you look at the left side CP angle? Doesn't appear a little bit blunt when compared to the opposite side. So all these findings were put in the report, and then there was a discrepancy clinically. So we had to look back again and take this imaging again. So to avoid all this, you will have to make sure all the imaging acquisition parameters are met. Like is it an adequately rotated, if the film having no rotation, is there adequate inspiratory effort? What about penetration? What about exposure? These factors might be a little bit tricky for us, but I think once in a while when we interact with the technologists, we spend some time with them and they'll be very happy to teach us what is going on. Yeah, so case 3, a 14-year-old under evaluation for stridor. Just have a graded approach. Any quick finding you're able to notice? So the clinical history, stridor. Yes, so have a look at the trachea. So the tracheal caliber is getting progressively narrowed, and it forms like a tent of a temple. That is what is called steeple sign, and this is croup, okay, or otherwise called as laryngotracheobronchitis. Okay. Now case 4, 55-year-old under evaluation for breathlessness. So anything you're able to find? So usually during interpretation of chest radiographs, we do get very short history. We do not get a long history. So we had to probe again, and what is something which sort of appears abnormal in this radiograph? What about the caliber of the trachea? So the patient had a known case of COPD. So can we get any clues from that? So this is saber sheath trachea, wherein the anteroposterior diameter of the trachea gets reduced, and on sagittal diameter the diameter progressively increases. So yeah, so this is saber sheath trachea which we usually see in COPD. So this is not a radiograph, this is a scanogram from a CT, but what can we look into this? 30-year-old recurrent LRTI since childhood. Apart from the most obvious findings in the lung, what is more striking? Just make a quick guess. We are seeing all tracheal pathology. So, yeah. So the trachea appears dilated, like abnormally dilated. So, any conditions associated with dilated trachea? What do you? Yeah. So this was tracheobronchomegaly with bilateral upper lobe bronchiectasis, and the possibility of Mondrian was raised. Yeah. So 45-year-old gentleman under evaluation for loss of weight, loss of appetite. Yeah, so what do you see here? Bilateral hilar prominence. Okay, so generally this is how the hilar should appear. So the hilum can be imagined as a K or a C-shaped like impression, but whenever we see this abnormal prominence, this should raise the possibility of underlying mediastinal lymphadenopathy. So the common condition is tuberculosis, or if at all you see some other opacity in the right paratracheal region also, it should be sarcoidosis. Yes, okay. Yeah, case 7, 68-year-old under evaluation for breathlessness and chest pain. Are we able to see anything abnormal? So, yeah, so the most obvious finding is, yeah, hilar, appears to be, the hilum appears to be enlarged. And yeah, we are sort of seeing some opacities in bilateral lung zones. Okay, so hilar enlargement with some opacities in the lung zones. What else we are missing? So this is how history we will be getting very like sort of blunt. So we can go back and ask the history, but anything else? So if you look closely, this we are not given any history of this is a male or a female, but you can see this is a breast shadow here. So the breast shadow here is missing. So meaning the patient had undergone surgery for mastectomy, and this is hilar and lung metastasis. Yeah. So it's always good to ask additional clinical history as well. Okay, 45-year-old under evaluation for breathlessness. Anything abnormal? So before we interpret what is happening, we also have to have a quick look on what is this indentations or bulgings or so-called moguls of the mediastinum. So mogul is a word which they use to describe the snow bumps which is there in snowy regions. So this is how generally we used to appreciate some of the impressions formed by the cardiomediastinal structures. So the first mogul is the one which is formed by the aortic arch in the posterior aspect. The second mogul generally is not appreciated at all, but if at all it is there, it is caused by the main pulmonary artery. And the third mogul is caused by the dilatation of the atrial appendage. The fourth mogul is the shadow caused by the left ventricle. The fifth mogul should be the epicardial fat. So which of these moguls do you think is abnormal in this radiograph? Second? Yeah, second should be, yeah. The second mogul is enlarged, and what else you are looking at? There is also some hilar prominence. So this is a case of pulmonary arterial hypertension. Okay, 80-year-old under evaluation for cough. Just cough, no fever, nothing else. And you sort of get like this image. I can give you a clue, like we do get to see like this images in older population. Unfolding of, yes, so we are able to appreciate that the mediastinum sort of appears widened. It is overshadowing the bilateral hilar region. So this is caused by unfolding of aorta, which occurs as a part of degenerative change. The aorta sort of loses its normal like caliber, and because of atherosclerotic change, it may assume a tortuous course, and that's how this shadow is produced. Okay, similar case, 50-year-old under evaluation for sudden breathlessness, and the patient collapsed. So the patient was taken to the ICU, and they did echo. The echo showed some pericardial effusion. They were able to see some pleural effusion. So in this case also there is widening of the mediastinum, but this should raise the possibility of rupture of underlying aortic aneurysm. Okay, case 11, 21-year-old under evaluation for dysphagia. So I think we have been seeing this case example since our morning lectures. Are we able to appreciate any fluid levels within the mediastinum? Yeah, so this is a dilated esophagus with fluid levels, and that's how progressively on an elongated pattern we are able to see this impression. So this is achalasia. Okay. So all these are examples are put forth to emphasize the importance of just knowing what are the common conditions, common pathologies we do encounter, and we should not get alarmed or miss out these common conditions. Is it okay if we even miss out some rarer diagnosis? But certain common conditions we should make sure that we reach the diagnosis on point. Okay, case 12, 25-year-old known case of hematological disorder. So the clue is there in the history. Yes, sir. So when we look into all these bones, these bones appear widened. Okay, so that is one clue. And one more thing is when we see this sort of like paramediastinal shadows, always make sure to have a close look at how the vertebral morphology is. So in this, it sort of appears okay, but with some kind of scoliosis. But given the history of hematological disorder, widening of the marrow, these soft tissues are to represent the associated soft tissue components in extramedullary hematopoiesis. Yeah, so one more condition which can occur like in the absence of this expanded ribs, but with relatively normal vertebrae. So what else you should think of? You must immediately look how the vertebral morphology is. And if at all there is collapsed vertebrae at that level, and you are also seeing some associated soft tissue adjacent to it, what do you think of? Yeah, so the possibility of tuberculous spondylodiscitis with paravertebral soft tissue component should be thought of. Okay, 65-year-old known case of hypertension. So just looking into the morphology of the heart, there is definitely left ventricular enlargement. So this was just put to emphasize the importance of just identifying left ventricular hypertrophy. And yeah, one more case, a conjunction case, like 17-year-old who was having a known congenital heart disease, but this is how the X-ray looks like. So boot-shaped heart, so it should be like TOF. So what is the difference between these two studies? It's just to emphasize the importance of left ventricular hypertrophy, wherein the cardiac apex becomes more pointed inferiorly. Whereas right ventricular hypertrophy, the cardiac apex sort of gets pushed up. So this is how we sort of differentiate between the ventricular enlargement. Yeah, 65-year-old under evaluation for dyspnea. History of surgery. Yeah, so this is leather bottle appearance. So yeah, this is an example for pericardial effusion. One more case, like 30-year-old under evaluation for trauma. Are we seeing something subtle? Are we seeing something very obvious? Yes, there is pneumopericardium. So if you closely observe, this small sliver of lucent area, so we might think it looks normal, but the thing is that when we just look into the normal radiographs and have a quick comparison, definitely this thin sliver of air around the left cardiac border is abnormal. So this is pneumopericardium. Okay. Case number 17, 25-year-old under evaluation for abdominal pain. What do we see? Yeah, so there is sort of what we call it as continuous diaphragm sign, but it is commonly seen if the air is above the diaphragm. Here we are seeing a lucent crescent-shaped area just below the central tendon, and it's there in the abdomen. So it's pneumoperitoneum. Okay. Yes, 50-year-old under evaluation for pneumonia. Yeah, so the finding is that we are seeing a very homogeneous opacity in the right upper lung zone. So this would qualify for a right upper lobe collapse. So like it will be too extensive if we just go into the findings of each lobar collapse. So it's very good to remember this chart, just have a photographic memory of it. Whenever we see any opacities in overlying any of these lung zones or the cardiomediastinal ciliates, we'll have to think of the corresponding lung lobe to be collapsed. For example, if the right side of the heart, of the right heart border is not visualized, immediately we should think of the right mid lobe collapse. If at all we are not visualizing the diaphragmatic contour in continuity, it should point towards right lower lobe collapse. And there is also some left facial sign whenever we look into the left upper lobe collapse and all. Yeah, so it is always good to have a photographic impression of this chart, which helps us in quick evaluation. Okay, 45-year-old under evaluation of shortness of breath. Yeah, so what are we looking at? So how about the lung fields? Oligemic, aren't they too much hyperinflated? Hyperinflated lung parenchyma, the pulmonary vasculature appears to be pruned out. The mediastinum and the cardiac sort of are beginning to assume a tubular configurations. The domes of the diaphragm are flattened. So all this will point towards COPD. This is a normal radiograph we tend to normally see in COPD, individuals having COPD. Yes, a 40-year-old under evaluation for cough. Yeah, so when you look closely, these may be some bronchovascular markings, but there are also some multiple cystic spaces which are there in bilateral lower lung zone. So there must be an underlying bronchiectasis. Okay, so this is a case of bronchiectasis. Yeah, 15-year-old under evaluation for fever. This is very like a striking picture, any like a well-defined cavity with internal levels. So it can be a lung abscess as well. So other differentials should be hydatid cyst, and we have a mnemonic for all the cavitatory lung lesions, so it's good to have a quick revision of whatever we are looking at. 75-year-old under evaluation for fever. Yeah, so we can see the bilateral hyla sort of stretched and pulled up, and a lot of all these vasculature are sort of falling down from that hilum, and the lungs are already showing some oligemia. Plus, are we seeing something here? There is an opacity here with surrounding air. So this is a case when we looked into the history, the patient had a past history of tuberculosis. Now within that cavity, the patient had developed aspergillum or fungal ball. So have a quick short notes on what are the differential diagnoses of what a cavity in radiograph looks like. Yeah, so 2 cases, now I'm going to put side by side. Let's try to decode it. So the first one is 15-year-old under evaluation for chest pain. Second one is 18-year-old under evaluation for chest pain again. Okay, so how do we make a difference here? So this is where all your signs, all your Silhouette signs, cardiothoracic sign, hilar overlay sign, hilum overlay sign, everything comes into play. But the thing is that we need to understand the concepts behind it and make ourselves very clear so as to what we are dealing with. So here we are definitely seeing an lesion, but are we able to see the hilum distinctly? Yeah, the hilum is seen distinctly. So meaning the lesion is either in the anterior or in the posterior mediastinum. Yeah, so how to differentiate between the anterior and the posterior mediastinum? So that is where the cervicothoracic sign comes to play. Okay, so this turned out to be an anterior mediastinal lesion. Yeah, now going on to the next case. This is an 18-year-old under evaluation for chest pain. What are we looking at? There appears to be something huge in the left hemithorax. It is causing significant mass effect. Tracheal deviation is there, mediastinal shift is there. So, and apart from that, whenever you're interacting with the clinician on an emergency basis, what else you could possibly opine as a diagnosis from this radiograph? Any clues are we looking at here? I think the windowing is somewhat off, but when we look closely, what are these areas here? These nodular areas which are sort of appearing more distinct than the background? It's a calcification. So this turned out to be a mediastinal teratoma. Yeah. Okay. So look for clues. This is another case, 17-year-old under evaluation for chest and neck pain. So this is very obvious. This is a posterior mediastinal mass, wherein we are the upper lobe of the margin we are not able to make out, and it's sort of ascending upwards. Okay. So a quick point on how to differentiate between lung or mediastinal lesion. The lung lesion always make an acute angle, whereas the mediastinal lesions will make an obtuse angle with the mediastinum. Okay. Few more cases left. Yeah, 50-year-old under evaluation for cough. Where is the abnormality? Yes, sir. So when you look closely, I think again the windowing is on error. There is actually a lesion here under the diaphragm on the right side. So this is just to emphasize the importance of paying attention to hidden areas, the lung apices, retrocardiac regions below the diaphragms, and also the scapular, gleno-scapular region, where we have to pay attention so as to not miss out any findings. Okay. So these are just case examples just to demonstrate the importance of pleural pathologies like homogeneous opacification, blunting of CP angle. This is right side pleural effusion. 40-year-old under evaluation of sudden onset dyspnea. Are we able to see something distinct? The lung markings are very sharp till here. There is paucity of lung markings up above. So this is a case example for pneumothorax on the left side. Yeah. And 30-year-old under evaluation for sudden onset dyspnea. So in this case, there is this classical finding. What do we call this? This is a deep sulcus sign. So wherein the pneumothorax gets accumulated more, and we tend to appreciate this abnormality in supine position. Okay. 35-year-old RTA, what are we looking at? So when we pay close attention to, now when this history is RTA, look at all the bones. The bones are sort of symmetric here. When we have a close look, there is a break here. 1, 2, 3, all these ribs are broken. So, and also there is blunting of the CP angle on this side. So there is a rib fracture with minimal pleural effusion on the right side. So 30-year-old under evaluation for chest pain. One more case. So the ribs look fairly normal, but when we count the ribs and have a close look, we are seeing some lesion here. So this turned out to be an enchondroma of the rib. So take-home message is always have a systematic approach, ask additional clinical history, and the previous imaging details are always helpful. And not only we learn the eponymous signs, we have to understand the concepts also, and remember to pay attention to all the hidden areas in the chest X-ray, so that we do not miss out any findings. Thank you very much.
Ma'am's next topic will be on pediatric chest imaging.
Yeah, thank you so much. We'll be quickly looking into the pediatric chest imaging as well. So in pediatrics, chest radiograph forms the first line assessment of the diseases of the lung parenchyma and also of the airways like we saw in the previous lecture. So chest radiographs are easy to acquire, they're of low cost and readily available. So, but the thing is that if at all we have some errors in interpretation, that may lead to inappropriate further imaging, and now everyone is sort of knowledge about the effects of radiation. So not only the doctors, the families are also very much concerned whenever they subject the child to any radiation associated procedures. So we have to make sure that we acquire a good quality imaging, and also we have to give an appropriate diagnosis in chest radiograph if it is in line with the appropriate clinical question. So so before we go on to the imaging, we have to also have a small idea about what is image gently. So image gently is it's a protocol which has been within the LRA recommendation, which states that especially in pediatric imaging, especially in pediatric fluoroscopic imaging, we need to press gently the exposure parameters so that the child is not exposed much. So always we tend to keep this sticker which can be placed in the monitor or in the fluoroscopic pedal. So this is just to minimize the radiation dose to children. Yeah, and also image acquisition in pediatrics is often very challenging. Sometimes it takes the effect of like 3 adults to make the child in position. Yeah, and the children will be all the more apprehensive and scary. So it is very important to spend some time and reassure the children and also the anxious parents so as to what we are trying to achieve through this imaging. In this image, we are also having few representative pictures of what is called as pigostat. So this is probably used in the Western countries where sort of place the kids in a tube and they do not move and the chest is adequately exposed. And apart from that, we can also, there are also some distraction visuals which can be played so that the child does not get more anxious. So again, once again, we will be looking into case-based examples, and I need some interaction from the postgraduates. Okay. 1-year-old boy under evaluation for cough and cold for 10 days and fever for 5 days. So on examination, there is bilateral scattered crepitations and severe wheeze all over the lung fields. So what are we looking at? You can also tell the diagnosis straight away. So so here we are looking into, so definitely this, in chest radiograph, whenever we localize a lesion, we tend to say it is not lung lobe, it is lung zone. So definitely the left, middle and lower lung zones, there is opacification. It is sort of an inhomogeneous opacification, just sort of fanning out. So So this usually results from suppurative peribronchial inflammatory changes. So wherein in chest radiograph we tend to see some reticulonodular opacities which may be patchy or confluent. So sputum showed gram-negative bacteria. I'm sorry for the, I think some error is there in the arrangement. Okay. So the diagnosis turned out to be bronchopneumonia. Okay. Next case, a 3-month-old under evaluation for fever, cough for 5 days. So the vaccines were given, but this is how she presented. And what are we looking at? On examination, there is bilateral subcostal retractions. So we do see this sort of opacity in the right upper lung zone. And after 3 weeks of antibiotics, the opacity is sort of cleared. And this is lobar pneumonia. And the most common organisms associated with it are Haemophilus influenzae B, Streptococcus pneumoniae, and Klebsiella. So what sign do we get in Klebsiella pneumoniae? Yeah, bulging fissure sign, very good, okay. So now next case, 2-year, 7-month-old boy, known case of chronic granulomatous disease under evaluation for cough and cold. So what are we looking at? There is definitely a lot of abnormality in the radiograph, which sort of has progressed because the child was treated with antibiotics only. Yeah. So what are we looking at? What else we can say from the history? The child already has an underlying immunodeficient condition. The patient has CJD. So this condition affects predominantly immunocompromised individuals. It turned out to be a fungal pneumonia. Yeah. So next case is 3-year-old boy who's a known case of steroid-resistant nephrotic syndrome who had breathing difficulty. And this is how we are looking at. So initially the chest radiograph started like that, and then it sort of progressed to form a uniform opacity. Yes, now this is an example for parapneumonic effusion. So the early signs include like obliteration of the costophrenic recess or the angle and a thin rim of fluid tracking up in a meniscus-like morphology like how we are seeing here. And it progressively ascends upon the chest wall. There may be an associated consolidation of the lung parenchyma also. So that's how it gets the name parapneumonic effusion. Yeah. So 12-year-old girl, right-sided chest pain under evaluation for 20 days. So this is how the radiograph was. And we sort of quickly took the patient to ultrasound also because they want us to tap the fluid. So this we can even evaluate in ultrasound also. This is pleural effusion, just to emphasize the importance of that. Yeah. Okay, the diagnosis is up for the next radiograph. Yeah. So in this case, 15-year-old boy under evaluation for fever, cough, and right side shoulder pain. So we were seeing this sort of a blunting of the right CP angle. Again, they asked for an ultrasound guided like pleural tap. Now when we looked into the ultrasound, it looked more like thick and septated. And after 3 weeks of rigorous antibiotic, the finding sort of resolved. And any pleural effusion which is infected, sort of having more of loculations and thick septations would qualify for empyema. Okay. So 9-year-old boy coughs since 2 years of age. Anything we are looking at? Much sort of obvious, an example we saw in the previous lecture. So sort of see these vessels or some linear reticular markings also fanning out here as well. Now the morphology here is sort of cystic, but here it's sort of tram-tack-like. So what this would qualify for? Bronchiectasis. Okay. This is more an easier one. Intermittent cough and fever. So this is situs inversus totalis. So we can see the cardiac apex all like turn towards the opposite side. And what happened to the gastric bubble? It is also on the opposite side. So you should, for exam point of view, we must know all the syndromic conditions associated with situs inversus also. Yeah. So one such syndrome is Cartagena syndrome. And one more is, which one? Young syndrome, yeah. Okay, 11-year-old girl under evaluation for cough and breathlessness for 2 days. This is also sort of an easier one. So what are we looking at? Some things are going into the hemithorax. So after surgery, it's got resolved. It is example for congenital diaphragmatic hernia. So the two main hernias which we have to know and the differentiation between it is very important for an exam point of view. Yeah, so 9-year-old girl under evaluation for fever for 3 months and also has generalized lymphadenopathy. Isn't there some mediastinal widening? Okay. What is this? Again, CT coronal images, we are able to see those mediastinal big areas, probably lymph nodes. So this turned out to be like tuberculosis. There was a supraclavicular lymph node which was biopsied, and apart from that, any other thing we are seeing here, just I'm asking out of interest, has nothing to do with this lecture. Some aberrant origin, artery. So this vessel is sort of tracing up and it was going here. So this is ARSA. Okay. So 4-year-old girl for under evaluation for cough for 1 month. On examination, there was normal vesicular breath sounds. Is it normal, abnormal? Yeah, this is normal because whatever opacity we are looking at is the Sale sign. Yeah, so the thymic Sale sign which we tend to get. Okay, which is caused by the lobulations of the thymus. It progressively regresses with age. If at all we have any doubt, we can take the patient for an ultrasound and we'll be able to see starry sky pattern in ultrasound. Okay, 2-day-old neonate. Chest X-ray taken for mild respiratory distress. What is this abnormality? What is happening? Yeah, so isn't the diaphragm assuming an abnormal contour and the heart sort of placed upwards? So what is happening with the diaphragm? Diaphragm is weakened. It is not, there is no defect, but that is weakened. The weakening is called diaphragmatic eventration. So any associated conditions that we know of, diaphragmatic eventration, it is volvulus. We also have to rule out gastric volvulus. Yeah. So 16-month-old neonate, chest X-ray taken for LRTI, and what are we looking at here? Is there something abnormal? So I just want to emphasize the importance of this trachea, whatever is happening. Sometimes in neonates, we do get to see this sort of tracheal shift. That entity is called as tracheal buckling because trachea is sort of mobile and very tender at the early age, and it tends sort of move to the left or right. Most commonly it moves anterior and to the right, and that's what is called as tracheal buckling. It's nothing abnormal. Okay, 8-day-old neonate. Now we know this chest radiograph is abnormal, but some of us had reported an additional finding out of enthusiasm because what else do you think went wrong? And this is respiratory distress syndrome, definitely. But the thing is that sometimes we tend to see this kind of lines. So one of the complications of RDS is the patient developing pneumomediastinum or pneumothorax. We thought this might be that, but it is just actually a skin fold, which is commonly seen in preterm neonates, and we have to make sure we know this entity instead of documenting as possibility of pneumothorax. Okay, this one. 9-month-old, chest X taken for respiratory distress. So there is this lucent area here. The lung, adjacent lung appears sort of pushed. So why do you think this lucency is there? Yeah, the condition is called as CLO, congenital lobar overinflation, which is the most common lung lobe involved. It is the left upper lobe. Here we are seeing somewhat involving the right middle lobe, but commonly it involves the left upper lobe. Okay, this example was put in the morning session. Excessive drooling of saliva with respiratory distress. What is more obvious here? Coiling of the NG tube. So it should be esophageal atresia. Yes. Okay, this 12-year-old girl under evaluation for repeated episodes of LRTI. What do you think here? Something is abnormal is going on, probably some fluid levels are what is seen. But the patient was having repeated episodes of LRTI. So finally, they had a lot of radiographs which showed this persistent of this finding. And then we took a CT, and the CT, this is how it looks. some fluid levels, some hypoic areas, and there is one artery coming, a systemic supply. So this would be CPAM with sequestration, a hybrid lesion. Yes, chest X-ray taken in a syndromic child. This is what the history was. Any abnormality? Anything quickly we'll be able to observe here? Okay, again, basics, trachea is normal, hilum is normal, cardium distal is normal, these diaphragms are normal, chest wall, everything appears to be normal, ribs are normal. Ribs are normal? Are really ribs normal? What are we seeing here? Yeah, there is inferior rib notching. So the patient had neurofibromatosis. The patient also had coagulation of aorta. Yeah, so also pay close attention to all these rib signs also. Yeah, so take home points, chest radiograph remains a workhorse for pediatric imaging, and we have to avoid room for error. We have to know the normal and also the abnormal variants very clearly. And yeah, in pediatrics it's challenging, but with practice and with repetitive learning, we can make things better. Thank you so much. Thank you.
Thank you, ma'am, for the very engaging talk. May I now request Dr. Adya Kinkar Panda to kindly facilitate Dr. Aishwarya. Now, building on those insights, please join me in welcoming Dr. Basanta Manjari Swain on stage. Madam heads the Department of Radiodiagnosis at IREP Bhubaneswar. She is a veteran radiologist and will be sharing her experience and insights with a lecture on tubes and lines in chest radiography.
Good afternoon. Are you all sleepy? So now we will be dealing with lines and tubes in chest radiograph. All of you know that chest radiograph is the one of the most frequently performed imaging modality in hospitals, and beyond evaluating the cardiac and pulmonary pathologies, its role is most important in assessing the position, complications of the life-supporting tubes, catheters, and monitoring lines in critically ill patients. So the correct placement of these tubes and devices is essential for effective therapy and patient safety. So wherever there is malposition, this can lead to significant morbidity and also sometimes mortality. So it is all the radiologists should know what are the importance of these lines and tubes in chest X-ray. They should assess this properly and report. Now all of you know that chest X-ray is done in AP view in critically ill patients in the ICU or in the bedside. So here what happens, the beam traverses only 40 inches, whereas 6 feet in PA view. So the heart is magnified, and also the nasogastric tube and other things, they may be malpositioned due to the rotation of the patient. All of you know what the PA versus AP view. I am not going into detail. Now coming to the lines and tubes, we will be discussing on its functions, correct position, malpositioning, and its complications. A little bit of tracheobronchial anatomy, you know it. In this, the carina is the most important point. It is the most important reference point for, to evaluate all these devices, and the level is at T4, T5 level. First is endotracheal tube. Endotracheal tube, you know, it is inserted for ventilation of both the lungs and for prevention of aspirations. ET tube is fixed in the mouth, and so we must take it in neutral position. And the important point here is, this is always in the trachea, and there is a cuff which inflates and keeps it in position, which is not seen in the radiograph, but this we can see. And it should be always 5 to 7 centimeters up in the carina, and it should cover only 2/3 of the trachea. And these ET tubes, they are inflatable cuff which forms a seal against the trachea. These cuffs are not visible radiologically. If the carina is not visible, then the ET tube should be at the mid-level of the clavicle. That is the normal position. So here the tube is in normal position or abnormal position. This is the tube in normal position. And here the tube is almost gone beyond the carina to the right main bronchus, but there is still no pathology. Here it has traversed to the right main bronchus, and you can see there is obliteration of the left main bronchus, and there is total collapse of the lung and also mediastinal strip to the left. So this is a major complication. Sometimes when we introduce these devices, there is barotrauma. We will encounter the surgical emphysema, pneumothorax, and pneumomediastinum. Now this is the pictorial diagram: surgical emphysema, pneumomediastinum, and pneumothorax. Coming to tracheostomy tube that provides secure airway directly into the trachea, bypassing the upper airway. This is kept for prolonged ventilation, airway obstructions in the tumor and trauma, and airway protection in neurologically impaired patients. So here again, these are the different parts of the tubes. This is the flange which is fixed, and we will see this tip. So unlike the endotracheal tube, here this is to lie midpoint between the upper end of the tube, or that is insertion point, and the carina. This is at the level of the clavicles. So here you can see this is the ET tube position, this is the flange, and this is the cuff, and this is the tip. So it should be above the carina. Now what are the complications? They are the bleeding, drainage to damage to the esophagus, and also mucus and fluid buildup will be there. Next is a little bit about the esophagus. You know, esophagus lies left of the trachea and towards the right of the aortic ductal. Then it traverses the midline and goes up to the GE junction. So the nasogastric tube that is inserted either for feeding the patient or for aspiration of the gastric contents, and for this purpose the tube should lie within the stomach, and it should be ideally 10 centimeters away from the GE junction. Here again we will see this tip only. What are the complications? If it is inserted into trachea or bronchus, there may be pneumonia or pulmonary lacerations, and pharyngeal or esophageal perforations. So is this tube in correct position? So this is the nasogastric tube placed in the stomach. Next is, here you can see this nasogastric tube is looped on itself, and it is at the level of the clavicle. So if you give feeding in this, then there will be aspiration. Here the nasogastric tube is the right main bronchus instead of staying in the esophagus. So it has to be repositioned. Now coming to the Here again, you can see the tip is lying at the G junction. This is a very unstable position. It can be easily displaced, so we have to again reposition it. Little bit of vascular anatomy. Here this is the right internal jugular vein and the right subclavian vein forming the right brachiocephalic, and this is the left brachiocephalic vein and the carina. So we will be discussing on the central venous catheters. This is used in the positioning of the tip of the central venous catheter should be within the superior vena cava. It is considered acceptable for most short-term uses, such as fluid administration or monitoring of central venous pressure. This is placed for purpose of long-term for chemotherapy or may be placed more inferiorly at the cavo-atrial junction. So you can see the position here. You can see this is the central venous catheter. And this is a long-term catheter that is used for a long time for giving chemotherapy. This is a totally implantable central venous access device that follows long-term intermittent vascular access, typically for chemotherapy, parenteral nutrition, and frequent transfusions. So this tip should be at the cavo-atrial junction. Another one is the PICC line or peripherally inserted central catheter. That tip also should be lie in the cavo-atrial junction. It should be below two vertebral bodies below the carina. What are the complications? This peripherally inserted central catheter is correctly located with tip at the level of the cavo-atrial junction, approximately the height of two vertebral bodies below the level of carina. This is often considered a preferable location for long-term catheters. This is the right subclavian catheter that is positioned with tip in the superior vena cava. Positioning, it is rightly placed, but you can see there is something here. There is pneumothorax, so due to injury to the pleura. Here again, you can see the tip is placed in the left brachiocephalic vein, and sometimes you have to take care of the double SVC, left-sided SVC and double SVC, that also you have to see. Then coming to the Swan-Ganz catheter, these are flow-directed balloon-tip pulmonary artery catheter used for hemodynamic monitoring. It measures pulmonary artery pressure and pulmonary capillary bed pressure. So this usually follows venous valve, right atrium, right ventricle, and pulmonary artery. It should be located in the main proximal right or left pulmonary artery, usually at just within 2 centimeters of the hilum, not beyond the midlung or peripheral third. It should be just at 2 centimeters of the hilum. So to avoid complications, the tip of the Swan-Ganz catheter must not be more than 2 centimeters from the hilum. This is the pulmonary artery catheter, you can see. This is a post-op case. The complications are intracardiac knotting, pulmonary artery perforation, arrhythmias, cardiac perforation, and placement in the IVC. Next, pacemakers. Pacemakers are used in cases of severe sinus node dysfunction, complete heart block, and various arrhythmias. They have two main elements, a pulse generator and a lead with electrodes. This is the pulse generator, this is the lead of the electrode. And they may be single lead, double lead, and triple lead. Single lead, that will, the tip will be at the right atrium. Double will be at the right atrium and right ventricle. and triple will be right atrium, right ventricle, and left ventricle. So these are the examples of single chamber pacemaker and double chamber pacemaker. One is at the atrial head and another is at the ventricular head. And this is the Twiddler syndrome. Here again you can see there is tear of the pacemaker lead. This is the complication that you have to look at. This is Twiddler syndrome, that is dislodgement, also known as Twiddler syndrome, is a complication of implanted cardiac conduction devices due to patient manipulation or pulse generator, typically diagnosed on plain chest radiograph. This is the example. Then implantable cardiac defibrillators, they are usually recognized by short wide electrode on one or both leads. One electrode is in SVC and the or brachiocephalic vein, and other is in the right ventricle. Then coming to intercostal drainage tubes, this tube lies between the visceral and parietal pleura. It is directed anterosuperiorly in the, for drainage of the pneumothorax and posterior-inferiorly in the pleural effusion. This is the triangle of safety where you can insert these tubes, and this is hangala. So this is the underwater seal bag ICD kit. Then precautions we have to take that these drain holes should be within the pleural cavity. It should not be outside in the outside the pleural space or in the soft tissue. If we place this in the lung parenchyma or place in the interlobar fissure or in the mediastinal or abdominal viscera, here you can see this is the pneumothorax. The tip is anterosuperiorly placed, and this is the visceral pleura and parietal pleura. This like this you have to put. This is again pneumothorax. And there is another Hemlis valve. This is a one-way flutter valve used to allow air or fluid to exit the pleural space while preventing backflow into the chest. So these are used in the emergency or ambulatory patients. These tubes appear like this. That is, there is only one bay route. And the other end is temperature probe. Temperature probe is placed at the mid-esophagus to monitor the temperature in critically ill patients and in also operative cases. So here you can see that one is esophageal temperature probe and other one is the nasogastric tube. Esophageal temperature probe is within the esophagus and nasogastric tube is in the stomach. These are the intra-aortic balloon pump. They are used in cardiogenic shock when the ejection fraction is less than 20%. This is, the tip is identified by a small metallic rectangular marker which should be pointed slightly to the right of the region of the arch. This is how it looks like. And here you can see the tip of is in the, this is the tip. Now in the pediatric case group, we have got two catheters. One is the umbilical vein catheter and the other one is the umbilical artery catheter. And umbilical vein catheter that passes through the umbilical vein to the left portal vein and then to the, through ductus venosus to IVC. The tip is at the IVC below inferior cavital junction at T10 and T11 level, and for long-term use can be inserted into suprahepatic IVC, that is T8, T9 level. If it is malposition, then it can lead to portal vein thrombosis or potential liver infarct. If the lead is at right atrium or right ventricle, it can lead to arrhythmia. This is umbilical artery catheter that is inserted through umbilical artery and passes into internal iliac, common iliac, and then to the abdominal aorta. This tip can be at T6 and T10 level. So these you have to remember. These are the desired positions of the different tubes and lines you have to remember and identify. There are some implantable loop recorders known as insertable cardiac monitors. They are small insertable devices that continuously monitor and record cardiac rhythms. They are placed subcutaneously and used for the evaluation of patients with recurrent and unexplained episodes of palpitations or syncope. So can you identify these different tubes? What is this? ET tube. This one? This green one? What is this one? And this? What is this line? So that is central venous catheter. So the take-home message is we should all be familiar with the different tubes, lines and devices, and we must locate the normal position, and any deviation or any complication, we have to be aware of it and report it. Thank you.
Thank you, Doctor, for reinstating the importance of our fundamentals. I would now request Dr. M.V.K. Rao, sir, to please felicitate Madam. Moving on, we are pleased to welcome back Dr. Aishwarya to tell us about the current concepts of interstitial lung disease and the role of multidisciplinary discussions.
Okay, hi. Okay, so we'll be quickly looking into the current concepts in interstitial lung diseases and the role of multidisciplinary team discussions. Again, I want it to be very interactive sessions because I have collected cases accordingly. So you can try answering the cases. So interstitial lung diseases on a broader perspective have been classified so and so. The recent update has been from the ATS ERS ILD classification. And there are also major changes listed within. For example, there is bronchocentric interstitial pneumonia, there is alveolar macrophage pneumonia, so on and so forth. But for a postgraduate level, at least we must have a clear understanding of these four varieties of ILD classification. So we'll be looking into it one by one. So first looking into idiopathic interstitial pneumonias. So they can be classified into fibrosing, smoking associated, acute, subacute, rarer causes and unclassifiable causes. So in this, where do we stand? So what is the role of radiologist? They play a vital role not only in just gauging what kind of pattern the ILD is of question, but also we may want to correlate clinically with the other symptoms of the patient, if the patient is having any autoimmune conditions or any other specific findings, so that we can correlate and give an appropriate pattern. Because ILDs are per se very confusing. We tend to confuse lot of patterns with one another. So just to have a clear idea, the idea of MDT discussions is very important. So let's take an MDT. So case 1, I just need any one of you from just to take this question. So 65-year-old gentleman with cough and breathlessness for 9 months. So I'm just going to scroll up above from in a cradiocaudal axis. Just look at the findings. So what are you looking at? So what are we looking at? Yes? So definitely there is some fibrotic changes. Okay, there is traction bronchiectasis, there is reticulation, and also what else we are looking at? Anything more? Honeycomb, there is honeycombing also. With all these three put together, what is the most important pattern? UIP, very good, okay. So let's say this is UIP pattern, okay. So among these three, you will choose option 1, okay. So, so how does UIP and IPF being related to? So a pattern of ILD on HRCT which suggests UIP with no identifiable cause is IPF, right? So this was how it was discussed in MDT. Now we also got to see how the patient looks. This is how the patient imaging is. So what are we observing in this patient? Okay, something is odd. The patient is having sort of albinism. The patient is having oculocutaneous and yeah, a lot of albinism features is there. Okay, right? And also some oral, perioral albinism is there. Okay, so this was what the information we got. So we sort of started thinking about the different causes of UIP. So what are the different causes? It can be IPF per se, collagen vascular disease, chronic hypersensitivity pneumonitis, drug toxicity, asbestosis, or some familial forms. Any syndromic conditions you can think about in conjunction with what patient history we saw? Yeah, you can just answer, try answering. Yeah, we saw UIP pattern, and with the patient history, what do you want to say? So this turned out to be what is called as Hermansky-Pudlak syndrome, which is oculocutaneous albinism, bleeding diastasis, and pulmonary fibrosis. Okay, so UIP can be, the three hallmarks of UIP is honeycombing, reticulation, traction bronchiectasis. And if honeycombing is not there, we move into probable UIP, and so on and so forth, like indeterminate pattern and non-consistent patterns also. So this is how the different sets of imaging of how UIP, typical UIP would look like. There is honeycombing, reticulation, traction bronchiectasis, and all put together this forms a typical pattern. Okay, what is indeterminate? Indeterminate will not have honeycombing. So this is how it looks like. So one other case, 60-year-old smoker, mucoid expectoration, cough, clubbing. What do you want to say about this? Just you can give it a guess. So what is happening in the lung basis? What is happening in the lung basis? Some fibrosis is there. What is happening in the lung apices? Very good, someone told us emphysema. Okay, so is there a condition in which this both can coexist? Very good. So this is combined pulmonary fibrosis and emphysema, which is smoking related ILD as well, and it can be, it can have a worse prognosis than IPF. Okay, now what is this? Is it typical for UIP? Is it something else what we should think of? So it is also very empirical, it's very tricky whenever we have to classify what honeycombing looks like, what is emphysema, and what are isolated cysts. How will you differentiate? All this will be so much confusing, these three entities, isolated cysts, honeycombing, and emphysema. So emphysema tend to has a very thin imperceptible wall, that's how the definition goes. Honeycombing is thin walled cyst which share the walls, and there should be somewhere between 3 to 10 mm in measurement, and isolated cysts are isolated cysts. So in this pattern, are you seeing the cysts being coalesced to form larger cystic areas? So this is a condition which is called as AEF, which stands for airspace enlargement with fibrosis. Right, so this is airspace enlargement with fibrosis. It's also a different entity, but this is one more thing which you can think of and probably ponder your thoughts upon. Yeah. So HRCT is also used to prognosticate patients with IPF. How? We can definitely assess the extent of honeycombing, and also we can monitor the worsening of fibrosis in HRCT. Another case. So yeah, by 2013, these two images were taken. By 2014, these two images were taken. What is the difference between these two images? Definitely there is a lot of fibrosis, but what else is happening? Are we seeing some additional white areas in between these fibrotic components? These areas were clear and now we are seeing some consolidation. So what does it actually mean? Yes? Organizing, not really. So the patient presented with acute exacerbation of the underlying ILD per se. So this is how we can opine it as, but we should give a close differential of underlying infection, which they have to rule out by BAL or TBLB, and then you can probably give it as a probable acute exacerbation. Right, yeah. So these are the diagnostic criteria for acute exacerbation. Among this, you can see new ground glass opacities and consolidation superimposed in UIP pattern. Yeah, so that is something we should think about. You can also refer to these references which I have quoted below. Okay, another case. Quick, I need we have a lot of cases to go through. What do you think it is? Okay, is it NSIP or it is probable UIP? It is again a confusion, right? So it can be, yeah, so in this case it is NSIP. NSIP, do you think because of what? Sorry? Yeah, I mean NSIP can be due to a variety of causes. Why do you think, can you ascertain a cause? Because we are seeing one specific additional finding in this case. Very good. The esophagus is dilated, so very good. That is all. Scleroderma. So the pattern is NSIP and the diagnosis is CTD related, which is scleroderma. Yeah. So NSIP can also be due to drug toxicity also. So this is how it occurs. It sort of forms a bronchocentric pattern of ground glass opacities. 63-year-old gentleman in fodder making business. This is how his CT looked. Yeah, but over a period of time it progressed to what is called as like this. What are we looking at? Sorry? Yeah, it is hypersensitivity pneumonitis. What pattern are we seeing here? Very good, yeah. So this is 3 density sign where we are seeing normal lung, abnormal lung, and also areas of air trapping. All these put together is fibrotic HP. Another case, what is this? We are going in a graded, so you can just very bravely guess the answers here. This is, so since we saw fibrotic NSIP, this is non-fibrotic HP. So are you able to notice some lobular areas of air trapping, absence of fibrosis with diffuse ground glass opacities? It is non-fibrotic HP. So hypersensitive pneumonitis can be due to any hypersensitive reaction which is happening in the airway and interstitium. Historically being classified as acute, subacute, chronic, but now do you think this is being used? No, this is not being used. Now we are using fibrotic and non-fibrotic HP, each having their own typical, compatible and indeterminate pattern for evaluation. Yeah. So what is this nodular distribution? What do you think this is? Centrilobular, perilymphatic or random? Centrilobular, okay. We are not seeing any other fibrotic changes, so we do take help of this chart and ask what else we can look into. So this chart says alternative diagnosis, which is there way back in our IPF table. So according to this, we are definitely seeing profuse micronodules. So how do you go about it? Once you see micronodules, how do you go about it? This is how we can classify. Perilymphatic, random, centrilobular. If it's centrilobular, these 3 might be the possibility. Okay. So again, going back to the same patient's upper lung sections. Now what do you think this is? RBILD, HP or infections? Of course, we need history, but this same patient had some exposure history. Now that I say that, this becomes qualified for HP, right? But how do we differentiate this from RBILD? So the findings are similar, only thing is that the nodules will be more extensive in HP, right? So this is smoker, where you can see the difference. Still some nodules are there, but not as much extensive as in allergic, extrinsic allergic alveolitis. Diagnosis, this is a spotter. Sarcoid, yes. Why? Perilymphatic nodules, peribronchovascular thickening, sarcoid. Very good. Okay. Yeah. These are two patients, different patients who have malignancies, and they have been treated with therapeutic agents, and they are showing some lung findings. What is happening with this patient here, and what is happening with this patient here? The case 1 patient, what is being arrow marked as? Are you able to see a pattern? Yes, very good. OP. Why OP? Arcade perilobular fibrosis is what is happening. You can see this, this pointer is getting dulled out. Yeah, you can see this arc-like areas of fibrosis is happening. And what is happening in another patient is that the patient has developed something called as ARDS, upper lobe consolidation, lower lobe ground glass opacities. So that all these can happen with chemotherapeutic agents. So this comes under drug-related pneumonitis. Okay? Yeah. And next case, 45-year-old, CTD symptoms, dermatomyositis profile is strongly positive. What do we see? We can just sort of guess out the answers from this group, something like that. So what does the first image say? What sign is that? Yeah? Straight edge sign, very good. Next is? Very good. Okay, anterior upper lobe sign. Yeah? Next is? Very good. That is all you need to know. So we also have this paper which says the sensitivity and specificity of each of these signs. So it helps us in identifying CT-related ILD better. One more entity, it is called as IPAF, interstitial pneumonia with autoimmune features, in which there might not be a clinically, patient might not have CTD findings, but might have some serological positivity and lung findings. So this would qualify for what pattern? There is no honeycombing, so just some reticulations and ground glass opacity. So very good, it's NSIP pattern. Okay, this one, this is classical. Yeah, so very good, this is OP. Okay, this one, ground glass opacities, peribronchovascular cystic changes, very good, lymphoid interstitial pneumonia. LIP seen in which conditions? Malignancy, Sjogren's, yeah, and retroviral positive patients as well. Okay, fine. So finally we have something called as ILA, in which we tend to see some findings in CT, but not really, we don't know what do they really stand for, but ideally they should occupy at least 5% of a lung zone, and yeah, they may progress over 5 years in 50% of the individuals. So they can be classified as non-subpleural, subpleural fibrotic, and subpleural non-fibrotic, and these how differently they may appear. We might have seen these abnormalities, some random cases or some basal sections of the lung when the patient is being screened for any abdominal pathologies. So they can be very boldly classified as ILA, and they can be kept under follow-up just to see if they're progressing or not. So take home messages is decoding ILDs is often challenging. We need to have a basic understanding of concepts. Now the cases put here are classical cases, but this might not be the exact scenario when you usually deal with on a daily basis. So just have thorough understanding of the pattern, just keep on seeing the cases, and the most important best way to learn is to have a good MDT discussion and learn from the clinicians as well. Thank you very much.
Thank you, ma'am, for that very encouraging and engaging discussion. Our next topic is on the assessment and current approach to lung nodules. I would like to invite Dr. Sudhanshu Shekhar Mohanty to the dais for the same. Sir is an associate professor at IREP Bhubaneswar with years of experience and several publications to his name. The stage is yours, sir.
So, Coming to my topic, long nodule assessment and current guidelines. So, the solitary pulmonary nodule are defined as relatively well-defined round or oval pulmonary parenchymal lesion equal to or smaller than 30 mm. And this should not be associated with lymphadenopathy, atelectasis or pneumonia. So depending upon the size, they can be divided into miliary, micronodule or nodule and mass. If it is less than 2 mm, it is called as, these are called as miliary nodules, and less than 6 mm are micronodules, and 6 to 30 mm are nodules, and masses more than 30 mm. Based on morphology, they can be divided into solid, partly solid and ground glass nodules. Then based on distribution, they can be centrilobular or diffuse, juxtapleural or subpleural, and can be perilymphatic or random. So they can be due to based on the etiology, they can be neoplastic, infective, inflammatory, congenital, and others. Coming to the neoplastic etiology, can be benign or malignant. Benign are like hematoma, chondroma or endometrioma. Malignant like primary lung cancer, solitary metastasis, lymphoma or carcinoids. Carcinoids can be bronchial or peripheral pulmonary carcinoids. And even infective causes can be granuloma, tubercular or mycetoma, aspergilloma, hydatid, lung abscess or round pneumonia. In congenital causes like arteriovenous malformation can be long cyst or bronchial atresia with mucoid impaction or sequestration or CCAM. So inflammatory can be rheumatoid or pulmonary inflammatory pseudotumor like plasma cell granuloma, sarcoid or Wegener's granulomatosis, and others which are like miscellaneous nodules can be infarct or intrapulmonary node or mucoid impaction or hematoma. So imaging are used for nodule assessment are like chest radiography, CT, MRI and FDG PET CT. However, in chest radiographs, nodules less than 9 mm could not be assessed, could not be visualized. So CT scan is the best modality for assessment of long nodule. And MRI is relatively costlier, so better CT scans are used for the long nodule assessment. So what are the mimickers of nodules in chest X-ray? They are like nipple shadow, skin lesions or pleural waste lesions, chest wall lesions or artifacts. So next, coming to the differentiation between benign and malignant nodules. So these are based on size, shape, margin, growth, calcification, air bronchograms, solid and ground glass component of a nodule, and then contrast enhancement. Coming to the size, Swenson et al. Have studied make a study where they have found the relationship between the size of a solitary pulmonary nodule and percentage of malignancy, and they found like less than 4 mm nodules having malignancy approximately 0%, and 4 to 7 mm nodule associated with 1%, 8 to 20 mm up to 16% of malignancy rate, and more than 20 mm are approximately 75% of malignancy. So depending upon the growth, they can be divided into malignant and benign and malignant. So for assessing a malignant nodule, the nodule should be assessed with the previous imaging. The size of the nodule should be assessed in comparison to the previous imaging. And duration of stability, it also depends upon the duration. Like for solid nodules, 2 years is taken as the period of stability. If after 2 years the nodule size doesn't change, then we can say a nodule is stable and no follow-up is required. For soft solid, it is 3 years. And for malignancy, the malignant doubling time is 20 to 400 days. So if it is less than 400, then definitely the nodule is malignant, and it is 400 to 600 days volume doubling time, then it can be, it can be intermediate of category, but and more than 600 means it is benign nodule. So next, coming to shape, according to a Japanese screening study, which showed that nodules which have a polygonal shape, a three-dimensional ratio is calculated, which if it is more than 1.78, is a sign of benignity. And polygonal shape means a nodule having multiple facets or multi-sided nodule. A peripheral subpleural location also a sign of benignity according to this study. This is the image, this is the picture which is showing an axial image, axial long window image, and this is a polygonal nodule. This is the transverse diameter of the nodule, and this one is the coronal image which is showing the vertical diameter or longitudinal diameter of the nodule, and the ratio between these two nodules is called as three-dimensional ratio. And if the three-dimensional ratio is more than 1.78, means the nodule is a flat nodule, and flat nodules are categorized as benign nodule. Next, coming to the margin. Based on the margin, we can divide, we can predict as like benign or malignancy. So irregular margin or speculated margins are also called as corona radiata sign. They are signs of malignancy. This is the adenocarcinoma with multiple speculations arising peripherally. And lobulated or scalloped margins are of intermediate probability. They are to be followed up. And smooth margins are more likely benign unless metastatic origin. So metastatic nodules can be smooth, can have smooth margins, and carcinoids also have smooth margins. Next, coming to air bronchogram signs. So recent studies which have shown that air bronchogram is more commonly seen in malignant pulmonary nodules. Like this is a long window image which is showing an adenocarcinoma having a air bronchogram at the peripheral aspect with irregular margins. So it is the most commonly like bronchoalveolar carcinoma showing air bronchogram sign. And next, coming to the solid and ground glass component. In another result from the screening studies that nodules containing a ground glass component are more likely to be malignant. So in that study, they have found 63% of partly solid lesions with ground glass components are malignant, and only purely ground glass lesions, approximately 18% came to be malignant, and approximately 7% only solid lesions came to be malignant. So ground glass nodules are to be followed up more for a longer duration to rule out malignancy. So next, coming to contrast enhancement. Contrast enhancement less than 15 HU has a very high predictive value for benignity, and this is only applied for nodules which have more than which have sizes more than 5 mm, and they should be relatively spherical, homogeneous, no necrosis or no fat or no calcification, and no motion or beam hardening artifacts. In delayed images, the net contrast enhancement should be more than 25. The net contrast enhancement should be more than 25 HU in post-contrast images, and in delayed enhancement, there should be washout of approximately 5 to 31 HU. So this is the figure which is showing. This is the image which mediastinal window which is showing a nodule with pre-contrast HU of 45 HU and contrast HU of around 107 HU and delayed HU of around 78 HU. So this delayed HU is approximately 31 HU, so which is suggestive of a malignant nodule, and this came to be a adenocarcinoma. So next, coming to PET-CT. PET-CT also we use the PET-CT to assess the malignancy or benignity of a nodule, but thing is it has high sensitivity 95% but high lesser specificity approximately 81%, because false positive results also come in granulomatous disease. Approximately 20% of granulomatous lesions they show positive uptake, FDG uptake in PET-CT. If an SPN is larger than 8 mm, then patient is at higher risk for malignancy, then PETs can maybe used for further evaluation. And based on the internal characterization of a nodule, it can be divided into benign, it can be differentiated, benign and malignant nodules can be differentiated. So internal characterization like calcification, fat, presence of calcification or fat, cavitation, and feeding vessel sign or satellite nodule. Coming to calcification, They may be, these are all benign calcification pattern like diffuse, laminated, central, popcorn types of calcifications which are seen in the granulomatous lesions and hematomas. All other patterns of calcification should not be regarded as benign calcifications. However, diffuse calcifications may be seen in osteosarcoma or chondrosarcoma, and central and popcorn pattern may be seen in GI tumors and patients who have previously undergone chemotherapy. So these are a few calcification patterns associated with malignancy like amorphous. This is the image, axial mediastinal window image, which is showing amorphous calcification in a non-small cell carcinoma. And they can be, another pattern is dystrophic, where the necrotic areas may be calcified, this is called as dystrophic calcification. And eccentric calcification, which is particularly seen in carcinoids. This is an example, this is an image showing a carcinoid in right lower lobes with eccentric calcification, and schwannomatous calcification may be seen. These are peculiarly seen in metastasis of colon and ovarian tumors. So, if fat is present, they may be benign or malignant. Fat containing lesions are like hamartoma, lipoid pneumonia, and metastasis from liposarcoma. So, this is an example of hamartoma, well-defined nodule with a focus of fat in the periphery, in the mediastinal window. Next, coming to cavitation. So, benign lesions may show cavitation or malignant lesions may show cavitation, both of them. Whereas the wall thickness of the cavitation helps in differentiation between these two lesions. If wall thickness is less than 4 mm, they are likely benign, and 4 to 16 mm is indeterminate. They have to be evaluated, and more than 16 mm are more likely malignant. And smooth cavity, smooth wall is more towards the benignity of the lesion, and irregular are more towards the malignancy. So this is a nodule, this is a benign nodule with thin wall, and this nodule with a thick wall which came to be malignant lesion. So next, coming to feeding vessel sign. Feeding vessel sign is like nodule which is just associated with a vessel adjacent to it, and this can be an infarct or hematogenous metastasis, or it can be arteriovenous malformation, arteriovenous fistula, or it can be a septic embolus also. Next, coming to satellite nodule. Usually these are smaller nodules which are found adjacent to the larger nodule are called as satellite nodules. So they can be they can be malignant nodules, because in malignant nodules also there may be, due to adjacent infiltration, they appear as the satellite nodules. They can be seen in tuberculosis or sarcoidosis. In particularly sarcoidosis, it is called as galaxy sign, where main nodule is surrounded by multiple tiny satellite nodules. So next, coming to guidelines, there are two guidelines associated with pulmonary nodules. One is Fleischner guideline, which was published in 2017, and British Thoracic Society guideline, which was published in 2015. So according to Fleischner guideline, this guideline pertain to the follow-up and management of indeterminate pulmonary nodules which are detected incidentally on CT, and which is published by Fleischner Society. So nodule characterization, according to this guideline, nodule characterization should be performed on thin slice CT images which is less or equal to 1.5 mm. Since a small solid nodule may appear to have a ground glass density on thick slice due to partial volume effect. So to reduce the partial volume effect, slices should be less or equal to 1.5 mm. And this guideline includes, this has certain rules, and which is applicable only for 35 years or older people, and it is not applicable for immunocompromised patients or known or suspected malignancy patients. In this, according to this guideline, manual nodule measurement or volumetry is used to measure the nodule size. I'll go in detail how to measure the nodule size. Then it uses the thin slice, as I just told before one slide. So actually, depending upon the density of the nodule, nodules can be divided into solid, soft-solid, solid or soft-solid nodules, and soft-solid nodules again they can be divided into part solid or pure ground glass nodule. So this is the image showing purely ground glass nodule through which it is ground glass because through which we can see the structures, vessels, faintly see the vessels through the lesion. And this is the soft solid nodule which has an eccentric solid component and surrounding ground glass component, and this is a purely solid nodule. And most subsolid nodules are transient and they may be due to infection or hemorrhage. However, the persistent subsolid nodules often represent pathology in the adenocarcinomatous spectrum. Compared to solid lesions, persistent subsolid nodules have a much slower rate but carry a higher risk of malignancy. So they are followed up to 5 years according to Fleischner guideline. In a study by Henske et al., partly solid nodules were malignant in approximately 63% of patients, and in 18% of cases pure ground glass nodules came to be malignant, and approximately 7% cases solid nodules came to be malignant. So soft solid nodules are more carry a higher risk of malignancy. They have to be followed up for a later period, like up to 5 years. So next, coming to risk factors. What are the risk factors which are taken into account in Fleischner guidelines? Like history of heavy smoking and exposure to asbestos, radon, uranium, then family history of carcinoma, CA lung, and older age group are more risky for malignancy. Females are more common, more predominantly more than male population, then black more than white population, and nodule with spiculated margin and upper lobe location also has a higher risk of malignancy. Less than 5 nodules increases the risk of malignancy, and emphysema and idiopathic pulmonary fibrosis, they are also high risk for malignancy. Among these risk factors, history of smoking and older age group, then spiculated margin, upper lobe location, and family history of CA lung, they are high risk for malignant lung lesions. And patients having these higher risk factors are more than 65% patients may have the malignant lung nodules. So next, coming to the according to this Fleischner guideline, how to manage these solid nodules. The solid nodules, the Fleischner guideline divide the nodules into 3 categories based on the sizes of the nodule, like less than 6 mm, less than 6 mm, and then 6 to 8 mm, and more than 8 mm. So less than 6 mm nodule, if it is a single nodule in a low risk patient, low risk means younger patients and no history of smoking and no history of family, previous history of any lung cancer, or no history of any first degree relative having cancer, lung cancer. So these are all low history, low risk factors. So if a solid nodule less than 6 mm, a single nodule in low risk population, no routine follow-up is needed, and in high risk patients, optional CT should be done at 12 months. And if the nodules are multiple, in low risk cases, no routine follow-up is needed, and in high risk patients, optional CT is needed at 12 months. But if the nodule size is 6 to 8 mm and it is single, in low risk patients, CT should be done at 6 to 12 months. Then if the nodule persists, then we should go ahead with another CT at 18 to 24 months. And in high risk patients, CT is definitely to be done at 6 to 12 months, and then it should be done at 18 to 24 months to see the growth of the nodule. And if there are multiple nodules of these 6 to 8 mm sizes, in low risk patients, CT should be done at 3 to 6 months, first follow-up CT to be done at 3 to 6 months. And if the nodule size, depending upon the size of the nodule, then we have to decide for another next follow-up CT at 18 to 24 months. And in high risk patients, the same protocol is followed, but that is to be definitely taken, the second CT has to be definitely taken at 18 to 24 months. And if the nodule is size is more than 8 mm for a single nodule, both for high and low risk, because more than 8 mm nodule are high risk nodules. Independent of the presence of low risk or high risk, CT should be done. First CT should be done at 3 months. Then again PET CT or biopsy has to be undergone, followed by the CT. So, if the nodules are multiple in low risk patients, first CT should be done at 3 to 6 months. Then, depending upon the size of the or growth of the nodule, again follow-up CT has to be taken at 18 to 24 months. But in high risk patients, definitely it has to be taken at 18 to 24 months. So next is for soft solid nodules. So soft solid nodules can be ground glass or partly solid. In ground glass nodules, if it is less than 6 mm, no follow-up is indicated. But if it is more than 6 mm, more or equal to 6 mm, then CT should be done at 6 to 12 months to confirm the persistence. And if it is persistent, then CT to be done at third or fifth year. According to this Fleischner guideline, the ground glass nodules has to be followed up to 5 years, and it has to be because these are more associated with malignancy. And in part solid nodules, if the nodule is less than 6 mm, so no follow-up is indicated. And if it is more or equal to 6 mm, first CT should be done at 3 to 6 months to confirm the persistence. If it is persisting, then annually one CT should be done for 5 years. So for more than 6 mm nodule, we have to do every year one CT for 5 years if the lesion is persisting, to assess the growth pattern of the lesion. And if the subsolid nodules are multiple and less than 6 mm, in this case we need to be followed up. And first CT is to be done after 3 to 6 months, and if stable, then second and fourth years has to be two subsequent CTs have to be taken at second and fourth years. And if they are more or equal to 6 mm, then CT has to be taken 3 to 6 months. At 3 to 6 months, subsequent management is depends upon the most suspicious, based on the most suspicious nodule, and depending upon the growth of the nodule. So, how to measure the pulmonary nodule size? According to this Fleischner guideline, it has to be done based on the average of the long and short axis diameters of the nodule. And this should be taken on the same transverse or coronal or sagittal reconstructed image, whichever reveals the greatest dimension. So next come into periphyseal nodule. So they are also most frequently we come across in our CT while doing CT reporting. Like they can be typical, atypical, or can be either typical or atypical. So typical nodules are like solid homogeneous nodules with polygonal pattern and maybe oval or rounded, lentiform, or maybe triangular in shape. And these are typically seen within 15 mm of the fissure or the pleura. But atypical may or may not have contact with an interlobular septum. This is an atypical example. So this has a broad base towards the pleura, and other one is approximately 15 mm within the 15 mm of the pleura. And this is a typical pattern where it is polygonal or pattern and lenticular pattern. So these are typical periphyseal nodule, and they represent intrapulmonary nodes, and they may show the growth pattern also similar to a malignant nodule, but these are usually lymphatic in origin. So next coming to British Thoracic Society guideline. So according to this guideline, important issues are like higher nodule size threshold for follow-up, more equal to 5 mm or 80 millimeter cube or 80 cc. So according to Fleischner nodule, the Fleischner guideline, they 6 mm as the baseline, they take 6 mm as the baseline size. But here in the British Thoracic Society, they have taken 5 mm as the baseline nodule size, and they have reduced the follow-up of the solid nodule up to 1 year, and they have Fleischner guideline, they have taken 2 years as the follow-up period for a solid nodule, for solid nodules. So use of two malignancy here in this guideline, they use two malignancy risk prediction models to better characterize the pulmonary nodules. The same approach fluorophore nodules, nodules they have taken, like whichever are detected incidentally as well as detected through screening. But Fleissner Society, they take only incidentally detected nodules into consideration. So this is applicable for more than 18 years people, and it is same as the less than 1.25 or 25 mm slice thickness should be taken using the MIP images to assess the nodule in the CT while in the CT surveillance. In case of multiple nodules, risk assessment and follow-up is done considering the largest nodule as the reference, and according to this guideline, volumetry is preferred over the diameter of the nodule. If the volumetry is not available, then manual nodule measurements are to be taken and based on the simple nodule diameter. So simple nodule diameter is the largest nodule diameter. It is not the short axis, it is the long axis diameter of the nodule. So follow-up for 1 year is according to this guideline. If volumetry is taken into account, then follow-up is done year. While if manual measurements are taken into consideration, then follow-up has to be done up to 2 years. Less than or equal to 5 mm nodule sizes require no follow-up, and stable nodules show a volumetric change of less than 25%, and growth is considered if more than 25% of volumetry change in size. So if less than 25%, then this is a benign nodule. You can say there is no growth, and more than 25% of volumetry means there is definite growth of the nodule. And if volumetric doubling time is more than 600 days, then consider discharge based on the patient reference. So according to this model, this guideline, they have used 2 risk assessment models. One is Broke model and Harder model to assess the risk of malignancy. And this Broke model, they are used to assess the risk of the malignancy for solid lesions more than 8 mm and soft solid lesions that are stable during 3-month follow-up. So I have kept 2 slides. What are these assessment models, risk assessment models? And according to and Harder model is used when PET CT is used for to evaluate a nodule. So this is like Broke calculator. In this, this considers 2 characteristics. One is nodule characteristics and patient characteristics. In nodule characteristics, like nodule size and nodule count, type of the nodule, whether it is in the upper lobe, lower lobe, and then speculations are present or not. In patient characteristics, age, gender, family history, and emphysema. So these are the factors which are taken into account, and then risk probability of malignancy has to be calculated. In Harder calculator, PET CT has to be taken into account, has been taken into account. So in patient characteristics, it has the same age and risk factor, then any extrathoracic carcinoma is present or not. Then in nodule characteristics like nodule size, location, whether it is in upper lobe or lower lobe, then speculation present or not, then FDG PET activity, whether it is FDG mild, moderate or intense. So these are to be taken into account, and they also assess the malignancy, probability of malignancy. So this is a schematic diagram of British Society British Thoracic Society of guideline for lung nodule. So if a pulmonary nodule is more than 5 mm, they can be solid, either solid or soft solid. In solid nodules, they can be 5 to 8 mm or more than 8 mm. If it is 5 to 8 mm, then CT has to be carried out at 1 year or at 3 months based on 5 to 6 mm or 6 to 8 mm. Then we need to see the growth actually. As I told, like volume doubling time is more than 600 means it is a stable nodule, and then we can discharge the patient. If it is more than 8 mm, then risk assessment is to be carried out using Broke model, and if it is less than 10%, then again CT follow-up CTs are to be done based on the size. Then if it is stable, depending on the volumetry or size of the nodule, then patient has to be discharged. But if it is more than 10% risk in a more than 8 mm size nodule, then PET CT has to be done, and PET CT followed by PET CT. Harder model is once PET CT is done, Harder model is taken into account to assess the percentage of risk, and if it is less than 10% risk, then we need to do follow-up scans, and we have to see the how much of volume or size increase in the size of the nodule. So based on that, we have to decide whether we have to discharge the patient or taken into for biopsy or further workup or management has to be done. So next is soft solid nodule, and 3 months followed by a 3-month CT. At the 3-month a CT has to be done, and if it is stable, then again Broke model has to be according to Broke model risk assessment has to be done, and if it is less than 10%, then soft solid nodules has to be followed up to 5 years. So follow-up CTs have to be done at 1, 2, 4, and 5 years. If stable, then we need to stop the follow-up study. And if there is growth at the 3-month scan in a soft solid nodule, then again further workup and definite management has to be done, because soft solid nodules have more chances of malignancy, and approximately more than 65% of malignancy. So they have to be definitely managed if we are seeing any growth in 3-month scan. So these are the main guideline differences between the Fleschner Society and British Thoracic Guideline. This Fleschner Society, they predominantly focus on diameter, especially like 4 to 6 mm, 6 to 8 mm, or more than 8 mm nodules. But British Thoracic Society, they have a volumetric assessment rather than diameter. And Fleschner Society generally recommends follow-up for nodules more or equal to 6 mm in diameter. But BTS, they recommend follow-up for nodules more than 5 mm in diameter. Then Fleschner Society requires a significant increase in diameter, at least of 2 mm, to be considered a growth event. But this British Society uses a volume of more or equal to 25% as a threshold for growth. So if it is more than 25%, then we can say there is a significant growth in the size of the nodule. And Fleschner Society, they primarily based on the nodule size, growth, clinical risk factors. But in this British Thoracic Society, they integrate the clinical features with a nodule characteristic and risk prediction models like Broke and Hodder model to stratify the patients. And Fleschner Society emphasizes follow-up imaging for many low-risk cases. A stronger emphasis on biopsy or PET CT scans have been taken into account in suspicious nodules according to British Thoracic Society. These are my references. Thank you.
That was an excellent presentation, sir. Thank you. I now call upon stage Dr. Basanta Manjari Swen to felicitate sir. Now, we have Dr. Tapas Kumar Sahu, Assistant Professor in the Department of Radiology at IREP Bhubaneswar, who will speak about characterization, localization, and diagnostic workup of mediastinal masses.
Good afternoon, esteemed faculty, my colleagues, teachers, and dear students. Today, the topic which is given to me is a very common topic in radiology, commonly asked in long question and as a long cases also. So, let's dive into this. Okay, so we'll go through the topic under this subheadings, the Felsen classification, which is the conventional classification system to divide the mediastinum compartment. Then the international thymic malignancy interest group, which they divided based on the MDCT into 3 compartments, and then whatever the imaging modalities which we have to characterize the lesion and to localize and characterize the lesion. Okay, so first we have to decide the lesion it's a parenchymal lung or it's a mediastinal or pleural based. So how we apply? So let's apply the rule of epicenter. Epicenter rule, if you apply for the first lesion, the broad base is towards mediastinum and the angle if it's making with the pleural surface is obtuse. But for the parenchymal lung parenchymal lesion, it's opposite. It makes an acute angle and the epicenter, if you see the bulk of the lesion is in the lung parenchyma, the shadow we can see through the lung parenchyma shadow. So this is the rule. Whether it is X-ray or the CT, where is the bulk of the mass, the epicenter rule will apply. The next, the angle in the X-ray will apply, and some associated finding like bone destruction, like in posterior mediastinal tumor or extrapleural lesion, where the bone destruction could be there. And air bronchogram is a sign which will be seen in lung lesion, not in a mediastinal lesion. So the same thing, let's see. So what we have seen is like the obtuse angle and the epicenter rule. Apart from that, the bony abnormality, all those things would be in the mediastinal mass, but lung mass would be having air bronchogram. So let's see the case on chest X-ray. It's very clear that we can see the angle which is making with the pleural surface is acute here, and there are multiple, and this is a lung mass. And whereas these two category of lesion, first one is your broad base towards mediastinum. It's actually, there is mediastinal widening, and it is also making an obtuse angle with the lung. And the other lesion on your right side, that also making the obtuse angle, and we can see some bone destruction as well. So these are not extraparenchymal lesions. Okay, and based on the epicenter rule, if we apply, there is mediastinal widening, and the lung and the mass is protruding towards both sides of the lung, towards the hilum area. So that lateral border is very clearly seen. But the center where it is superior extension, where it is ending, inferiorly where it is ending, that we are not able to see because of the loss of silhouette. And the same thing, the consolidations, air bronchogram, those things will be in a lung origin, which suggests lung origin. Coming to the anatomic classification, above the sternomanubrial junction, that is corresponding to the T4 inferior end plate, above that is your superior mediastinum, and below that you can divide into anterior, middle, and posterior mediastinum. We'll come into that. Conventionally, Felsen, what he did was, he divided the line which is anterior to the trachea, anterior to it was anterior mediastinum, and according to Felsen, the heart lies in the anterior mediastinum. And 1 centimeter posterior to the anterior vertebral margin, where the middle mediastinum posterior boundary lies, and posterior to that is your posterior mediastinum. In 2024, the group, the International Thymic Malignancy Group, they came up with this classification where they divided the compartment into prevascular, where it's just anterior to the pericardium or the heart and the vascular structure, which is your anterior mediastinum, and they kept the bulk, the heart and all the viscera in the middle compartment, that is the visceral compartment, and the same thing, that paravertebral compartment is your posterior compartment here. So, stuck. Next. Okay. So let's try to see some cases where we apply these signs to localize the lesion on chest X-ray. So let's see one by one. So silhouette sign, silhouette is kind of, you can say it's a shadow. So whatever the structures which are in close proximity to each other, if they have the same density, then the interface is obliterated. So we'll call there is loss of silhouette. So in this case, it's a mediastinal mass. If you apply the epicenter rule and the angle, it's mediastinum, the broad base is towards mediastinum, and it is showing loss of silhouette with your hilum. Lateral film, in this case, not much helping. Maybe we can see there is a hilar density. Okay. Next, the X-ray sign, which is very important, is your hilum overlay sign. This sign we have seen already in today's many cases. So what does it depict is that if the mass is not in direct contact with hilum, then we can see the hilar vessel nicely through it. And what does it suggest is that the mass is not lying in the middle mediastinum, either it is anterior or posterior. And if you see in this case, the lateral view has been taken, and where we can see the loss of retrosternal clear space, and this is a anterior mediastinal mass. So coming to the next sign, the hilum convergence signs. So this distinguishes whether it is actually hilar mass or is a pulmonary artery which is enlarged. If we trace the arteries, it leads to the hilum. So that means it is your pulmonary artery enlarged, and there are associated signs of cardiomegaly. So in this case, it's a enlarged PA. It's a pulmonary hypertension case, not a hilar mass. And the same thing we are seeing on the lateral chest X-ray. These are the dilated, enlarged pulmonary arteries. Coming to the next sign, the cervicothoracic sign. this sign and the next sign, the thoracoabdominal sign, which we are going to see, here the anatomy holds key. So what is the basis behind is that the anterior mediastinum actually ends up at the level of clavicle, but the posteriorly the lung extend above the sternoclavicular junction. So if we can see clearly the the upper boundary, in this case, the lung interface is there. So that means it is posterior mediastinum. Okay. And based on the same principle, thoracoabdominal style is also described, where the posterior diaphragmatic sulcus, the costophrenic sulcus is deeper. So that's why if we try to appreciate, here is your lateral mass, lateral margin of the lesion, which is extending caudally, and we can see if it is anterior mediastinum, it will merge with the diaphragm shadow and we won't be able to see. So based on the same principle, both the signs are applied, because the posterior mediastinum has a craniocaudally longer course. So the lung interface makes it easy to see, to compartmentalize the lesion as posterior mediastinum. And the next sign, we see in such mediastinal masses, we see the obliteration of some lines and strips. Like in this case, this was the same case where we saw the pulmonary artery enlarged hilum convergence signs. So we can see here clearly the azygoesophageal recess, it's maintained here. But in one case where it is obliterated and we can see some lucence in this area, so what does it suggest? Let's see the lateral X-ray, and this is suggesting your hiatal hernia, where the azygoesophageal recess, so anything esophageal mass or any esophageal pathology will cause the obliteration of this line. And there are other lines, it may be very difficult to appreciate those anterior and posterior junction line. We see on the HRCT also these lines. And the commonly what we see on chest X-ray are these stripes on both sides of trachea, right and left paratracheal stripes, right and left paraspinal stripes, the descending thoracic aortic shadow, and the AP window. And we have already seen your azygoesophageal recess. So using all these signs on X-ray, we can categorize the lesion, whether it is coming from which mediastinum, with the principle of the loss of silhouette. Okay, let's see, we'll see some cases with case-based example. And coming to that ITMIG group of classification, where they divided the anterior mediastinum, the prevascular compartment, where the major content is your fat, thymus, lymph nodes, and left brachiocephalic vein. As we all know, in our textbook, we have read that those 4T, the group of 4T, the terrible lymphoma, thymus origin is your thymoma, and the retrosternal goiter, thyroid origin, and which one I forgot? There is one more T, terrible lymphoma, thymoma, teratoma, yes. So the germ cell tumor, because the ectopic, the germ cell also lies in the germ cell rest lies in the anterior mediastinum. So, and after that, coming to that visceral mediastinum, where the heart and the other viscera, like this trachea, esophagus, and the vascular structure, pericardial structures, heart, all those, and lymph nodes. So few structures are seen in all mediastinum, like the fat is seen in all mediastinum, lymph nodes are seen in all mediastinum, and mesenchymal tissue is also there in all mediastinum, and vascular structures. So some cases where we see all the compartment involved, like such a big liposarcoma will be involving multiple compartments, or lymphoma will be also having multiple compartment involvement. Vascular lesions like hemangioma, lymphangioma, we know that they have the transspecial. So multiple compartment they can also involve. Infection and hemorrhage, they also know no boundary, they don't know any boundary, they can also involve any compartment. And coming to the density of what we see on the CT, if it is a fluid density, then there can be a cyst, necrotic nodes. Based on the compartment, we can narrow down the differential, and vascular structure like aneurysm and hemangioma, those things will come. And in the fat containing lesion like thymolipoma, teratoma, all those things will come. And the extramedullary hematopoiesis in posterior compartment, that also contains your myeloid and fatty tissue, that also will be having fatty tissue. So those important lesions coming from this anterior mediastinum are those 4T, and lymphangioma can have any compartment involvement. Midgut, middle compartment, there is one foregut duplication cyst, that's one congenital lesion can be there in the middle compartment. One special point on this, that how we will differentiate between the bronchogenic cyst and enteric cyst. Both are the mid-foregut duplication cyst. The bronchogenic cyst will have the location commonly at the subcarinal region or right paratracheal region, but the enteric cyst will have, it's closely awaiting the esophagus. And as they will have the ectopic gastric mucosa, they can be symptomatic, and the gut signature will make the wall thick, and the patient with peptic ulcer can present and become symptomatic. But these are usually asymptomatic, and they, unless they are very large and extensive compression it's causing, then it is symptomatic. So let's try to see some cases. What we do, the same epicenter method we apply on the CT also. So actually this was a case of thymic CA. The epicenter, the bulk of the lesion is in the anterior mediastinum, but it is extending posteriorly to the middle mediastinum as well. It is a huge liposarcoma, like in the retroperitoneum we see huge mass, fat containing and soft tissue density also there. So this kind of lesion can occur here also. And this is a neurogenic tumor which is in the posterior mediastinum, and we can see some foraminal extension which is better appreciated on MRI. So let's see by case-based example. So this is a young patient, 25-year-old, and has the history of chest pain. And let's try to, first let's decide which it's a lung mass or mediastinal mass. It's mediastinum widening is there. Then let's apply the rules, the Silhouette rules. So it has very well-defined lateral border because it has a very clear interface with the lung. The soft tissue and lung, they have the contrast, so we can see the lateral margin very well. But the superior extent and inferior extent we not able to see because the loss of silhouette with the soft tissue structure of the mediastinum. And then using that rules, if we utilize those rules, let's see where it is falling. We are able to see the descending thoracic outer shadow, so that means it is not posterior, right? And the whatever we can see, these are the SBC shadow and your aortic arch shadow. So that means it is no middle mediastinum also. And further we can see nicely your trachea. We can see there is no paratracheal widening. So this is also confirming that there is not a middle mediastinal lesion. And lateral confirms that the loss of retrosternal clear space. And on CT, it was having very homogeneous soft tissue density lesion. And as a young patient, and this case came out to be Hodgkin lymphoma. So some cases where anterior mediastinum, those 4D group falls, the people who are having this lymphoma, they are usually fall in the younger age group. And seminoma and your other teratoma, germ cell tumor, those all can be seen in a young male predominantly. And the tumor markers like alpha fetoprotein, beta HCG, those can also help us to narrow down the differential. But the thymoma and the thymic CA, those are more predominantly in the elder group, above 50, and they can have, like thymoma would have a very well-defined lobulated margin, but thymic CA will be more of invasive. So they will invade adjacent structure, and we can have some pleural deposits and even distant metastasis in that case. So let's come to the next case where let's try to see where is the structure lying in the mediastinum. So in this, we may be able to see some outer pulmonary window, some convexities there towards lateral side. So this is your AP window. So normally how the AP window is seen is that normally it makes a concave margin towards lateral side. And in this case, what we are seeing is there is little widening and convexity towards lateral side. So what makes it is that the location we can now tell is that it's middle mediastinum structure. And then what other thing we are seeing here, there is some effacement of the trachea and the left main bronchus. Also narrowing is there. And it was a case of actually a malignant melanoma known case, and it was very avidly enhancing. So it was a melanoma mets. Okay. So next case, the patient was 50-year-old and having fever and back pain. And if we see, these are hilar mass we are seeing. So are these hilar convergence signs? No, not really. We can see the hilar vessel through it. So that means it is either anterior or posterior mediastinum structure. So let's see So hilum overlay sign is seen. So that means it is either anterior and posterior, either anterior or can be posterior. So let's see on the lateral X-ray, if you see it is posterior to the hyla and there is kyphotic deformity of spine and it is anterior to it. And the patient was having fever and back pain also, very common in our country. It was actually on, before seeing the cross-sectional image, we can have the idea in our mind that what can be this. There are two posterior elements where we can see two contiguous vertebral involvement, destruction is there and loss of height and making it the kyphotic deformity. And on soft tissue window, we are seeing the bony destruction nicely and the some soft tissue pre and paravertebral collection or phlegmon. All those things we can confirm. Like on MRI, we can see the patient having weakness, paraparesis, then we can go for MRI and see if there is an anterior epidural extension. All those soft tissue resolution will be very good and cord compression, all those things we can see on MRI. So MRI has its role in such cases to characterize and even if it is a collection, abscess, phlegmon, all those things also nicely in post-contrast MRI we can see that. And the extension into the spinal canal also we can see on MRI. So here, this the next case. The patient was having a history of chest pain and the sign we saw already, it was a cervicothoracic sign. It's positive or negative, it's little confusing where we use positive, where it is used negative. So it was actually based on that sign, the concept, if we are able to see the posterior, the superior margin of the lesion quite well, so it's extending beyond clavicle, above clavicle, so it's a posterior mediastinal lesion. So, and we can see the aortic arch shadow, so it's not a middle mediastinum lesion, right? And it's extending, so that's why it is a posterior superior mediastinal lesion. So the patient CT, the same patient CT was showing it was very homogeneous and T1 it was hypo to iso and T2 it was bright. So it was neither coming from the esophagus or nor vascular or neither from a vertebral body, but it was having some foraminal extension, so it was came out to be schwannoma. So applying the cervicothoracic sign again in this case where we are not able to see the upper margin of the lesion, that means it is anterior or middle mediastinum and there is some tracheal deviation towards right side. So it is the forte, one of the forte, this is your thyroid, the retrosternal thyroid goiter, which is extending to the thoracic cavity. So this is the cervicothoracic sign, and this is your cervicothoracic sign negative, this is your positive. Cervicothoracic positive means the cervical extent and the thoracic extent of the lesions are merging with each other. The basis is that clavicle means anterior mediastinum is ending at the level of clavicle, but posteriorly the mediastinum is extending above the clavicle. So the lung interface makes us to see to see the superior margin of the lesion. And based on the same principle, we are seeing the thoracoabdominal sign. Coming to the role of ultrasound, limited role. Such cases where we commonly see in our practice some cardiophrenic angle mass, some very commonly we see in an obese patient where there can be pericardial fat pad very prominent, but in this case it was a cystic lesion and on ultrasound it was confirmed to be cystic. But it was a Morgagni hernia, the common location right retrosternal, and if there is fat or bowel coming, that also maybe we can correlate with ultrasound and see, but usually ultrasound is not done. This is a case where it was a bronchogenic cyst. It was looking like soft tissue density, but it was not enhancing on contrast. But ultrasound, if we get a window to see this, then we can see the debris quite well, and it makes it confirm that it's a cystic lesion, not a solid lesion. Roll-up MRI, the same confusion where we have the confusion of it's a cystic or solid. If you don't do contrast, if you don't look at your non-contrast before seeing your contrast HU value, then you will be in trouble. So, but in such cases, MRI, if you see, if it is, the cyst is containing clear serous fluid or hemorrhagic or protein, where they can be T1 bright and the T1, T2 signal intensity can vary based on the protein concentration of the lesion. And microscopic fat, if it is like suppose thymic hyperplasia, where the chemical shift imaging helpful to differentiate between thymic hyperplasia from a thymic lesion like thymoma or thymic CA. Macroscopic fat will have the suppression on fat suppressed signal suppression. Cine imaging, how does it help? Cine imaging, if we can see the mobile structure quite well, so if patient is having some phrenic nerve involvement, let's see. So in this case, what we can do, what modalities we have? We can see on fluoro, the diaphragmatic movement, the paradoxical movement. We can see on ultrasound, but at the same time, MRI also can see the paradoxical movement or the absent movement of the involved phrenic nerve. So diaphragm movement will be reduced or paradoxical on that side. And the soft tissue and contrast tissue is quite good in MRI, so that's why the neural and spinal structures involvement are very nicely seen. And coming to the diffusion and the dynamic contrast imaging, the diffusion, how it helps, those are few examples which I talked about, the cystic lesion, nicely it is seen, and the chemical shift imaging where the signal suppression is there. Thymic hyperplasia, if after 20 years you are seeing the thymus more than 1.3 centimeter. It can happen in condition like acromegaly, additions, thyroid cancer, but some cases like Graves' disease, Sjogren, or some autoimmune disease, myasthenia gravis, they can have lymphoid hyperplasia, not true thymic hyperplasia. What is rebound thymic hyperplasia? At the time of stress, like some cases of major surgery, burns, steroid, chemotherapy. So in such cases, patient thymus will shrink, and when the patient recovers, it will rebound and it will grow to even more than its potential. It will grow even more than the pre-shrinking stage. So all those on chemical shift imaging, we can confirm it's a thymic, not a thymic mass, it's a actually thymic hyperplasia, nothing to be worried about. And the dynamic contrast enhancement, the time taken to reach the peak enhancement. The thymomas will usually have that short time to peak, but the thymic CA, lymphoma will have the longer time. So based on that, the Masoka staging, the lower risk thymoma, high risk thymoma, non-thymoma like germ cell tumor, lymphoma, all those we can differentiate based on that. And the same thymoma risk, it's a low risk thymoma, and if it is a high risk thymoma or thymic CA, based on the ADC value, the diffusion characteristics. So the strong restriction like the low ADC value will incline towards a thymic CA, but with high ADC value, less cellularity, it will be more of a thymoma. Role of PET CT. So usually what we have read is that more than 3.5 SUV considered to be malignant, less than that is benign. But there are some pitfalls like cases of thymic hyperplasia, fibrosing mediastinitis, TB, some inflammatory lymph nodes also can have the high FDG value. And the thymoma thing, that Masoka staging and lymphoma, what we follow is Lugano and Duvalli 5-point scale. Those are PET CT based nuclear medicine people use, but for your MCQ, you can maybe remember some names. Okay. And those are the staging system, but it's not in our, actually Masoka staging is your histopath based staging, but the same thing can be applied to look for the invasion of the structure, and based on that, we stage the lesion. So this is the summary of the mediastinal mass. So based on the lesion characterization, like the composition of the tissue, we can narrow down our differential. And coming to the conclusion, so what we have gone through is that conventional classification system on chest X-ray, the Falcon system. Then the ITMIG group classification, they divided the based on MDCT, they have divided into prevascular, visceral, and posterior paravertebral compartment. And using the epicenter rule, displacement of the adjacent structure, we can localize the lesion, and based on the composition, the lesion characteristics, the post-contrast property, and sometimes even MRI can helpful to characterize the lesion. And we can choose the avid area, the viable area for biopsy planning, and avoid critical structure like mediastinal vessels. And further PET CT in staging and PET restaging of lymphoma and all can be very helpful. And that Duvalli score 5-point scale we saw. And the characterization, whether it is cystic, fat, or solid enhancing, based on that, we can narrow down the differential. And few things we shouldn't forget, like the patient history, the age group. If it's a young patient, the common differential will be a germ cell tumor, the big symptoms associated with lymphoma. We should look beyond our lungs, mediastinum. So lymphoma can have abdominal lymphadenopathy as well. In the visualized neck, we can see some supraclavicular or cervical lymphadenopathy. Patient coming with myasthenia gravis, lobulated anteromediastinal mass, can be a thymoma. So all those things, the history, the associated findings, the pleural deposit will favor in thymic CA will have this kind of dissemination in the pleura, metastasis. So the tumor marker will come into play in anteromediastinal germ cell tumors like non-teratomatous, like seminoma will have your LDH value increased, and yolk sac tumor will have alpha-fetoprotein, and beta HCG can have increased in your choriocarcinoma. So those we can, if we have, because mostly the mediastinal mass which come to the hospital, they at least have an X-ray. So if you don't have an X-ray, if you have the CT only with you, you can see at the scanogram, or you can try to see the X-ray and try to localize the lesion, which compartment it is. And with extra information like the tumor marker, if they have done already. And beyond our mediastinum and thorax, if we look at the clinical picture, the associated finding, maybe we will be able to differentiate and narrow down our differential. So thank you. And this is a picture from 2011 Cricket World Cup win where Yuvraj Singh celebrated, and you know that after just few months he was diagnosed with mediastinal seminoma. And after 1 year of treatment in US, he came back to professional cricket. So it's very inspiring. Thank you. Thank you all.
Thank you, sir, for that very informative lecture with all the minuscule details. Next, I would like to request Dr. Niranjan Sahu to please come and felicitate the speaker. Our next speaker is our inspiration here at the department. We are pleased to welcome Dr. Debabrata Sahani, who is our associate professor at IMS and Some Hospital. He is our constant source of academic updates, and so aptly, he will be delivering a lecture on lung cancer staging, along with the advantages of dual energy and photon counting CT in thoracic oncology.
Good evening, everyone. Respected faculties, seniors, and dear residents, I am thankful to Dr. Satya Mahapatra sir for giving me this opportunity. My topic is lung cancer staging, advantages of dual energy and photon counting CT in thoracic oncology. Somewhat new topic, but we'll try to understand it simply. And why this topic today? Radiologists are at the crossroads of therapy. Many clinicians come to us for better predictiveness of a lesion as lung cancer, its extent, for deriving their best modality of treatment. So we should help them with our precise reporting. Even after reporting, many clinicians come to discuss about something extra, extent of the lesion. So residents should keep in mind the TNM staging, about the extent of the tumor, nodal staging, and any metastasis either intrathoracic or extrathoracic, so that they can get everything from our report. So staging is categorization of the extent of the disease, and purpose is shorthand to communicate the disease extent, guiding the treatment and prognosis assessment. This is extensive TNM staging is the 9th edition, which is implemented in January 2025. The only change is N2 and M1C. What is the change? N2, it was previously discussed in 8th edition as ipsilateral mediastinal or subcarinal lymph node, either single or multiple. It subdivided into N2A and N2B. N2A is single station involved, N2B is multiple stations involved. And what is M1C? M1C previously described as multiple extrathoracic metastasis to any organ, but subdivided into C1 and C2 as multiple extrathoracic mets into single organ, or M1C2 is into multiple organs. So first we should know, for T staging we should measure the lesion accurately. How to measure? We should reformat the image into axial, sagittal and coronal plane, and the longest axis whichever is, we should measure the length for staging. And for subsolid lesion, we should measure the solid component. So T staging, it tells about size, location and extent of the tumor. T1 further divided into T1A, T1B, T1C, then T2 further divided into T2A, T2B. And according to size from 1 to 5, it is like that, less than 1, less than 2, less than equal to 3, 4 and 5. And T3 is less than equal to 7, T4 is more than 7. T1 lesions are generally peripheral. In the peripheral, peribronchial lesions surrounded by lung tissue and visceral pleura. We can see here, a nodule is there in the left lung anterior segment of upper lobe and surrounded by lung parenchyma. What is about pure ground glass and subsolid lesions? Pure ground glass, if it is less than 0.5 centimeter, it is not classified under TNM. If it is 0.6 to 3 centimeter, then tumor in situ. And if it is more than 3 centimeter, then T1A is given. And for subsolid lesions, we should measure the solid component, and the TNM classification follows as it is. But if it is less than 0.5 centimeter, we call it as minimally invasive carcinoma that grows in the lipidic form, that is along the wall of the bronchus, not involving into the lumen, not obstructing it. So these are the T2 lesions. They can involve the visceral pleura or main bronchus, and it can cause atelectasis or obstructive pneumonitis of the corresponding segment, lobe or whole lung. And T2B is only the size criteria, more than 4 centimeter. This is a case of adenocarcinoma of lung involving left main bronchus with left lower lobe complete atelectasis. Another lesion, many small nodules we are seeing in the department, like transvisceral extension. So fissure is made up of visceral pleura. If there is any suspicious lobularity or invasion into adjacent lobe, then it is T2 lesion. Then what is T3 lesion? T3 means it can involve parietal pleura or thoracic chest wall or thoracic nerve roots. And it can also involve parietal pericardium involving azygous vein, phrenic nerve or satellite nodule in the same lobe. Here we can see more than 5 centimeter lesion in left lower lobe, and it is involving the parietal pleura and adjacent chest wall, aborting the ribs. Here one lesion is there in left parahilar region, aborting the pericardium, and we can see there is elevation of left hemidiaphragm, means phrenic nerve is involved, so left diaphragmatic palsy. So this is T3 lesions. T4 lesion, it is more extensive. It can involve the mediastinal fat, great vessels, heart, and recurrent laryngeal nerve. And also, it will go up to involving carina or trachea. Here you can see a lesion in the anterior as well as involving mediastinum from right upper lobe lung, encasing the ascending aorta, and another, and also involving right hilum, encasing right pulmonary artery. And here another lesion, it is involving to left pulmonary artery and involving left pulmonary vein. All the cardiac structures like mediastinal structures, mediastinal fat are involved in this case, so T4 lesion. Then come to N staging. N0 is no lymph node, N1 is ipsilateral peribronchial or hilar lymph nodes, and N2 is, as we discussed, ipsilateral mediastinal or subcarinal lymph nodes and subdivided. And what is N3? N3 is contralateral mediastinal lymph node or hilar lymph node. If there is supraclavicular or scalene lymph node, either ipsilateral or contralateral, they are also classified as N3. This is the basic stations of the mediastinal lymph node. One is low cervical and sternal nodes. 2 and 4 are paratracheal, upper and lower respectively according to the aortic interface. The upper margin is considered to classify 2 and 4. Then 3 is prevascular, 5 is subaortic, 6 is paraortic, 7 is subcarinal, 8 paraesophageal, 9 along pulmonary ligament, 10 is hilar, and 11 is more peripheral, that is peribronchovascular. So this is a case of right lung lesion with peribronchial nodularity, that is peribronchial lymph node, that is N1. N2A, single lymph node in the subcarinal region, that is N2A. If multiple lymph nodes in ipsilateral mediastinum, then N2B. Here mass is in the right paratracheal region, paramediastinal region with multiple lymph nodes. If the lymph node is contralateral mediastinum in the it is N3, and if it is in supraclavicular, then ipsilateral or contralateral, then N3. Then M1A lesions. It is intrathoracic metastasis, either to contralateral lung or pleural nodule or pericardial nodule with malignant pleural or pericardial effusion. Here we can see lesion is on the right lower lobe with contralateral lung nodule. So it is M1A. If it is different lobe but same lung, it is T4, and if it is same lobe, then it is T3. Here you can see infiltrative right lung lesion with pericardial and pleural nodule with pleural effusion. It is also intrathoracic met, so M1A1. What is M1B? Then single extrathoracic mets into single organ. We can see a lung lesion in a case of adenocarcinoma, liver lesion in the case of lung adenocarcinoma. If multiple mets to single organ, then it is M1C1, and multiple mets into multiple organs. Like here you can see non-regional axillaris and pectoralis lymph nodes with left adrenal lymph nodes. Right was also there, not shown. So it is M1C2. So prefix can be used like CTNM, PTNM, or YTNM according to the stage of management. In pre-treatment stage, it is C. After resection, it is C. After resection, it is P. And when treatment is given, then Y. And suffix can also be used accordingly the evaluation categorization, like E1 for physical examination was done, E2 if imaging information is available, E3A if cytology is available, E3B is if histology, and E4 is post-resection. This is the overall staging which helps the clinician in deciding the management. Then comes to the dual energy. So some basics like how dual energy regulates. Like it uses two energy spectra to acquire the images. One is high dose, another is low. Low is around 70 to 80 kilo electron volt kVp, and higher is 100 to 120, up to 140 can be taken. So how it works, like it can be dual source or dual detector. Here one source, one X-ray tube here, one is here, and with two detectors. It is ultra fast kV switching between in the single source. Here two rotations are being made with different kVp to acquire the image. Here filter is used to separate the spectrum like energies into two different data set. And here dual detector system, and this is photon counting. So after taking high energy and low energy photon energy, we'll reconstruct into image like low energy image and high energy image. Low energy will help in getting better contrast resolution in the form of blood vessels or any lesion, and high energy will help in reducing the beam artifact and metallic artifacts. Then we'll reconstruct a blended image that is equivalent to 120 kVp normal image for diagnosis purpose, and iodine map for quantification, and virtual non-contrast image can be taken from single acquire image with reduced radiation dose. What is spectral toolkit in case of DECT? One is virtual monoenergetic image. Generally, we can get either 40 kilo electron volt image or 70 kilo electron volt image without with maximum iodine conspicuity, that as iodine atomic number is around 50. So around that kilo electron volt we can get better conspicuity of the lesion. At, as we discussed, at high kilo electron volt, there is benefits of reducing beam hardening effect and metallic effects. We also discussed virtual non-contrast image after subtracting the iodine from post-contrast scan. Then iodine concentration maps can be used to quantify the iodine distribution in a lesion. Then other uses like automatic bone removal and pulmonary blood volume in case of some incidental finding in thoracic oncology. The advantages we saw, and if there is indeterminate nodule, how DCT can help. In a 3-minute delayed scan, in some literature it has shown that if the HU is more than 20, then it is more chance to be malignant lesion. And it can also predict the invasiveness. When iodine map, we will see there will be heterogeneity in case of malignant and homogeneity in the benign lesion. And caution should be taken because some hypervascular inflammatory lesions can show high iodine uptake. So clinical context remain the key factor. Another software is called 3D iodine related attenuation. It generally known as iodine volume. So we will put the ROI, it will show the volume of or concentration of iodine. So it helps in grading the tumor. Like high grade tumors are generally heterogeneous and there will be low iodine volume and more chance of invasiveness. We can see in right pulmonary speculated SPN. So we'll, in MDCT we'll see the enhancement, even sometimes it is not that much, we can appreciate whether it is benign or malignant. But iodine map can show the proper uptake of iodine. So it is a malignant nodule. Another case also, SPN in right middle lobe showing iodine uptake, and also in PET CT it was taking FDG. Bone removal can be done in mediastinal window as well as in VR images for better angiographic purposes, like tumor invasion and also any other findings. So DCT also helps in differentiating any metastatic pleural nodule or from benign lesions. Like here we can see very small nodule in left anterior pleural lesion, but it was showing iodine uptake. But another nodule in right pleural lining, very small lesion, and it was hyperdense in virtual non-contrast, showing no uptake. So it was a case of pleurodosis, so benign, and this is malignant. DCT also helps in evaluating any recurrence or residual after radiation therapy. So this is a case of right lung lesion, showing subtle hyperdense lesion in CCT, but iodine map shows no uptake. So there is no residual or recurrence. Sometimes when we put the HU, it is difficult to appreciate the enhancement, but iodine map helps in that cases. So here another case of post-radiation lung carcinoma and showing iodine uptake and FDG uptake. So there is recurrence. Here another case of right lung lesion with incidental left pulmonary artery embolism, and it is showing in iodine map, it is showing the hypoperfusion in the left lung, in the peripheral locations. But in HRCT, there was no impact. So DCT can help us at early stage of perfusion defect. DCT also has some correlation with tumor gene expression, like iodine map. If it is higher, then it is associated with like TNF alpha in gene. Then it can also, it has also seen in some literature, like it is correlated with VEGF factor for tumor angiogenesis, along with the quantitative iodine map. Some limitations are there for DCT. It is of restricted use in morbidly obesity patient due to high noise, and also it has some inherent high noise in low kilo electron volt images, and also it requires more data to be saved. For photon counting detector, it is not properly implemented yet in many cases. A few cases only it is available in India. So how it is different from conventional detector? This is conventional detector and this is photon counting. Conventional uses photodiodes and here it uses semiconductor devices. Like we can see in conventional detector, X-ray is incident on the scintillating membrane and it will convert into light energy. So light energy, to confine that light energy not to scatter here and there, we use the septa. So it will reduce the, it also reduce the some useful X-ray radiations. But in semiconductor device, what happens? All the photon energies from X-ray, it will strike the semiconductor, will convert into some ions, and there will be potential difference between the detector, and all the incidented photon will be calculated according to their energies and segregated into different energy bins. So we can get 40 kilo electron volt image, we can get 70 kilo electron image, and 140. So these are the advantages, what I said. Like, it counts the individual photon precisely and categorize them according to their energy. And also it has intrinsic multi-energy analysis capability, so every scan contains spectral information. What is the advantage in thoracic oncology? For better detection of very small tiny nodules like sub 5 millimeter nodules, precise staging can be done because the margin is very well defined in photon counting detector with sharp margin, so invasion into adjacent structure can be fluently told. Then quantitative imaging, like accurate and robust material decomposition in giving our opinion, and also due to varied data, it helps in implementing with AI and radiomics. Here we can see conventional detector images with slightly blurred margin and air bronchogram. But here we can see the margin is very good for both the ground glass and solid lesion nodules. In conventional detector, even with 1024 matrix, the lesion is not looking better. But here, the lesion is looking better. Here, another case of ground glass lesion proven to be adenocarcinoma. We can see in the proximal row, the margin is well set compared to the distal row. Here we can see this is conventionally taken non-contrast scan showing anterior mediastinal mass, that is thymoma, and this is virtual non-contrast image that is subtracted from the iodinated contrast scan. So the HU value is not that much different. It is 63.9 and it is 63.5. So, and these three images are monoenergetic images. One is 40 kilo electron volt, one other is 70, and it is 100. So at low energy, the iodine is very much prominent. We can assess the vessels as well as the enhancement of the lesion at the same time. No need to do arterial phase, venous phase, delayed phase separately. And this is HU curve, spectral HU curve. The yellow line is the contrast enhancement of aorta, and the white line is for soft tissue, and pink line is at 70 kilo electron volt. In the y-axis, it is kilo electron volt, and x-axis it is HU value. So we can see at low kilo electron volt, the HU value is very much higher. So in it, like one scan taken at equilibrium phase at around 70 or 90 seconds, we can segregate the arterial phase images as well with lesional enhancement. So photon counting detector CT is way better than DE-CT as well as conventional CT, and these are the positive benefits. So what is take-home message? Staging is important in guiding therapy as well as assessing the prognosis of the lesion. Only change in 9th edition is N2 stage and M1C. DCT, derived iodine uptake, quantification when assist in characterization of tumor differentiation and gene expression, as we saw. And DCT also helps in post-contrast, post-treatment assessment and incidental pulmonary embolism with perfusion status. Photon counting, it has ability to detect individual X-ray photons, measure their energy, and enable more accurate tumor characterization. Photon counting CT nowadays, it is considered as green radiology with very up to 40 to 50% reduction in dose. So it promotes safe, sustainable, and patient-centric imaging practices. Also helpful in long-term surveillance, in which cases cumulative exposure is common. So thank you.
Thank you, sir, for that very crisp presentation. I now request Dr. Basanta Manjari Swain, ma'am, to please come up on stage and felicitate Dr. Debabrata. Now, we understand that we have overshot our program schedule by quite a bit today, but I can assure you that our last session will end on a high note with a lot of interaction. And for the same, I'd like to call upon Dr. T. Seetam Kumar, who has kindly made time for us today. For the film reading session has been shifted to tomorrow as Dr. Sikandar Sheikh has rescheduled his travel plans. So Dr. T. Seetam Kumar is a man of many accolades. He is a fellow of the Royal College of Radiologists and is currently working as a consultant in neuro and vascular intervention at Manipal Hospitals, Bhubaneswar. After having completed his DM in neuroradiology from NIMHANS, Bangalore. We welcome sir to dive straight into the hot seat neuro case discussions.
Good evening, everybody. So I'll say the background, who was sitting, they should come forward. It will be like not one-sided. We will discuss one by one. If not, my first question will be go to the back side only. Just an interaction, nothing we are doing. We'll discuss how we should approach neuro cases and further. Meantime, I am to the organizers who have given me the opportunity to do a neuro session. There's a quiz session, hot seat, and I'm thankful to Adya sir and Satya sir, as well as my senior faculty members here.
Hello.
So we'll quickly go through the few cases, and there are mics available. These all are cases from my alumni, like all the institutional cases from NIMHANS Bangalore, and currently I'm in Manipal, Bhubaneswar. So coming to our first case. So as we say, now we have to become a clinical radiologist. We should not be more on imaging based, and it's not like imaging diagnosis. We have to look at the patient, we have to ask the question before we are sending out the diagnosis, because that which changes the thing. And finally what happens? The clinician says, ki, oh, it's a tumor, it's an infection. See, 5-6 things are there in diagnosis of neuro. Either one is in neuroinfection, second is neuro-oncology, third is neuroinflammation, fourth or fifth, any other, like maybe leukodystrophy, congenital diseases. These are winds up all the various differential diagnosis of neuro. So coming to case 1, a 7-year-old girl presented with headache and vomiting. So I would ask first question, what do you think if somebody comes with a child with headache and vomiting? Huh? Raised ICP features. So that is the first question. Somebody told meningitis. Yeah, it can be meningitis, but there is one history omitting because there is no fever. So we might not think of meningitis. With that, we will go back first question. What's your clinical diagnosis? So somebody says raised ICP features, means what are the differential diagnosis? Tell, I told 5-6 diagnoses we have in brain. Tumor. So in the back of mind of tumor. So any specific questions we should ask? As I asked that side, any fever is there or not, we should ask. And how it is happening, how many days it is happening. So with that, we further goes to our further investigation. What should the patient goes for? A 7-year kid. What investigation you should do? Radiological, obvious. MR, if not CT. Then what other, from the other investigation point of view? Huh? Blood investigation or something. But if you have a fever, you should go for another clinical important in neurology is CSF study. Okay. So next, what is the reason of particular modality? For example, MR. Why MR in a child? Radiation is part, whenever patient comes with a problem, no, the radiation is stopped there only. What is all IRIA principle works when there is something called normal, general population. Once the patient comes for problem, then you have to give whatever radiation, because we have to go somewhere. By saying that, I'm not saying MR is like the reason behind ki MR is non-radiation. What very much important is tissue architecture, right? Whether it is a fat, whether it is a hemorrhage, whether it's a something lesion, that is better seen in MR. And any other things what MR says, like what are the specific sequences? We see routine T2, T1, flare, diffusion, SWI, then comes contrast, then for the infection what we look into, or tumor, MRS, perfusion. These are the very, even there are a lot of things, but this is the things which we do routinely. So now the case goes to audience. So first, I think we should start from that corner. Yeah. So what are the sequences? From left to right. This one. From left, which sequence? This one, which sequence? This one, which sequence? Start, huh? You people have to answer. I already made the questions. This one, T2, yeah, then layer, this one, T1. Okay, this is basic sequence. So now the second person, just side of next lady, yeah. So you see the lesion, how it is? Okay. And what about flare? Hypointense. So before going further goes into whenever we say it is isointense, hypointense, hyperintense, in brain, what is the things we look into? For example, brainstem, or what we say? Gray matter, right? So, okay. So it may be some form of little bit hyper on T1. It's okay, ISO to hyper. Next, further these are the cross-sectional. So next guy, I think, quickly we should go for. You tell. Already we told that this is T2 hypointense. This is the coronal, sagittal and axial. And what is there in that side corner? Just summarize what we are seeing.
This is a lobulated mass lesion, causing mass effect in form of compression of fourth ventricle and some perilesional edema.
Okay, just say the one term now. What you are saying? Obstructing, causing? Hydrocephalus. Obstructive hydrocephalus. Some lesion in the fourth posterior fossa in the right cerebellum causing obstructive hydrocephalus. Next guy. So, what are the sequences? No doubt
diffusion restrictions.
Yeah, this is diffusion. This is trace image. We didn't have ADC. It's my wrong. But what about this sequence? This side.
Diffusion, sir.
This is diffusion. diffusion, you should not see any bone, right? What are there in the bones when you are saying black bones? The other next person? SWA sequence. Okay. So what you are seeing in the SWA? Is there any? What we see in SWA?
Blooming art.
Blooming to look for what is the thing?
Hemorrhage or calcification.
Calcification. So is there any hemorrhage and calcification? No. Grossly no. And is there any diffusion restriction?
No, sir.
No. Okay. Next person. This is what?
Contrast.
Contrast study. So what we are seeing in the contrast? Peripheral wall enhancement with irregular nodular wall enhancement. So next person. Yeah. So if you summarize one lesion, you tell. You remember the case, right? So what you will say one line?
It's a mass lesion.
Okay, that everybody knows. From the history, somebody told it's a tumor. We know. We already 6 people told about what are the findings. So if you summarize, means what you'll say? It's a T2 flare, hypo, intense lesion, lobulated margin, having no calcification or hemorrhage within it. There is no diffusion restriction within it. And on contrast study, it is showing peripheral irregular wall enhancement. Okay. Anything you further want to do? Or it's done, just sign out the report, mass lesion done. This is real world scenario. You will get this case and just you write this mass lesion or what you will do further.
Midline shift or not?
That's okay. That is a part of thing. Lesion causing hydrocephalus, whatever, okay. Any further sequence you want to do or you are sure it is a lesion, it's a tumor or what type of tumor? Okay, next. I told what are the sequences. Anything, whenever something you are saying tumor, what you do for the sequence? I told, no? 3 sequences I told, after routine sequence. MRS. You will do or you will not do? If you do, where you will do? Somewhere voxel, if you do, single voxel, multi-voxel. The voxel where you want to see, whether in the wall or, sorry, whether in the wall or within the content. Huh? Huh? Somebody is telling. If you think something, then in that, if you think abscess, is it abscess? Why? Huh? No. There is one sequence which says abscess is there or not. Diffusion. Diffusion is, nothing is there, no. So if it is an abscess, you could have done in the content or wall? Content. That also difference. Whether it's a pyogenic, whether it's a fungal. Okay. Leave it out. Okay, we did MRS. What it is showing? You give the mic to him. Yeah. Switch to CT switch. Okay. Lipid lactate peak or lactate peak. Okay. Lactate peak or lipid peak? It's a lipid actually, not lactate. Okay. So what do you think? Does it goes with tumor? You all people told tumor. अरे कोई तो भूल भी बताओ. हाँ? Yeah. Why tuberculoma? Why the tuberculoma comes to your mind? T2? Hypointense and lactate peak. Okay. Again lactate, lipid peak. Lactate. So we told it is a tuberculoma. Okay. So why it's not tumor? Because there is no choline peak, nothing is there. So it's a tuberculoma. Another thing which striking for tuberculoma is it's homogeneously T2 hypointense. Tumor will never be such homogeneity. It will be very heterogeneous. Okay. So this is a case of giant tuberculoma. It's not a tumor. So companion case, you see, for example, I'm not going detail, but tuberculoma, there are various stages. non-caseating, caseating, abscess and all. What do you think, it's a caseating or non-caseating? Huh? Caseating. Hypo. Are you sure? Caseations means what? It will liquefy, right? So it will be bright. It's a early stage, non-caseating. So these are the few cases. These are known tuberculomas, giant tuberculomas, and if you can say the similar looking lesion in the right cerebellum. But when you see, this is the normal pot spine. Okay. So in my primary case, there is nothing like that. That's a solitary lesion in the brain. So it's a tuberculoma. Coming to the second case. So 37-year gentleman presented with headache on and off, 1 month new onset of seizure, which is respond to the anti-epileptics. Okay, the last person, yeah. Those, you two people, I think, left out. You should come out, come front. Neither next two will go there. Okay. Same question, these 4 questions I always will be there in the case. What you are thinking, what clinical diagnosis you are thinking, what you want to, like where you want to locate the lesion, and what modalities and all.
Modality will be MR.
MR, okay. 37 year.
Would be infection associated, post-infective etiology.
Yeah, it can be tumor, it can be infection, it's okay. When we are seeing seizure, where you want to locate the lesion in the brain? Cortex. Cortical, subcortical, okay. You all thinking of where you are imagining, right? So next we are going to the image. So this is the image. The next person, I think. Yeah.
T2 hyperintense.
Yeah.
Area.
This is what sequence, the first one, this side.
T2.
This is T2 towards my side.
Sir? T2 flare.
T2 flare, no, it's not
flare.
T2.
Flare.
T2 is that side. Flare is this side. Okay. You are seeing some T2 flare hyperintense signal where?
Eye frontal and
Left frontal, okay, no problem. Then where? He told no.
subcortical and white matter also involved.
No, you tell. I didn't listen what you are telling.
Subcortical.
Subcortical. You are seeing the normal cortex in between, isn't it?
Yeah.
Predominantly involving subcortical and reaching up to the corpus callosum. Okay. Next. So here also we are able to see what you are seeing. It's predominantly subcortical signal.
Yeah. It
Maybe somewhere the cortex is involved in this area, but here there are normal cortices and reaching up to the corpus callosum. Okay. So as we always go for this case, I think I am telling you diffusion was normal. There is no diffusion enhanced. I mean to say diffusion focal diffusion restriction was not there, and there is no susceptibility for example or bleeding. So this is the contrast. What you are saying in MR, any radiology is like how you can describe something, how I can describe you similarly.
patchy contrast enhancement.
Focal, nodular, patchy, contrast enhancement, how it is there? Linear, serpentine. Okay. Focal, nodular, contrast enhancement is there. Okay. So we did the MRS. Anything we found abnormal? Maybe here, somewhere here, okay. This might be a new foci, but we are not sure. There is something called trehaloge, okay. But we are not sure whether it is there or not. So this much, what do you think? There is no diffusion restriction, there is no bleed, no calcification, predominantly involving subcortical, cortical. then this type of focal nodular enhancement. Patient having seizure, headache, on and off, new onset seizure. Infective etiology. Do you feel it is a tumor at any point of time? Why not tumor? There is no expansility, there is no cortical, subcortical expansility, right? It's looking like some white signals are just sitting. So it's not tumor. Okay, that we are very sure. Then comes to infection. What type of infection you look into? Infection means bacteria, fungus, parasite, viral. So similar companion case I am showing. Okay, now you can guess. This is a similar case where there is nodular, patchy, serpentine, linear enhancement. Okay, what you are looking? There is some organ there, right? In the last corner. Which are the organ will be like this? Parasitic infection. Okay. So this is a case of sparganosis. Okay. Sparganosis. But it can be also, there are very new cases like this. We see lot of in Odisha also. There is one thing called melidiosis. Okay. These are the new emerging infections. Where you say, whenever you say melidiosis, they travel along the white matter tract. Neurotropic parasites. Okay. So this was given as a tumor somewhere. Then we went back, no, it's not tumor. And the patient get with praziquantel. There is a drug of choice, and the patient recovered. Okay. Next case. A 44-year-old lady presented with progressive increase in headache and vomiting for the new onset of seizure episodes. Next person. We already discussed headache, vomiting means what? Huh? Raised ICP features. So next, seizure also added. What do you think? Raised ICP क्या हो सकता है? Again tumor. A new onset seizure means? Where you want to look at? Again, cortical, subcortical. You have to tell. I can say, no? You have to tell. So, first we did CT. You say. You can describe, right? CT?
Yeah. Where to find round, hyperdense.
Mic above.
So it's not.
Go above.
A round to oval, well-defined hypodense lesion with peripheral calcification.
Okay.
With central focus of calcification in left frontal region.
Okay. Midline shift.
Yeah.
Yeah. So there is peripheral calcification, there is central calcification, as well as hypodense, well-defined marginated lesions. Okay. Oval-shaped lesions. This is the contrast. Maybe some form of contrast enhancement is there. Then further in MR. Next person. Yeah. What we see more on extra than CT in MR?
The T2 image, which is enhanced.
T2 well-defined, T2 hyperintense lesion, oval-shaped lesion with central and peripheral hypointense signals. What are the things which says hypointense on T2? Calcification or hemosiderin also, chronic bleeds, right? So this is what? This is what sequence?
SWI.
SWI. What is showing? Calcification and hemorrhage both will be black on. Then how you will differentiate? Phase. Okay. So I didn't have that much. This is some form of central calcification which already seen on CT, but there is blood product still there. Because CT it was small, but when you see SW it's diffuse. So there will be microhemorrhages going on with calcification. This is what sequence? Next, I think. Yeah. The first one towards me.
So T1.
Yeah. And the other two? It looks little bit different. But CSF is black. What will be? It's a 3D flare actually. 3D flare, so it's very thin, so it looks like that. So okay, flare within the lesion is hyperintense. T1
Even ISO to hypointense.
hypointense. So what you are thinking?
Cystic.
Okay, now diffusion. Is there any diffusion restriction?
No, sir.
No significant diffusion restriction. What is this?
Perfusion.
Perfusion. What type of perfusion? You told perfusion, so we'll go further. There are two things, T1 contrast, perfusion, DCE and DSC, dynamic susceptibility contrast perfusion. What it is? Actually DCE will not have, that is DSC only. Okay. T2 star perfusion imaging. What you are looking for the? Two things are seen in perfusion. What is called? CBV, CBF. Okay. Flow and velocity. So there are central some form of increased and peripheral also very mild increased perfusion. Then this is
Contrast. T1 post contrast.
What it is? Anything significant?
No significant vascular.
No significant contrast enhancement. So what you are thinking? What's your diagnosis? Already came into play. It's a tumor, right? Mic ta come over. So what is the differential diagnosis? Where you will want to put in? See, now I have opened the classification. Whether it's a glioma, whether it's a glioneuronal tumors, it's a germinal tumor, ependymal tumor, lot of things are there. There are few tumors which causes seizures. Okay, there is term called islets, something like that. Tumor causing epilepsy. Okay, in that, what are the tumor it comes? Yeah, why you think of ganglioglioma? Okay, they are very well. Okay, have you seen glioma so well defined? They never happens like that. Astrocytoma, diffuse astrocytoma, glioma, and ependymoma, they don't happen so well defined. So it's a glioneuronal tumor. Understood? So how it looks? So in this significant calcification there, no doubt calcification means ependymoma, but the pattern is different. So it's a proven case of glioneuronal tumor. So the next case, 31-year male having headache for 3 months, diminution of vision in right eye for 2 months, diminution of vision in the left eye for 1 month. I think, yeah, hi. Everything is just in front of you. Again, we told headache, 13-year, progressive means what you are looking for?
Increased ICP, sir. Increased ICP.
IC features.
Yes, sir.
Means diagnosis?
Yeah,
tumor.
Yeah.
Where you want to put into that tumor? Because vision problems are there.
Frontal
Skull base.
Yes, sir.
And anywhere other? Anything along the?
Yeah. Optic nerve pathway.
Optic nerve pathways. Okay. So we are skipping those and going to directly to the image. Okay. CT.
So that's CT shows a hyperdense, irregular, well-defined hyperdense lesion in the.
Don't describe. What do you think? It's a fat? It's a calcification or anything else?
Sir,
that calcification, what you told, hyperdense, what it is? Is it looking something hyperdense or it's similar to the bone?
Similar to the bone, sir.
So you can directly say chunky calcifications and significant calcified lesions noted in the frontal lobe, mid-frontal.
Mid-frontal.
So what you think, is there any differential diagnosis you people are inside? calcified tumors in the brain.
Oligodendroglioma.
Yeah. Next. Huh? Capnon. Capnon usually small. They can't be so large. Next. Huh? Plenty will never happen like this. Plenty will be like subcortical, cortical, some clusters like that. Huh? MBNT. But this type of chunky calcium never happen. They will like spotty calcium. Huh? Meningioma. Okay, meningioma I can't rule out. Okay, fine. Meningioma. Next. Oh, that is already told. Everybody said. Okay, we'll go to the next further. So, what you are seeing in MR? Anything more than CT finding? We know calcified lesion, frontal, lobulated. Anything you are seeing separate from that? What is this?
Heterogeneous.
What is this? Huh?
Vasogenic.
Yeah. Peritumoral cysts are there.
Yes, sir.
Okay. So that is that happen in meningioma?
No.
It can very rarely. Very rarely. Cystic meningioma is a different entity. Calcified meningioma is a different entity. This is like calcification is there and peritumoral cysts are there. So in T2 flare it is suppressing. Okay. And in the SWI you are seeing that is again hypointense and T1 also hypointense. So in diffusion you are able to see some form of
Diffusion restriction.
peripheral diffusion restriction. And on perfusion also some mild peripheral perfusion, increased perfusion. In contrast, it is showing
Sir, heterogeneous enhancement.
Huh? Tell.
Heterogeneous intense
See, you have to say no heterogeneous. वो तो पता है. Yeah, कुछ देखना है. Then like you have to see something called कितना enhancement है. Mild enhancement है, moderate. Mild है. Are you see T1? कैसा है था भाई? Nothing was there. See black.
Hyper.
T1. Then no doubt it is heterogeneous, but that is peripherally and thick, nodular, even avid enhancement you can say. Like it's almost looking like surrounding vessel. Okay, whenever you see the enhancement near vessel, like almost equal to vessel, we can say avid enhancement. So now the diagnosis. Huh? Yeah, it's a supratentorial ependymoma. Okay, though that is one of the common supratentorial ependymoma. Rela fusion genes are there. So there is one thing called periwinkle sign. Okay, आमर सदाबहार फूल अच्छे सदाबहार देखी तो violet color फूल था है ना तार ना हो जी periwinkle. So it's like the calcificants are like lobulated and there will be some cystic component outside. So it's a known case of supratentorial ependymoma. Next is 10-year boy headache and raised ICP symptoms. Already I have told. Next question, yeah. So what you are thinking? Tumor only. Oh. मेरे को तो सर ट्यूमर ही देंगे. ठीक है. चलो. Okay. Now you can describe. See, I have not written simple cases. Little bit tricky to look for further differential diagnosis. So it's a child, right? Okay, you told tumor, now you describe. Sorry, I didn't have further imaging, but are you able to look into where is the lesion? See, there is nothing called choroid plexus. You can say like where you are, where currently you are, hall. If I can say somebody, you are in the hall, they can't recognize. No, they have to say some convention center, right? Similarly. Where is it? Ventricle. It is intraventricular lesion. No doubt, we don't know whether it's a choroid plexus origin. We don't know. This is a single. And what it is causing? Yeah, lateral ventricle hydrocephalus, obstructive hydrocephalus. So this is T2. Next. So we are already aware of it is an intraventricular lesion. This is how it looks in T2.
Heterogeneously hypointense.
Yeah, hypointense. And anything extra from CT you are able to see in this T2 sequence, where it is involving tentorium. There is some tentorial component there. There is something intraventricular component there. Next person. It is T2 hypointense. Further. Now on diffusion, is there any diffusion restriction? You tell. You have to tell no. No diffusion restriction.
No diffusion.
Yeah. You have to by head because long case, how you will describe? Okay. So T. You have to say. You say.
No diffusion restriction.
And the last sequence is? What type of sequence? T2 flare, T1 diffusion, HWI. Next. T1 sequence, right? So is the what you are looking into T1? Any T1 hyperintensity within the lesion? Are you able to see?
Yes, T1 hyperintense.
ISO to hyperintense. Sorry, it's a gray matter hyperintense. But is it bleed or hemorrhage or calcification? Are you feeling like that? No, it's not like that much hyperintensity is not there. Okay. Now this is which type of sequence?
Third one is DTI.
That is?
DTI.
DTI. Okay. Why we did DTI?
To check for white matter.
Yeah. Mass effect and all. How is? Okay. These two? These two. Huh? Tell.
SWI.
Susceptibility weighted imaging. What you are looking in?
To check for any calcification or hemorrhage.
Is that there? Nothing much we are able to see, but even you can assure because CT done no calcification, so there is no calcification. We are looking into microhemorrhages, but that's not there. This is 3D flare. This is next person. We completed. Then I think these two last guys come forward. What is the sequence? देखो टोटल MRI रे आई थिंक ओडिया इज एवरीबॉडी हिंदी ओके सो इट्स लाइक टोटल MRI में दो चीज़ें हैं जो कलरफुल है एक है DTI एक और परफ्यूजन हाँ परफ्यूजन कितना टाइप का है देयर आर 2 हाँ 3 एक्चुअली बट इफ यू लुक इनटू कॉन्ट्रास्ट बेस्ड नॉन कॉन्ट्रास्ट बेस्ड ओके कॉन्ट्रास्ट वी डिस्कस्ड DCE DSC नॉन कॉन्ट्रास्ट ASL, full form. So, what type of perfusion this is? अब एक तो दिखा दिया जो बचा है ASL. So, this is ASL actually. Okay. So, arterial spin labeling. Are you seeing anything? Which year? First year, second year, third year? Second year. Okay, no doubt, no problem. There is ample amount of time to read. So there is mild increase in, if you compare how the gray matter in the superior, that is not like that, but some form of perfusion is there. Okay. Now contrast. So if you summarize, the lesions are intraventricular, there is tentorial component, there is no diffusion, significant diffusion restriction, and no mild perfusion, raised perfusion, no calcification, no hemorrhage. And what type of enhancement I told? Whenever enhancement you say whether it's homogeneous, it's a heterogeneous. So what is this? Homogeneous, nearly homogeneous. Next. Mild, moderate, avid. What is this? Avid contrast enhancement, right? There are very less tumor which avidly enhances, and there are a lot of other things which enhance very avidly. What are the avidly enhancing tumor? Can you say? When you say in tumor avidly enhancement, क्या देखते हो? Meningioma. Meningioma में differentiate के लिए diffusion में meningioma होता है क्या? Diffusion नहीं होता है mostly. Calcification solved. If it is significantly diffusion and avidly enhancing. Lymphoma, okay. When lymphoma, meningioma are the very avidly enhancing. Next is hemangiopericytoma, some part of hemangioblastoma. They are very avidly enhancing. So this is not tumor. Are you sure, or still we have a doubt? That is my question. I think we will go for survey. How many you are thinking it's a tumor? हाथ खड़े करो जल्दी. If it is tumor, what type of tumor? Maybe it's some 10 odds. We just described, no? Avidly. Huh? But does choroid plexus tumors are T2 hypointense? Choroid plexus are T2 hyperintense because it's highly vascular, bloods and all. There will be flow voids, but it cannot be homogeneously T2 hypointense. You just told now what is avidly enhancing, which type of tumor? Meningioma, right? Intraventricular meningioma is the first differential. Next, what is not favor of meningioma, which is something else? This is so homogeneously T2 hypointense. Meningioma T2 hypointense usually will have calcifications, okay? And this is multi-compartmental. I mean to say tentorial, intraventricular, these all are there. It's a very rare diagnosis actually. This is called, there is something called lymphohistiocytotic disorders, Langerhans cell, non-Langerhans cell, lymphohistiocytotic disorder. Anybody know some disorder name? Erdheim-Chester. Another one? Rosai-Dorfman. So this is Rosai-Dorfman. Okay. So this Rosai-Dorfman will have multiple cerebral, like tentorial. So these are the various form of presentation. Tentorial in ophthalmic extension, extra ophthalmic extension, infratemporal extension. It can be similarly like meningioma. It can be intraventricular. It can be like tumor-like. It can be lymphoma-like. Anything. These all are Rosai-Dorfman. So I think why I should give in this case, you should broaden your mind when you are saying differential diagnosis. So last case we'll go for. So this is 37-year gentleman complains of progressive headache, giddiness, further weakness in the right arm. Progressive headache, giddiness. What you are looking in, where you want to put the lesion, and weakness on the right arm. Because after MBBS, we just put into ultrasound and we start doing. We never think like patient as a clinician. There is something, brain mein kya hai, separate, something called supratentorial, something infratentorial. How infratentorial lesions usually present? Raised ICP features, next. Ataxia, imbalance, giddiness. These all are the posterior fossa. Okay. I am not sure, we'll go for. This is the lesion. Just now, what is your differential? Tumor. खड़े करो. Who those who are thinking tumor? Just quick, we'll round up. अरे हाथ तो खड़ा करो जिसको भी ट्यूमर लग रहा है. 6 लोग. तो और सबको क्या लग रहा है? Huh? Sir told something called effective demyelination. Is it like that? How many are betting upon sir? It's a tumor effective demyelination. हाथ खड़े करो. Again 10 लोग ही हैं. Rest people are not. क्या है ये? So see, we see the lesion how it looks in tumor. I have not shown you the glioma. Actually, I didn't have here. Glioma will have cortex and medulla differentiation lost, expansile, significant. But something what is very, you should remember for lifelong. You see how the T2 is involving, the lesion is involving subcortical, and there is something T2 hypointense, vessels are still there. And if you see, the signals are variable. Like when you say endometrioma, pelvic mein, shedding, something called different type of T2. Similarly, in T2 in brain, there will be variable changes of T2. This is a little bit hypo, मतलब थोड़ा कम hyperintense, इधर थोड़ा ज़्यादा hyperintense. But when you see here, it is clear, fluid-like. Okay. And how I work it is like that. When you see T2, when you look into flare, what is happening in the flare? Flare? Suppression. Means something fluid, crystal clear fluid, which never happens in tumor. Very rarely. Unless solid cystic, well-defined, like glioneuronal tumor. That never happens, glioma. Because like C, we always think of glioma. Like midline glioma, lobar glioma, or diffuse astrocytoma and all. And T1 is another point. The reversibility that we tell is rarefaction. Okay, when the term is rarefaction, when you see T2 such hyperintense, flare reversal, and T1 will be black. We see all the previous lesions, that is T1 iso hypo like that. But do you see like how black it is? See the CSF and here. So this is a telltale sign of sir told the diagnosis. Why it is tumor effective? What tumor? It looks like tumor, no? Tumor effective demyelination. And another diffusion which helps us rule out tumor. What it is? अरे demyelination का क्या ही दो finding है? Peripheral diffusion restriction, जहाँ active demyelination हो रहा है. Okay. And are you able to see in these images the peripheral diffusion restriction? And maybe in this case there are some microbleeds because of some microvascular thing, and some peripheral perfusion raised perfusion, and contrast will be peripheral enhancement. And I told those T2 hypointense normal inside, these are the veins actually, which is intact. So it's a case of tumor effective demyelination. In this also, in the active region, if you do MRS, there will be more lipid, big membrane is going on, so there will be lipid lactate peak. This is another companion case. This is very beautiful. You can see like how the diffusion is so peripherally it is. But it looks like a tumor and the enhancement is peripheral, where the active demyelination is happening. We'll close or last? This last first we'll quickly close. So this is 10-year-old female, recurrent vomiting, decreased weight gain, recurrent focal seizure, which is further into secondary generalization seizure, GTCS, and there is post-ictal paresis, and the child is going, academic performance is going on. So what do you think? Something is going on for long duration. Okay. क्या हो सकता है? Whenever tumor happens, it happens in the cortical, subcortical, right? Will they go for GTCS? It can be GTCS, it can be GTCS, it can be focal, yeah, focal. But tumor will progressively goes down. But how many childs will present like this? And there is something called post-ictal paresis. Is it anything you are looking into? So whenever in a child chronic things happening, no, we always think of some chronic disease rather than of a tumor, some form of leukodystrophies, some form of mitochondrial diseases, some form of chronic inflammation. So this should be the differential diagnosis. So we went for MR. I think quickly anybody want to volunteer? So this is T2. So what you are seeing, T2 flare, diffusion restriction. Diffusion restriction. Nobody is saying, I am saying diffusion restriction, everybody is silent. T2 and flare, hyperintense signal, right? What we told, seizure means cortical, subcortical, right? What is happening here? It is predominantly involving cortex, right? But does the subcortical is normal or involved? Some part involved, some part not involved. But anything more is involved? Huh? Thalamus. So whenever we are saying T2 flare hyperintense, we further go for diffusion. Always to look for two diagnosis, primary diagnosis, flare, T2 hyperintense, diffusion restriction means अरे एक ही डायग्नोसिस है. हाँ, in fact, stroke, ischemic stroke, right? So does it fit into ischemic stroke? Yeah. Tell me. Does it goes to any what? Whenever we say ischemic stroke means it should follow vascular territory. Does it goes to any vascular territory? थैलेमस इन्वॉल्व है, टेम्पोरल इन्वॉल्व है, पैरेटल है, हो सकता है क्या? नहीं हो सकता है, नो. दिस इज एमसीए टेरिटरी इन्वॉल्व, देयर इज ऑल्सो थैलेमस इन्वॉल्व, विच इज विच टेरिटरी? पीसीए टेरिटरी. सो when you looking into this, next time when you see any stroke in SWA only, it says lot of things. What I am saying, see, this part is the left part, I think. Here, if you say flare, normally there will be veins. Here what is happening? पूरा एकदम white out है ना, थोड़ा सा different नहीं है other part of area से. But whenever territorial infarcts will happen, the veins will be there, that will be black, and the deoxygenated bloods will be there. That says it's an acute arterial territory infarct. So if it is like that, what is the problem is happening? It is non-territorial, but it is infarct or not? It's infarct. Then what is happening? It's happening in the metabolic cellular level. Okay, so it's an ATP problem. So what we are seeing in the areas, actually it is lipid lactate pair. No doubt it can happen in normal stroke also. But whenever we say stroke, what I say? T2 flare diffusion. Next sequence is TOF. TOF is what? Anything is you are seeing? Any abnormality? Nothing. So when TOF becomes normal and you are seeing stroke, you have to think of metabolic causes. Okay. So this is another thing we do normally. I don't know how many centers in Bhubaneswar is doing. Whenever we look into stroke, we do T2, flare, diffusion, TOF, next perfusion. Okay. Perfusion best is ASL. We don't want to give contrast. So this is ASL. What you have seen in ASL? बताओ कुछ तो, रेड रेड है ज़्यादा, मतलब क्या है? हाइपर परफ्यूजन. दैट नेवर हैपेंस इन एक्यूट स्ट्रोक. दैट विल बी एकदम ब्लैक. व्हाई इट इज हाइपर परफ्यूजन इन दिस केस? एंड दिस इज व्हाट द लास्ट वन. दिस इज फ्लेयर, दिस इज ASL, दिस इज T1 vessel wall enhancement, contrast study, T1 space maybe, spin echo sequences. This to look for any form of vessel wall abnormality, but we are not able to see. ASL is happening because there is some form of increased vascularity, but what I will say, when blood comes, SWA, artery and venous signal will be different. Deoxygenated blood, oxygenated blood. In MELAS, what happening? The oxygenated high bloods are coming, but tissue is not able to use it. That's why side what you are saying pura white tha, that is because of oxygenated bloods. And there is increase because that is metabolic, it is increasing. Because of that, CBF and ASLC only CBF, cerebral blood flow. That's why it will increase. So it's a case of MELAS. What is MELAS? You have to say. नहीं तो एग्जाम में यही क्वेश्चन आएगा. Encephalopathy symptoms. And what I told, there is multiple different progressive strokes are happening. And there are few peculiar childhood strokes. I just completing by saying. So this is a stroke where you want to say I am saying vessel wall and there is something in childhood that is what happening. There is focal narrowing here. Okay, and there is some focal enhancement. What is the diagnosis in childhood strokes? Focal wall enhancement. Same word use karo. Focal cerebral arteriopathy. That is very common in childhood. FCA. So, एक diagnosis always when you look into childhood strokes, always remember what I told. how you rule out MELAS, how you rule out this one, doing a vessel wall enhancement to look for FCA. Because childhood strokes are not common. कितने लोगों को दिन में बच्चे को stroke होते हुए देखा है? Very rare. So this is another patient having recurrent strokes, bilateral gangliocapsular strokes. Something answer in the CT. Mineralizing vasculopathy. So mineralizing vasculopathy is one of the common in childhood strokes. Okay, finally this case, then we'll goodbye. What do you think? Is it tumefactive demyelination? It is lesion, tumor, abscess, infarct, embolism, whatever. There is no bleed much. There are multifocal lesions. There is areas of rarefactions. What is this? What is this? अरे sequence का नाम तो बताओ. Diffusion. How you are seeing? There will be multiple thick peripheral and central projections. Okay. Central projections. Arrow है MRS का. And peripheral wall enhancement. Fungal. But it's a very rare form of fungal when it happens in the bilateral frontal. Okay, fungal it's okay. I'm not going to go into diagnosis. I think I'm very thankful to the organizers as well as IREP, IRIA and ICRI Central as well as state team to giving me the opportunity. And I think you people has to speak. सब कुछ तो मैंने ही बताया. Thank you. Sir?
Thank you, sir, for that very exciting session. I would like to call upon Dr. Niranjan Sahu to please felicitate Sitam, sir. That brings us to the end of today's session. I would like to call Dr. Adya Kankar Panda to please deliver the closing remarks. Sir is saying it's closed. So I hope everyone has had a stimulating time with all our speakers giving wonderful talks, and we'll see you again tomorrow, punctually at 9 o'clock. Thank you.